to the technique, we are easily able to achieve 5 millimeter width, extra width. So in this case, you can start with the 2 millimeter, and then we end up with a 7 millimeter. In this case, we were able to place most of our implants in the diameter of 3.5 to maximum 4 millimeter diameter implants, leaving at least 1 to 1.5 millimeter of a labial plate beside our implants. This is another case for a fully edentulous patient. The mean value of the crest was about 3.2 millimeters. I was able to do the splitting at the same sequence after the piezo splitting with the piezo saw tips, starting to introduce those special chisels, and slowly until I achieved at least 4 millimeter width. At this moment, I can place my surgical guide. In this case, it was just a simple surgical guide. It's not a complicated one. It was a simple surgical guide. So we mark and we introduce our pilot drill to just create, to know the exact place where we are going to place our implants. And at the same location that has been marked by the pilot drill, after doing the whole splitting, we are able to introduce our condensers or expanders of the system that we use, and then achieve more expansion after the splitting, and we are able to place our implants with a high, very high, almost, in most of the cases, it's more than 35 Newton centimeters with the primary stability. And as you can see now, in this case, look at the width here, I was able to achieve at least 7 to 8 millimeter width after it was 3.2 millimeter width. And I was able to place my implants in the correct positioning as was planned. Of course, this was in the maxilla, but, well, how about the mandible? It's not so easy in the mandible as it's in the maxilla, and we all know it's definitely due to the less quantity of the spongious bone, and as we all know that the mandible has a higher density bone, and it's not always easy as it's in the maxilla that I showed you in the video. So to achieve the bone splitting in the mandible, we should do the regular crestal split with the utilizing the piezo tip inserted up to minimum of 10 millimeters inside the bone, and then we have to add lateral releasing bony cuts, which does not go deeper than the cortex. So it's a very simple, it's a very shallow, let's say, osteotomies or saw cuts, so just in the cortex area. After achieving 2, now we are able to introduce again our chisels. In the cases in the mandible, we frequently use the chisels and the osteotomes to obtain the splitting, because it's usually a dense bone, and it's not as easy as in the maxilla to do it. So we need some effort sometimes to do to introduce our chisel inside the bone. At the end, we are able to place our implant at the same manner, placing our implants, packing the area, the void area between the two cortexes with any kind of graft material of choice you want. It depends on your choice. I'm not gonna go through this issue because every one of us has his own preference of using a special kind of bone substitute materials. I personally would prefer here the allograft material or autogenous. Well, at the end, it's recommended. It's not mandatory. It's recommended to cover the area with the collagen membrane, and this is the final result before placing the final prosthetic work. Of course, in cases that we are using those kind of chisels, Nobody would like to introduce a chisel in his mouth. Of course, the sound and the shocking feeling is not recommended. So a lot of companies have created a lot of techniques to achieve the expansion gradually, what we call a gradual expansion for the table. Are let's say blade-like, and some of them are screw type, which we call it in this case controllable expansion after splitting. So this is the kit I use usually, and the technique is very easy. After achieving the splitting, utilizing the piezo tip, those expanders are introduced exactly in the place where we are planning to place our implants. So after achieving the splitting, the same sequence of the case that you saw in maxilla, we use the pilot drills, and you will see now a live demonstration of that or a video for that. And we introduce gradually on a sequence our expanders in the exact of site preparation. So there's no drilling, it's just using those expanders to prepare the site of the implant to be introduced in place. So gradually and slowly we are able to expand without using the osteotomes anymore. Very rarely now we are using osteotomes to introduce and to achieve our splitting. Well, of course, at the final result, we are able to achieve our implant and place our implant in between the two splitted cortexes with a very high and predictable, very high initial stability. Everything will be covered with the membrane, and the void between the two cortex, I would believe that if it's more than 2 millimeters, it should be filled with the grafting material. It's more recommended if you also place any collagen membrane, any resolvable barrier on this case. I want to share with you, this is one of my cases. I will show you the degradable or the continuous splitting. This is the controllable. We have to, even that we did the measurements on the CBCT, we have to check. And as you can see here, those two vertical placing cortical cuts. Now placing my surgical guide, which is a simple surgical guide at that time. Now introducing my pilot drill through the splitted area just to do the markings of what I need to do the splitting. And through the holes or the drilling sequence of the pilot drills, now I'm completing the full depth of the pilot drill. Now I'm introducing again the pilot drill just to be marking to the full depth of my planned implant, and then starting to introduce or to start using the expander slowly. It's a very slow procedure. We don't have to rush. We are not in a race. We are in a marathon. Gradual sequence. Usually I place two, leave one of them, and go back counterclockwise and place the other one, as you can see. So I keep the bone spread. After each phase, or after insertion of each side of those, we have to let the bone relax. Keep those in place and let the bone relax. The viscoelasticity of the bone would allow us to start this separation easily and continuously. At the later stage, the implants are, those are the implants inserted in the area. They can go easily after splitting and after preparation. As you can see, I inserted 3 implants, and the torque is about 40 Newton centimeters. Those are the implants after insertion, and this is the final suturing, watertight suturing for our case. So it's not a race. We have to take it easily, atraumatically, as much as possible. And what we gained here is that I was able to do the augmentation, what we call an augmentation, look like augmentation, the splitting and enhancing better width of the bone and placing the implant as a one stage. And this is one of the most important advantages of the bone splitting. Of course, you will say that what happens with this gap of bone. I would say that according to literature by Sethi and Kaus, which was published in 2000, in most of the cases of the splitting, the implants can be placed immediately. And the bone grows back into created gap, and this will osteointegrate with the implant as a normal implant. Exactly the same manner that would happen in a straightforward implant case. And Coleman said in 2003 that the ridge split procedures provides a quicker method. And this is one of the main goals that we are achieving. Okay, and this is very important because the patients, they want it as a one surgical time. So at a one step, one stage, we are able to finish our case. So those are the advantages of the splitting combined with the controlled expansion or the controlled screw expansion. It's atraumatic because it's a gradual controlled expansion. There is no bone loss because we are not drilling. We are not removing any bone, just expanding. So no bone loss, no thermal injury, and this allows immediate implantation. And we can use this technique with the most commercially available implants in the market. Most of the cases, they don't require grafting, but I would recommend if the gap is more than 2 millimeters, it's better if we graft the area. It's minimally invasive and it's cost effective. And this is the advantage over the eyelid bone regeneration, that we have to use a lot of material, a lot of coats on membranes, tacks, and bone grafting materials, and then postpone the patient for another second stage surgery to place our implants. So this is a very cost-effective method when indicated. And the and this is CBCT for a case that had been splitted, and this is CBCT post-operative. As we can see that placing the implant exactly in the spongeous bone component, and the spongeous bones component is surrounding all the implant. So the healing is just like exactly putting the implant as a straightforward implant as any other cases. And even if we graft the gap, the stable graft is only because it will heal much better because it's surrounded. It's a closed envelope and surrounded by the bone. And this will eliminate the need for autogenous bone block graft, and the total recovery times is not more than 4 to 6 months to let our patient reach the final restorative work. Well, Edward Anitwa has published a lot of papers on the last one was maybe one I read. It was 2013, where he measured as a mean value how much we are able to achieve a better width or a more width while splitting. Well, he made a study on 37 implants on 20 cases, and the mean expansions was about 3.5 millimeter, and and even the occurrence of malfractures of the labial plate following the split crest technique does not reduce the gain in the bone quality. And in his study on his 20 cases, there were no cases of failed implants or even complications. Of course, as every technique in the world, any surgical technique, we have advantages and we have some drawbacks, or let's say limitations. The main limitation of using the crestal bone splitting is this is not absolutely not applicable in the one bone. When we have an extremely dense bone, that means we have much less spongeous component. This technique is absolutely contraindicated because it will definitely lead to a labial fracture or any kind of separation of separation, total separation of a cortical bone. Plus, one of the disadvantages is that there is a slight risk of bone resorption, and I will show you a case. How did I get a bone resorption? Due to the disturbance in the blood supplies of the laterally displaced buccal bone. Of course, it's also not indicated. It's not a choice. If we have a vertical bone loss combined with our horizontal bone loss. So if we have a vertical bone loss with our lateral bone loss, so we've got to find another way to augment our edge. So there are limitations for using the crestal split. If we follow the rules, if we follow the protocols with the limitations and the indications, we are able to achieve very good results. Of course, sometimes we get some intraoperative complications. Nothing goes so easy all the times. Sometimes we get like immobilization of the vestibular plate, or sometimes, in very rare cases, if we don't pay very much attention, we may get a total break off of this plate. And this may require more advanced technique to get to put back this the separated bone plate into action again and to stabilize it at the bone. And in very rare cases, temporary nerve temporomandibular injury to the bundle, which is extremely rare, and I didn't see it ever once. Even if we get what we call a malfracture, excuse me, I have to go back one slide so I can show you. Even with a malfracture case, Saguro Ishida showed with his research and published in 2014 that you can turn this separated cortical plate into a free cortical block. Of course, this will need more training, and he has to be a surgeon, very well trained with the surgical skills to do this. But in case it happens, just simply turn your broken cortical block to a free cortical block and fix it with 2 screws, and it will go very well. And according to Piccinini, said mandibular bone expansion technique in conjunction with root form implants with a case report he presented in which a split bone on the vestibular side was completely removed and then replaced and stabilized with bone screws with a very highly predictable result. Some of the late complications that I faced personally, this case, when I was going back for I just made a CBCT and was going back for the next stage surgery after 6 months, I found that I lost part of the labial plate. So this resorption is a bad prognosis for a long-term success. And this is one of the late complications that we may face after bone splitting. Well, to be on the safe side, Andrew Stryker and Jonathan Fleiner, Fabian Dottenhofer suggested that after each splitting, modify your approach and add more onlay grafting material over the labial plate. This will protect and this will prevent the resorption of our labial plate. And this protocol had been published since 2014, and you can see and we can easily add any bone substitute material and cover it with the collagen membrane to add more width to our cortical plate. And in this case, the only particulated bone graft material I would recommend to be a xenograft, so it stays, it will stay for a long time. And this is one of the advantages of the xenograft, that they last and they resorb extremely slowly. So this is the case. After doing the bone splitting, if you are in doubt and your labial plate is about 1 millimeter or less, we have to add an only granulation, particulated bone substitute and covered with a membrane. And this is called stabilizing our crestal split. And this is a CBCT of a follow-up after 2 years, and we can see how much it's stable, all the stable, and this is the final prosthetic outcome after doing the bone splitting. Well, according to them also, if we follow the stabilization technique, that means that we add some of the articulated bone to our splitted case, we are able to maintain for a long term. And according to their study, so it will be done totally in one operation, doing the splitting, placing our implants, and doing the stabilization technique. All implants placed in the bone gap created by a ridge were successfully osseointegrated, and the hard tissues as well as the soft tissues revealed very favorable and stable follow-up for 2 years. Of course, and the study was done in the University of Freiburg, at the Hospital University in Freiburg. So if we do a simple comparison between our techniques in managing narrow ridges, either we can use GBR or block graft materials, or this alternative with the limitation of indication of each of them. I want to put it in this manner. Let's say if I have a case and I have a choice of doing 3 techniques, the 3 techniques are indicated and reliable in this case, I would definitely go for the ridge split, for the ridge splitting or the crestal bone splitting, because it's a one surgical side, one surgery, no morbidity, with less trauma, and I can place my implants directly with less time, less cost, and less complication than any other alternative. Even the GBR, simple procedures of the GBR, if we are placing, if we are doing, let's say, a real major correction in the horizontal plane, so we have to use the titanium mesh in most of the cases, or at least a PTFE reinforced membrane, and in case they are exposed, we are losing everything. Plus, we cannot place our implants simultaneously. It's a 2-stage. But going for the ridge split is a 1-stage, and we can get and achieve the best of the best results if we follow the technique with the limitations of the indications, and we get more patient acceptance. Well, as a conclusion, I say it's I can consider, and all the research have considered, that the crestal bone splitting is a relatively less invasive technique with less trauma than any other techniques, and we are able to place our implant in narrow ridges with a very high success rate. Okay, and we can produce afterwards in a matter of 4 to 6 months maximum good looking and good functioning restoration with good function and good aesthetic results. Of course, ridge splitting has to be a little bit user sensitive, and an advanced training is very highly recommended in those cases. We shouldn't do any technique just by watching a YouTube video on that technique. Please, everybody, if you are not using any technique, even for expert, I never go for a technique without taking a special course for that. All the courses are highly recommended for each technique you want to add it to your practice. Of course, if you follow the British Academy, I think that after the coronavirus or the COVID-19, after the COVID-19 crisis, we will be able to organize very good advanced training courses, hopefully shortly with the British Academy of Implant and Restorative Dentistry. So please stay tuned and subscribe to BAIRD and follow. You may find one day one of those courses that I do on the advanced technique, and one of them is the bone splitting. At the end, I would like to invite you all, hopefully soon after the end of this crisis, my beautiful city, Tartus in Syria, and visit in the clinic. I share with you all the cases, spend time. I'll be glad to host you all in my lovely area. Till then, with this beautiful sunset from my area, I would like to thank you all for your kind attention, and I will ask you to stay home and stay safe. And my final thank is actually for Tamer, Hassan, and Solange, and for all the BAIRD family and the Academy of Laser Dentistry for having me here, join with you this marvelous conference, and to be part of the great lineup of speakers, which most of them are my friends, and I'm proud of them. And thank you to you all for your kind attention.
Thank you, Dr. Imad. This was amazing, very comprehensive. I have so many questions. Hopefully you hear me very well.
Yes, yes, I'm with you.
Perfect, 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 perfect. Do we know what resorption rate we might have following ridge splitting with a long-term follow-up?
With the long-term follow-up, according to my readings and from my clinical point of view, what I saw that I have more than 25 cases of splitted cases followed for 7 years. And of course, I have some complications, and most of the complications were not related to the splitting. I mean, long-term complications or long-term failures. It's not related to splits. What I discovered is most of them, they were related to the soft tissues at this area. With the thin phonotype cases, I had some problems as a follow-up after 7 years. Yes.
Perfect. So I have many questions about the usage of the Versa technique at the osseo in the
certification. Yeah.
Yes.
Yeah.
Do you combine them, or do you recommend one over the other, or what do you do?
Of course, I combine them now. Maybe I was one of the first who used the tensor BAIRD. It was a gift from my dear friend Salah Weiss, and it's a great salute for him from my place now. I've been using the tensor BAIRD now for more than 5 to 6 years. I combine them, yes. I combine them now after the splitting. You can use the tensor BAIRD as an alternative for using the condensers and the spreaders and the expanders, the hand expanders I am using. Of course, it's a very reliable technique, and the tensor BAIRDs are a very good option in achieving expansion. But the tensor BAIRDs are limited for expansion. You cannot do it as splitters. So the range of gaining extra width of bone, as to the best of my knowledge, with the osseodensification technique, you cannot achieve more than 2 to 3 millimeters extra width at the most. But with the crestal split, you can achieve up to 5 to 6 millimeters. So you can consider that the osseodensification or expanding by using the tensor BAIRDs is indicated when we have a small undercut or a little width. I'm 100% sure it works excellent, and you can achieve a good expansion with tensor BAIRDs, of course.
Perfect.
But I use them sometimes after splitting. After splitting, I use them sometimes. But as long as I have this gradual expander kit, which is a screw, okay? So I'm achieving without taking any kind of bone. So no drilling, no drills, just using the controlled expander screws.
Perfect. regarding the height width bone, which one more complicated to lose? And if we have height loss, does the augmentation will treat that? Actually, I have many questions regarding the bone grafting. Is it mandatory to place buccal bone? You always place grafts?
Yes. Actually, now since 2015, I've been placing always. I'm adding particulated bone graft material to the labial part of the splitted area. This is to maintain for the long-term stability of the buccal plate, because they found that almost 30 to 40% of the splitted labial bone may undergo some kind of resorption. So it's mandatory now to control and to prevent our labial bone from future resorption. I would recommend, yes, adding all the time now.
Okay, what is the maximum expansion we can do to the bone in millimeters? And what if fracture happened during the splitting? What you do?
As I told you that for the first part of your question, you can achieve up to 5 to 6 millimeter maximum expansion. And this is related to how much height, because you cannot get expansion width more than 2/3 of the height that you have.
Okay.
So if you have the height, let's say for 12 millimeters, you are able to achieve 5 millimeter. Of course, it makes a difference if you are in the maxilla or in the mandible, and it makes a big difference how much you have a spongeous bony component. Okay, but the maximum, and I think that if you have a 3 millimeter and you were able to achieve 4 to 5 millimeters more, so you have an 8 millimeter width, and 8 millimeter width is more than enough to place a 3.5 or a 4 millimeter diameter implant, which is more than enough. For the second part of your question, if something happens technically, or it's a complication that could happen during surgery, the break off of the labial plate, just simply turn this broken plate. If it's partially broken, just keep it attached as much as you can and fix it with 2 screws, 2 1 millimeter screws from the kit of Stoma or whatever kit. Just think of it as a free graft, free bone graft.
Okay, Dr. Imad, I'm so thankful for you. I will. This was so comprehensive, so informative. I need one favor from you. If you can go to the question and answer section, okay, and if you can answer the questions related privately.
Of course, I will.
Yes, please, because we have so many questions. Just do that for me and the rest of our colleagues. And
no doubt.
Again, I'm so thankful. Stay safe and stay home always.
Stay safe,
yes,
everybody. Thank you so much. Thank you so much for hosting me. I'm ready to answer all the questions. You can contact me privately or on this forum. I will gradually answer all those questions during this night. Thank you for hosting me. And
stay safe. Thank you so much.
Stay safe, everybody.
Thank you so much.
Thank you. Bye-bye.
So now, thank you, Dr. Imad. This was great. Now, and I have another amazing speaker. He's actually a close friend. Guglielmo, do you hear me?
Hello, my friend.
Hello.
Do
you hear me? I need you to start your video. Yes, we have your video.
Okay.
Perfect.
Video?
Yes, and I'll ask you to share your screen.
Okay, 1 second.
How is the situation now in Italy? Everyone is worried.
Yes,
hopefully you're doing great in Italy.
It's very hard. It's not easy, but maybe we start to see the light, the final of this bad situation. Yes, it's not easy. A lot of people died, as you know, and it's really sad.
Yes, but it is.
Now it's a little bit better.
hopefully you'll see the light after and you'll go out stronger. Okay.
Yes,
I leave the audience with you. I'm sure you're gonna do a great presentation talking about the differences between the digital and the analog world. I'll leave you the mic. Thank you, Guillermo.
Welcome. Okay, you can see my presentation.
Yes, perfectly. You can start.
Okay, 1 second. Okay, 1 second. So everything is okay?
Perfect. Just perfect.
Okay. Hello, everyone. Thanks to stay here with us today. And I'm very honored to be part of this excellent online congress. And I would like to thank the organizer for inviting me, Dr. Hassan, Dr. Tamerti for his support, my best friend. And my big hand today goes to the many died of this day and their families. I'm so sorry. We are so sorry for that. So, okay, my name is Guglielmo Parziale, and I'm from Italy, from Naples. And someone maybe will know Napoli for one of the biggest volcano in the world, or maybe someone for the football and of course Maradona, or for the pizza, because the pizza was born in Naples. And here in my laboratory is where I spend the most part of the day. And from more than 10 years that I focus my work on metal-free restoration, especially in aesthetic veneers, as many of you know. So this is the topic of my lecture. Analog versus digital, is it possible to compare them? It's a good question, but almost provocative and with 1,000 answers. Very often happens that I receive calls of dentists like, what do you think about intraoral scanner? What do you think is the right time to start? Which is the best scanner? Or something like that. So I understand that for many dentists, are there still too many questions about this topic? Today, we will try to see the two methods in confrontation, but especially in cohabitation, because I think the both can help each other. I'm sure of one thing. It is possible to have an excellent impression both in traditional way and in analog way. I'm sure of that. Today, I will try to know more about some of the most used material and comparing different techniques. So we start with an excellent model where we do our workshop or project. And then we do a silicon index for a guide during all the work. So we start with the refractory technique. This is the model of refractory technique with refractory die technique. And here we have the die in refractory material, and then we can check with the silicon guide of our workshop. In this phase, I'm going to try to show you the principal step of the layered. First, we make a crystallization of the die, and then we use different denting. And then we continue with the opal translucent and several effects. This is the result of the first bake. This is the second bake result. And now we are ready to start with the finished touches. I usually use these bars and this rubber disc. I like to use also the pencil to trace the transition linear and the depression areas. Here we can see it better. Okay, this is the surface, the finished texture, our surface texture. And now we can do the final glaze. If we need, we can put a little spot color. The final step is very important because the restoration are polished by hand with diamond polish paste to obtain a more natural effect. I like to do this under microscope. I think for a best result is always, we always need a microscope. Here we can see the details after final polishing. The surface is very natural. Also, I like to use a golden powder for check the surface and texture. So we can compare the different kind of texture. Compare our restoration with the patient texture. This is the final restoration results. And now we can proceed with sandblasting of the coating material with crystal microspheres. These are veneers after sandblasting. So now we'll show you the platinum foil technique. The process of layers is the same, just we don't need to duplicate the model because we can work directly on the original dies, as we can see in this slide. The platinum foil come adapted on dies directly like this photo, directly on the dies. Okay, we always check the form as usually with the silicone die and of our wax up or project. Here we are going to try to repeat the same step of the stratification. Now it's not our focus of the presentation because it's very long to explain everything. This is the result after the final bake. Also, we continue with the finished touches with the pencil to check the texture. And now we are ready to do the final glaze. First with glaze in the oven and then manually. This is our restoration. Details of restoration. These are the veneers removed from the die. Now we can start with the removal by means of pliers with very thin tips. I like to do that under microscope also to have more control and more precision to respect our finish line. Now we can see the veneers once the foil is removed. And now we can talk about CAD/CAM technique. As you can see, we did the digital planning of our cases, and nowadays we have a large variety of materials, but obviously they must be carefully selected of our different needs. Now I would like to show you a different material and compare the result that we can obtain with different technique. Those are after removing from black. Here we are going to design the kind of cutback that we need. I like to use these bars and the rubber disc for the cutback. Obviously, we try to make this step at this moment because the material is softer. This is before the crystallization, Emax. At this point, we can check the thickness with the silicone guide. And this is before the crystallization and after crystallization. So now we can paint before the layering. So basically we start to painting, trying to emulate some natural effect before the minimal layering. This is cutback technique. This is the result after bake. Some details of painting. And we proceed to do a macro layer with enamel, transparent, opalescence, and some dentin, but very thin layer of ceramic. Again, we made mechanical polish with the diamond paste as usual to achieve the more natural effect. So we can see the final result is natural, is soft, it's like a natural tooth. So this step, we'll see the Emax monolithic restoration before the crystallization. Also, we take care for about the shape in this phase, morphology, surface, and this after crystallization. Here, let's check the texture again. Control, final control with the silicone guide. And now we are ready to paint. Today is trending. A lot of dentistry ask about monolithic restoration, but it's not easy try to emulate the natural effect. It's possible to do something, but I will show you this technique also. So here we can see some detail of painting, some steps of this phase. Final restoration. Also, let's use diamond polish paste for final effect. This step I like to do everything. Always I like to do this manual polishing. And with various surfaces, we can check the golden powder we saw. Those are the veneers just painted with various technique. And also the easy technique. This is the middle way because we have this veneers was layered a little bit, just cut back, and the final completely layered. So we'll try to compare them. In this slide, we have all results, all technique that I showed you. To be honest, in my opinion, it's very difficult to achieve high aesthetic level results just painting. Why? Also because, as we know, the tooth is made of different layering. So I did this experiment with an original tooth, and if we cut this part and we put here, for example, and we see a big difference between the parts, and we repeat the experiment to put here down, we can see the big difference in the same tooth. So we can see again. So the question is, with the monolithic restoration, we can do that, we can emulate that. It's very difficult, very difficult. Another thing, another kind of problematic is related to the darkness and different thickness of the tooth. So we must take in consideration the value, the chroma, the opacity, and other characteristic of our tooth for the final restoration. Now we will analyze some clinical cases. This is the first case with Dr. Jesus Creas from Spain. Photo protocol. intraoral photo protocol. We can see several problems: missing tooth and old restoration, very, very bad old restoration. So we have to do a full mount rehabilitation on implant. This is X-ray, our patient. And now we are entering in digital world. Let's see. The digital becomes normal. Is the occlusal photo, digital project, all the faces, and we can make the matching with the patient between the project and the patient, picture of patient, to have the best result and double check. A dynamic recording of the facial scanner project. Nowadays we can use also the facial scan to put in the program. The surgery guide, up and lower. And it's time of the surgery. The surgical template and the temps are ready before the surgery, of course. Some intraoral steps sequence, upper arch and lower arch. I cannot explain a lot of that because it's not my, I cannot explain because I'm dental technician, as you know. And so I go fast. The summary of the whole process, we can have all under control using this way. Scanner of implant, DVO, the scan, STL file, the lower, same, the scan. Some zirconium milling process before sintering and after sintering, we can see in the slide. Our restoration, the final restoration mounted in articulator. This is monolithic restoration, zirconium monolithic restoration. Only a thin layered on the gum. Pink ceramic. Some faces again. This is the final appointment. Intraoral situation. And here we have our rehabilitation, the overall X-ray to check everything. And here we are, the final intraoral situation. And here we can see how copy and paste dentistry is a reality. So this is another case in team with my friend Giancarlo Pongione from Italy, Naples, my city. One of the biggest changes in our work is copy one central, one tooth. Let's try it. We can see the symmetry of this tooth. We can check with digital way. We just copy the other central. Sounds good, sounds easy, but it's not easy. Digital planning in the lab. So before and after our planning. The wax up, digital wax up. This is the printed model. And I always prefer to mount the model in the articulator physically. And not only digitally, also as to have double check. Now here we can see the 3D printed guide for the surgery, removal of soft tissue. And it's time to scan. We are ready to scan. This is our WhatsApp project, our temps, millet temps, using the same project. After surgery, after temporary. This is the provisional after 1 month. White and pink aesthetic. Now we can start with the lab procedure. Some steps of layering. In this case, I did, I mixed old school with the new school. The scan oral impression with 3D model, and I did the veneers on with ceramic refractory technique. So I mixed the two techniques. This is the final restoration. Train day, we are satisfied with the restoration. Some etching steps, as you know, silent agent. Okay. Just cemented. And this is after 1 month of cementation. We was happy and also patient, so we can go to our first cases. This time was this case was sent me from Mexico, Jesus Flores, from dentist from Mexico. And we see the patient. With this picture, we start to analyze the overall. We can see the different wrong things, like very bad old crown ceramic, like form, color, and proportion. So let's try to improve. I bring this case because it's very interesting. Due to we have a combination of crowns, bridge, and veneers. So we have different. Okay, we can see the face again. So the doctor prepped the teeth and sent to me the final impression. We did this case in one shot because the distance was very big. And I did the zircon frame for the bridge and crown, some lab steps, layering steps. After one bake, second bake. This is the final result on the model. Here we can see the translucence much better, transparent. This is the result of the handmade polish, as we saw. So you can see the opacity of the surface. It's very natural. This is the final case. The occlusal view, we can see the bridge, the crown, the veneers. A different step and train. The cleaning of the restoration with sandblasting, silent agent. The taste of the cementation. This is the final result. Here we can see the tissue looks very nice and healthy 3 days after cementation because we respected all the parameters. The final result on the mouth. Our patient very happy. Before and after intraoral photo. And here we can see before and after full face. Our patient happy again. And we are happy. Oh. like the patient. So another case, this case with my friend Federico Brunner from Argentina. This is very interesting case because we mixed again traditional way and digital way. The analogic impression and digital dentistry, 2D from 2D to 3D. Printed plastic based, we tried to do something new. We did the base tradition, the plastic printed base, and we add the traditional wax, as we know. Lips at rest, smiling, some test in the mouth. Here we can analyze the importance of the various areas: lip support, smile frame, incisor age, vertical dimensions, centric relation, wax rim print base. This is another important step. I did the aluminum bar in order to check the passivity, first on model and then on the mount, of course. Passivity test. This is the final bar, titanium laser sintering. This is the project. This is the reality. And here we can see the project, the initial project, the various laboratory steps, the base millet, the arch millet also, one block, upper and lower, so we can see all the steps here better. Some photo already in the disc after milling. And completely millet prosthesis, completely millet. Frontal view of our articulator. So as I told you, the digital way, but we like the check in the manual way, in the physical articulator. Digital and okay, this is the final restoration train. So digital can help us a lot, but we always need a great knowledge of that. It's not easy, but we can help a lot, as I told you. This is before and after of our patient. So let's go to our next case, and with my friend Jesus Cresh from Spain. This case is very interesting because we did 100% digital veneers restoration, just painted. So patient digitalization. This is the project. Our digital model and printed model for motivational mockup, as we know. Time to mockup, motivational mockup, short video, okay. Time to see the results. Our mockup was, the patient was very happy, so she accepted the case. And here we can see another step, very important. The guide for the preparation, printed guide. As we can see on the model, I like to do some different guide for preparation, as we can see better here. This is for the margin, for the length of our preparation. This is the there's some detail of the prep, very minimal prep on mock-up, of course, to have more control. Some details, double check, first on the model, second on the mouth. I like to use this, it's like spider. It's very nice because we can see all the prep in all the frontal view, the surface, from cervical to incisal. It's very nice. Here we can see better. We can check again. It's very prep-less. Very good prep. Okay. Now we are start this. We can start for the impression scan, of course. Now, this is the bonding attempts. Temporary mock-up, edge bonding, the result of the mock-up, temporary mock-up. And here we can mill it. As I told you, this case was done 100% millet with Empress multi-layer, ceramic. This is the microscope procedure to remove the block from the veneers. Some step of the painted whole video. This is my daily routine. It's not a case for a lecture. It's normal for us. Okay. Go fast. So here we can see the first after millet after the adaptation on the model, then the first fixed colored and final glazing. This is the final result. We can try to emulate some natural effect also. Cleaning of the veneers. This is time to train. Clean the preparation, time to bond our restoration. This is the final result after cementation. All the steps from initial to final. One day after cementation, palatal view, and nice live patient testimonial.
Hi Jackie, I'm so happy with my new smile and I know it's yours. So thank you so much for donating your smile. Now you have a clone in Spain. Hope you're happy about it. Bye.
So that's why we like our work. This is before and after. As we saw, 100% digital. Very happy patient. So the final case that I will show you was sent me by a Greek dentist from Russia, Dr. Gazi. And we can see a very difficult situation. Here we have all the picture that I need so I can do a very good study of the different position and various views of the smile. It's important to analyze the different lip position, smiling and rest lips. Smiling again, lateral view. We have very deep bite here, and we will try to study and decide what we can improve. Orthodontic treatment, of course. And here we have before and after the orthodontic treatment. After ortho treatment, full face patient. And now we are ready to do wax, to start our wax up after the ortho treatment. So the model, the mount, and the model. The models in the articulator and mounted in the articulator. In this case was the same to our wax up, lateral view, frontal view. I always use this instrument to check the occlusal plane. I like to use. And here we can see in the mount the exactly replica of the wax up. That's why I use very hard and stable silicone index. Sometimes big, but I want to 100% the stability. This is our wax mock-up mount. Here we can see mock-up again. So initial, after, ortho, and mock-up. We are ready to start. The patient was very happy with the mock-up, so we can try to copy. Now we can start layering. The alveolar model, the wax up with guide for the layering. Some step, always following the mock-up. Again, the check. Final result on the model. After removing the dye, the gypsum dye, and here we can see some steps of cementation. This is the final result after 2 weeks of cementation. We can see the texture, the natural texture, not a lot of glaze paste, as we saw natural handmade polish. Here we can see also the texture, micro texture, lateral view. With lips. The patient was very happy again. This is the final restoration. And patient. This is before and after. 10 upper ceramic veneers. Natural smile. Smile again. This is the full face before and after. The patient very happy. So the conclusion. 'Cause believe in the quality of traditional work, and I think there is no quality without sovereignty. And the technology must help us access our qualities. Thank you. Hello, I'm sorry.
Thank you. Yes.
I'm sorry. Just the final. What's happened? Okay, thank you, my friend. Okay. Can you see? Okay.
Guglielmo.
Yes, I'm here.
Thank you so much.
You.
So I have, thank you. This is such an amazing and inspiring work. I have so many questions, so stay with us.
Let me put the camera.
Yes,
Okay.
I have mine. Okay.
Let me see. I cannot see.
I can see myself.
Okay. Me? No?
Are you on?
Yes.
Okay. So I have a question. Why do you do the hand articulation? Don't you trust the digital articulation?
Can you repeat?
Why do you still use the hand articulation? Don't you trust the digital articulation?
Well, it's a good question. To be honest, I trust in the on the digital articulation, but I prefer to check again in my hand, to double check, because we use the printed model, and we know the printed model are sometimes not very precise. So we can understand. We use the printed model only to the layering, to check the model, the final restoration. But I like to have double check.
So is it enough, the digital articulation, or we need to double check?
It's enough. It's enough. But when we take the restoration, zirconium restoration, ceramic restoration, everything, from the machine, we have to remove the block, to do something manually. So it's better to check. For me, I'm more comfortable. Maybe someone don't need, but I can see sometimes a small thing to adjust, just for the functional. Also, because, to be honest, was my daily
work
from many years. So I want to live this way slowly, as slowly as possible. You know, we can trust. So basically, we can trust on digital articulator, but I prefer to have double check in my hand.
Perfect. Okay. So another question. Isn't more effective or more cost effective to have the denture bases printed rather than milled?
Printed what? From model?
The denture base, yes, for the dentures.
Yes, but okay. I did this test. I used the printed bases, but you mean for the final restoration, not for the...
Yes, isn't more effective to have the denture base printed?
The problem is not the cost, but the problem is for the future adjustment. The printed resin cannot be used with the normal resin. Maybe after 1 year, 6 months, we have to refill with resin, you know?
Yes.
Or we have to adjust. The printed resin is not compatible with the normal resin.
So you say that the milled denture bases are more accurate than printed denture bases?
No, we can use the same resin for the milled resin for adjustment in the future, but we cannot use the same resin for the printed model, the printed base in the future. We cannot repair, we cannot do nothing in the future.
Okay, got it. So it's about the resin we use
also for
in the milling.
polishing. Also for the polishing, the millet we can polish handmade, but the millet we can use only glaze. So it's very retention plaque. It's not so good for the cleaning.
Okay. So we recommend the milling denture bases. Okay, I have questions about.
We have not all the certification for the final restoration printed. We have only for the guide, surgical guide, because it's during slow time, you know.
Yes.
We cannot have
this is my opinion too. We always go for milling rather than printing whenever we are talking about the final restorations.
We can have the certification of this millet resin, but of the printed we cannot have as final restoration.
Okay. Do you have any specific recommendation for the milling materials, the CAD/CAM for CAD/CAM veneers? Do you like specific material whenever you are considering CAD/CAM veneers?
Yes. Depend a lot of the final color that we want, and of the color of the tooth where we start. So the best material for me is ceramic, not IMAX, but is also dangerous because it's very, very soft. It's like ceramic. So in the millet processing or in the finalization processing, we can break. So basically we have IMAX and Empress, basically, okay? Two big family. One, so IMAX is very strong, it's very nice. Also we have a lot of color, but Empress is a little bit high aesthetic because it's ceramic. But it's very, very difficult to manage all the steps, even when we have less space, when we work with the very, very thin veneers. When we work in the thin veneers, it's much better IMAX, to use IMAX, because in processing milling, we can break very, very easily.
So, you usually go for IMAX most of the time, let's say.
80% of the time, mostly of the time, yeah.
Yes.
Sometimes when I have space, when I have a lot of space, and I want to do the monolithic restoration, as the case that we saw in my presentation, monolithic restoration, this was Empress, but was not thick, but was monolithic. So I had a good thickness to work.
Perfect. Okay. Do you deal with face scanners? Did you try the face scanners? Any recommendation regarding this?
I try, but to be honest, I don't know the file where which scanner the dentist used, because they send me the file, you know.
Yes,
I think
but I'm talking about the face scanner.
Yes, face scanner. Yes, face scanner. Yeah. We have 2 or 3 brands now, actually, but I can see only the STL. So,
do you think they are useful? Do you think it's mandatory to have face scanners now? Are they helpful?
Yes. Yes. Yes.
So you recommend them?
Yes, I recommend them. Is always as much we can have the information. Is always better to have more information.
Yes.
So I like to put the face scan in the project model and the project cut. I like, because it's the matching is perfect. You can see the patient.
Perfect. Perfect. Okay, what is the thickness you can achieve when you are doing veneers on CAD/CAM? How far we can go regarding the thickness?
We can achieve 0.4 on milling process, but when we cut from the block, we can do manually. We can achieve 0.2, 0.1, like ceramic veneers. You know,
so it's the same like the manual.
It's the same, but we cannot achieve in the machine by hand.
Yes.
Yeah.
But you can drill after that.
Yes, you can drill. You have to drill, of course.
Okay. So I have a question. What do you think about zirconia veneers from Noritaki? This is a question of Firas.
To be honest, I don't understand this way, because why we need the hard material than IMAX. IMAX is 450 megapascal, so we don't need more. You know, I don't know. So, I don't know why we have to use that. Just for
yes, I share the same idea with you. But maybe sometimes if you have, for example, zirconia bridge and 2 units veneer nearby, some dentists and some ceramists, they might suggest using zirconia veneers, especially that now we can bond zirconia to a certain extent. Of course, it's not the first choice to do zirconia veneers, but I think we will see more zirconia veneers in the future. What do you think?
In the future, I don't know. I think we don't need to use zirconia, because now we have ceramic that we can use on IMAX and zirconia.
Okay.
We don't need. It's just it's just more difficult to bond them. That's it.
Okay, another question.
But it's difficult.
About face scanners. When do you need a face scanned file, and when you prefer face photos? Are face photos a replacement for the face scanners?
No, for me, I need everything, every time. It's much better. You can compare. You can sometimes some photos are not enough, and you can see the face scan, or the face scan is not right, and you can see the photo. If you ask me, I always reply you, give me all the information that you have. It's always better.
Yes. Of course, nowadays we see many face scanners. Of course, they are helpful. They are not mandatory, but they are helpful. as Guglielmo said, anything you can provide for your lab technician will be of help. Finally, many participants are asking about the mock-up. The dentist, they send the teeth non-prepped, right? You prefer that the dentist, they send the teeth non-prepped for the mock-up, right?
Yes. Yes, of course.
Yes.
For me, it's the best.
For how long usually dentists do temporization with this mock-up?
Also for 2 weeks, 3 weeks, 4 weeks. With both bone etching.
Yes, without etching.
But usually they stamp, they remove, they drill, they polish, and they cement them.
Yes. Guglielmo, that was inspiring. This is a great job you did. Very nice, beautiful cases. I'm so thankful. Hopefully you and all of my friends in Italy, you stay safe and you come out of this stronger. You know, I'm a big fan of Italy. I love this country. Hopefully all of us, all of our attendees also, they are safe and they are staying home. Thank you so much. I have another great speaker, a friend of... thank you, Guglielmo. I have a great speaker waiting. This is Dr. Alexander Khairallah. I will ask Dr. Alexander to join us and to start his video. He will be speaking about radio opacities in the maxillofacial region, when to worry about it. I have many questions. Hi, Dr. Alex. Hi, Dr. Alex. You look great. How is the situation in Lebanon?
Well, it's like around the world. We have the same problem everywhere. So hopefully we are going to be all safe and see each other later, face to face.
Hopefully you are having low numbers of cases.
We have a little bit of numbers today, like 5 or like 10 or 12 cases, new cases, but it's under control.
Perfect, perfect. I have so many questions from the attendees asking about the schedule. You can see the schedule now in front of you. Every 1 hour, we're having a full lecture. We will finish around 7:15, 7:30 p.m. Greenwich time. So it's 2 hours plus or 3 hours plus in the MENA region. Also regarding the certifications and the CME hours, many are asking about that. Actually, we are trying to do certificates for those who attend our webinars through the Zoom Congress. We are looking for a mechanism to count down the attendees, because we have more than 13,000 registrants to these webinars, and now live I have more than 2,000 people attending this lecture. Dr. Alex, I'm sure you're gonna give us, as usual, a great presentation. So I will let you share your screen, and I will leave the podium, the online podium.
Thank you, Tom.
Okay.
Okay. Hi, dear friends. Hope everyone is safe and enjoying our live broadcasting. As you know, we've been participating a lot of today's to lots of webinars, and it's now time as BAIRD member to share ours. A special thanks will go to my friend Tamer, Solange, Hassan, and Walid, and all the team of BAIRD and ALD for their huge effort. Okay, my presentation for today will be about I have to hide this one. Okay, will be about, or do I hide it? Let's take it down. Okay, will be about the opacities in the maxillofacial region, when to worry. Okay, if we want to go a little bit to the basic, as you know, radiopacities are the state or degree of being opaque to X-rays. They appear as a white image on X-ray films. They can be described as bone, soft tissue, or tooth-like opacities. Their image, discovery, and extension may vary according to our receptor or field of view. Our smallest field of view is the periapical, as you know, or the small field per cone beam CT. Also, as you know, the periapical will cover around 3 to 4 centimeters, and the smallest cone beam CT is around 5 by 3.7 centimeters. And for sure, the cone beam CT is a 3D imaging. Let's begin with something very easy. This is a two slight opacities. On the left side, you can see that we have a root over here, and on the right side also we have a root over here projected into the sinus. Both are iatrogenic opacities done by dentists. This one is an old one, and it's here lying here without any problem. This one can cause a problem because it's projected into the sinus, and as you can see, we have a communication between the oral cavity and the sinus over here. Another two slight opacity, this one. On 2D and 3D imaging, we can see that this is a compound odontoma, preventing the eruption of the canine over here and the upper canine over here. And on 3D imaging, you can easily see that. We can see it in 3 dimension. We can see that the canine is directed palatally, and we have to go and find our way through the palate in order to do our surgery. Another two slight opacity, this one, this is supernumerary tooth, and it's also preventing the eruption of the molar over here. Now we have incidental radiopacities because we don't have any clinical sign, as you can see over here. We have on periapical 2 supernumerary teeth. On cone beam CT, we have a small odontoma over here preventing the eruption of teeth. No, sorry, not preventing the eruption of teeth. We have no clinical side, and this is purely incidental. And we are introducing a new word nowadays called incidentaloma. If you look a little bit on Google, you can see that incidentaloma is defined as incidental finding observed either on 2D or 3D imaging during our normal survey. If you look a little bit more on literature, you can see that it can cause some medical legal problem. Why? Because if the radiologist believes an incidentaloma is of no clinical significance, and if he mentions it in his report, this will possibly lead to a cascade of tests, biopsy, and other surgical procedure, which occasionally can cause serious complication. And if it was not mentioned in our report, and it turned to be a significant disease, the patient health may be in danger. And in both cases, we have a medical malpractice. So we have to be a little bit conscious wherever we are dealing with incidentaloma. Another two slight opacity, this one, and this is very easy. This is very easy. It's an idiopathic condition characterized, it's epivercementosis, idiopathic condition characterized by the excessive formation of semen around one root or more than one root on one or more teeth. Another kind of two slight opacity, this one, it's at the level of the central incisor over here, and this is not, and it's a hypercementoma, it's a calculus buildup. Okay, look how much calculus we have here at the level of the central. And this is what I'd like to call patient negligence radiopacities. Another bone-like radiopacity, as you can see over here, this is purely anatomic. This is the malar bone, and this is a projection of the zygomatic arch, and we have it on 2D imaging whenever we are using a steep angulation from up to down, and the projection of the malar bone over here will be projected over the teeth. Also, the zygomatic arch will be projected over the teeth. Let's say this bone-like radiopacity over here, it's projected over the central and the lateral, and more posteriorly. This is a typical image of torus palatinus, which is, I have to remove this one because it's always in our way. Okay. This is a common exostosis that develop in the middle region of the hard palate or on both sides on the mandible, as you can see over here at the left and the right side. And this is a good source of bone. Whenever we need to have autogenous bone, we can easily use them and as a graft. Let's see this one. This is bone-like radiopacity around the root of the molar here, badly decayed, with the relation between the decay and the pulp over here. As you can see, we don't really see the difference between the radioopacity and the porture of the tooth over here. This is a condensing osteitis. If you look a little bit at the literature, you can see that we can call it also focal sclerosing osteomyelitis. It's periapical, poorly marginated, non-expansile, sclerotic, uni or multifocal image. It represents a local reaction to a low-grade inflammatory stimulus, for instance, an inflaming pulp, in individuals with high level of tissue resistance. And it results in bone apposition. This is how it looks on a cut of a cadaver. And this is not a pathological bone. This is a normal bone. You can easily do implants in it, as you can see on this 2D imaging or on this one on a 3D imaging. So you can use it as a site for implant or whatever you want. What about this one? This is also a bone-like radiopacity, but as you can see here, we can easily see the periodontal space. There's a difference between our radiopacity and the tooth. And this is an idiopathic osteosclerosis. Okay, on a cone beam CT also, we can see it. It has nothing to do with the tooth. And if we look again at the literature, you can see that it's generally separated from the teeth, cannot be attributed to any inflammatory or systematic disorder. It's round, ovale, non-expansile image with sharp margin and occasionally peripheral speculation. Let's see this one. This is a Guetta-like radiopacity, an over-obturation, over-preparation, over-obturation of the root over here. This is a wrong pass of the preparation. And this is also a iatrogenic radiopacity. Other kind of radiogenic opacity, this one, when you have a puff of cement going out of the root. And this is what I'd like to call the Christmas tree of a dentist. This is cement-like opacity. Another case, as you can see over here, this is what I'd like to call the ultimate endo treatment. Whenever you find a canal, go and fill it. And this is a cement going out of the canal into the inferior lower canal, and that causes some paresthesia for the patient. Another iatrogenic opacity, this one, this is the calcium hydrochloride dressing going out of the root into the subapical region over here. It's an incidentuloma also. The patient didn't hear anything, but I wanted a little bit to go further in this direction, and I looked over the internet for some articles, and I found an article published in 2002 into the Journal of Oral and Maxillofacial Surgery, and as you can see, they were reporting a case of a patient with adverse reaction after calcium hydroxide extrusion during endodontic therapy. And you will see that when the paste was applied with the syringe into the distal canal, the patient experienced severe local pain. After 1 or 2 minutes, the corresponding half of the face became pale. In the 90 minutes, following 90 minutes, the right half of the face, including the ear, became increasingly blue in combination with increasing pain. Part of the palate, corresponding to the right greater palatine foramen, also became cyanotic. Facial nerve paralysis and trigeminal paresthesia developed in all branches of the right side, and the vision on the right side was also blurred. What was the cause? The syringe probably entered the root deep enough to increase pressure, which exceed the arterial blood pressure and make it possible for the paste to go upstream. This is the fluoroscopy of the image over here. As you can see, this is the paste going into the vessel. This is how the patient look clinically. Lots of scars due to necrosis. And this is an internal view of his mouth, where you can see we have necrosis of a palate over here. Another case was also published in 2008 in the OOO, talking about the 2 cases. The first one where calcium hydroxide was injected into the distal root canal and the lower segment molar, resulting in the distribution to the external carotid bed. And the second one was about the injection into the palatal root of an upper segment molar with a flow into the infraorbital artery. And in both cases, they had severe clinical pain and symptom ending in tissue necrosis, long-term sequelae, including scarring, deformity, and chronic pain. So we have a little bit to be cautious whenever we are injecting calcium hydroxide into artery, into the palpable complex when we are doing some endo treatment. Let's see some metal-like opacities. As you can see over here, this is separated root kept into the alveolus, the extraction site after the extraction, and this is a metal part of an amalgam also kept into the socket after the extraction. Another one, this is a post. Also, the dentist put this post outside of the pulpal complex over here, and this is really a iatrogenic radiopacity and a teratogenic problem. Another metal-like radiopacity, this is an old implant metal, needles implant metal system. It has nothing, it's well osseointegrated over here, it fractured. So the dentist wanted to do something over here, so he did a bridge, as you can see, leaving this old needle system at its place. Another metal-like radiopacity, this one, as you can see, this is a fractured implant over here. The dentist did 2 crowns, one as cantilever over here, and he left the implant at its place. Other metal-like radiopacity, this one, the staple. This is due to what I call patient negative radiopacity. The patient felt so many pain over here and he wanted to release his nerve, so he inserted the staple into the palatal root in order to release a little bit himself. Other metal-like radiopacity are those one. This is what we call waffle thread facelift, and this is are used in facelift as to flatten the furrow of the face over here. Other metal-like radiopacity are those ones. This is the metal vascular clips. They are used in facial surgery whenever they wanted to clamp some arteries during their facial surgeries. This is on a small field radiopacity, but if you want to see it on a large field image, as you can see over here, this is patient injured during the war. He has a wrong graft for the mandible over here, but he has lots of metal vascular clips, as you can see here, here, and here. And also this is a fragment of bomb over here during his injury. Okay. Other metal-like radiopacity are those ones that are round. Well, the one that goes to hunting knows them very well. This is a firearm accident. And if you wanted to see it on a larger scale, this is another patient with some firearm problem. He lost his right eye. And as you can see, they are well represented on the mandible and the maxilla and all around. So it was on the small field radiopacity. Now let's go to a bigger field radiopacity, which is the middle field radiopacity. What I mean by middle field radiopacity is an 8x8 on cone beam CT or the panoramic field. And in both cases, we have a representation for the maxilla and the mandible. The first one is this one. It's a metal-like radiopacity. It's evident. As you can see, this is a purely incidentaloma, and this is a part of the fractured surgical burr during the removal of the tooth over here, probably the third one. Another case, this one, this is also a metal incidentaloma radiopacity. This is due to a firearm, but if you look carefully at this panoramic, you see on the other side we have radiopacity over here. It's blurry, it's not well represented, and it's not at the same level of this one. This is what we call the ghost image, and it's due to the projection of a radiopacity on the other side. Usually it's projected on the other side. It has an ovoid shape and it's not clear. It's a little bit blurry. Okay. Another metal-like radiopacity, this one, this is a part of the shell, a shrapnel of the shell projected at the level of the sinus, as you can see over here, and this is it after the surgery. This one, a metal-like radiopacity, it's evident for everybody. This is an implant projected into the sinus. This is not my problem over here. As you can see here, we have an implant and we have two crowns. One is a cantilever. And this is purely incidentaloma. The dentist didn't say anything to the patient that he lost his implant. He did his crown, as you can see over here, without telling him that he has an implant into the sinus. Although the sinus is clear, there is no sign of infection to the sinus, but the implant is over here in the sinus. So this can cause easily a medical legal problem for the dentist. Another case over here, this is also pure like incidentaloma. This is a tooth-like opacity at the level of the coronary process on both sides. It's an ectopic third molar position. The patient didn't feel anything. What about this one? This is also a tooth-like opacity at the level of the condyle. But in this case, the patient is feeling pain. Why? We did a cone beam CT for him. And as you can see on the frontal cut, part of the tooth is going out of the condyle, as you can see it also here. So whenever the patient is opening and closing his mouth, he's feeling pain. Okay, so this one, it's not incidentaloma. The patient is feeling something over here. What about this one? Also, we have a tooth-like opacity at the level of the submandibular region, at the level of submandibular region over here. Okay. And this is a projected tooth during surgery due to some uncontrolled maneuver. The tooth went from the alveolus over here into the submandibular region over here. And this is, we have to be very cautious whenever we are addressing third molar extraction with no lingual plate, as you can see over here, because any uncontrolled maneuver will project the tooth into the submandibular region over here. Also, a tooth-like opacity projected into the sinus, as you can see here, and this is also incidentaloma. The patient was not aware of it, and it's in the sinus. What about this one? Let me tell you a little bit about this patient. This patient went to our friend over here, Dr. Zogbi, in order to do some implants in the posterior region at the right and the left side. Dr. Zogbi ordered a cone beam CT, and he found that we have a tooth over here. So the tooth was not extracted, it was projected to the sinus. And this can cause also a problem, a medical legal problem for the first dentist, because he didn't say anything to the patient that he has a tooth into his sinus. What about this one? Okay, if you look at this panoramic reconstruction, over here, we have a tooth-like opacity, okay? But if you look carefully over here, you can see that we don't have the second and the third molar. So probably this is a tooth projected into the sinus due to incomplete extraction. But if we look a little bit to a more thin slice, as you can see, we have here the radiopacity, but it has the shape of a cauliflower, and it's connected to the posterior side of the sinus over here. So this is not a tooth-like radiopacity, it's a bone-like radiopacity. This is what we call anthrolate, which is a calcified mass within the maxillary sinus. The origin of the nidus of calcification may be extrinsic from a foreign body in sinus, or intrinsic, like stagnant mucus or fungal bone. Most anthrolate are small and asymptomatic. Larger one may cause sinusitis with symptoms like pain and discharge. So we have to be a little bit cautious whenever we are looking at cone beam CT. We have to look at the smallest thick in the part of the image in order to see the whole reality, and not to look on one cut. We have to look on all cuts. Another incidentaloma over here, as you can see, we have a radiopacity at the level of the second and the first and second premolar. We took a cone beam CT for it. The patient is 38 years old. We took a cone beam CT for it. As you can see over here, this is what we call an anthrolate, which is a calcification into the sinus also. What about this one? This is a bone-like radiopacity into the sinus. So is it renal problem to the sinus or not? As you can see, no, this is not. This is a failed sinus graft. Okay, this is the sinus graft. We have a second Schneiderian membrane over here as a reaction. And as you can see here, we have the opening done, the window done whenever they did the sinus lift procedure. So it's not a non-trolate, this is a failed sinus graft. What about this one? Is it a non-trolate? It's a young patient, 8 years old, Cedric. As you can see, we have radiopacity at the level of the second and the first and second deciduous teeth over here. When we did our comb CT, you can see that it's not into the sinus, it's into the nose. And it's called renolite, which is mineralized foreign body into the nasal cavity. Undiscovered, they can grow in size and can cause a full smelling nasal discharge and a breathing problem. So this patient must be addressed to an ENT in order to do something for him and not leaving him only as a dental patient. Another one. This one, it's a bone-like radiopacity projected at the level of the third molar over here. This is an old case. It's Matilda, 42 years old. At that time, we didn't have a comb CT, so we wanted to manage a little bit the case. We took a posterior anterior X-ray. As you can see, it has nothing to do with teeth. It's projected at the level of the ramus. So we took a periapical X-ray for the cheek of the patient, and this is the result. This is a soft tissue fibrosis and calcification due to an old burning accident for Matilda. About this one, we have a bone-like radiopacity over here. Okay, we have two teeth, one badly decayed, and the third molar was projected a little bit into the ramus. The patient is 26 years old. We took a comb CT for him in order to see the relation with the inferior alveolar canal. As you can see, there is no relation between the image and the inferior alveolar canal. The inferior alveolar canal is well preserved. A biopsy was done in order to see it, and the report is a non-specific condensing osteomyelitis. Okay, it's a reaction, inflammatory reaction to the decay and the region over it. It's an overreaction, but it's a reaction. Another bone-like radiopacity, as you can see over here, we have lots of bone-like radiopacity in the maxilla, upper right and left, and the mandible right and left also. The patient is suffering from also polyp into in his colon intestine. So we have a multiple center stoma, and it's typical, the Gardner syndrome, characterized by hard tumor on bone-like structure developing into the bone and the presence of multiple polyp into the colon. Another radiopacity, this one, it's outside the bone, as you can see over here, and this is a peripheral osteoma. It's a hard tumor of bone-like structure developing on a bone, not into the bone like the other one. The other one is center, this one is peripheral. Another one also peripheral osteoma at the level of the end of the mandible over here, and it's completely lingual to the mandible, and it's only seen on 3D imaging. What about Ibrahim? Ibrahim is 18 years old, and he has a bone-like radiopacity invading the whole sinus, as you can see. Okay, clinically he has some bulging over here. A biopsy was done, and the report was a fibrous osseous dysplasia, which is a reactive bone formation. Okay, the patient need only shaving in order to have a better aesthetic result, but with no any problem. What about this one? This is a bone-like radiopacity. This is typical. This is what we call a socket sclerosis due to a node extraction. Usually it's asymptomatic. It's an incidentaloma. But when I was reading a little bit over the internet about the socket sclerosis, I found this article. It was published in 2008 in the Angle of Orthodontic Journal. As you can see, socket sclerosis can be an obstacle for orthodontic space closure if traditional mechanics are employed. So our friend orthodontist, please be a little bit careful whenever we deal with this kind of images, because with traditional mechanic, they couldn't close the space. But with many implants, reinforced anchorage, it can lead to success phase closure, resulting in complete resolution of the sclerotic sites. Now let's go to something more dangerous, between quotes, we are going to see, and it's not addressed directly to us dentists, but we can easily see them in our panoramic. As you can see here, we have more likely opacities on both sides at the nasopharyngeal space, at the pharyngeal space over here and over here. And it's a typical image of tonsilolite, which is the soft aggregate of bacteria and cellular debris that form in the tonsillar crypt. This is how they look on cone beam CT. This radio opacity in the soft tissues, and this is clinically how they appear. As you can see over here, those are the tonsilolite. They are radio opaque on both sides, and sometimes the patient can take them out with his bare hand, as you can see over here. Okay. Another kind of bone-like opacity, it is a little bit more advanced. Bone-like opacity at the level of C4 and C5, as you can see here on both sides. And this is what we call cervical carotid artery atheroma. Okay, it's dangerous. This is how they look on cone beam CT. Why we have them at the level of C4 or C5? Because here we have the furcation of the carotid artery, and we have a turbulence over here, and we have a deposit of calcification over here, and the artery will become narrower and narrower. And especially in patients with medical history, in obese male, cardiovascular disease, hypertension, type 2 diabetes, hypercholesterolemia, and this can cause dangerous ischemic attack. And if you look a little bit over the literature, you can see an article published in 2015 by Dental-Maxillofacial Radiology. The aim of the study was to evaluate the association between the extra and intracranial calcification of the carotid artery, incidentally found on cone beam CT. As you can see over here, we have a correlation between the calcification of the common carotid artery and the internal carotid artery over here. And as a conclusion, they said there's a significant correlation existing between extracranial carotid calcification and intracranial carotid calcification. And those patients need further medical evaluation by other physicians, not the dentist. Usually, they are treated with stents in order to leave the carotid patent, and the blood will flow now easily. This is how stent will look on cone beam CT, as you can see over here. Another bone-like opacity projected at the level of sigmoid notch and around the region of the temporal region over here. This is a typical image of phlebolith, which is calcification in the maxillary artery. Sometimes they are unique, double or triple, projected into the region, as I said before, sigmoid notch, coronoid process, the condyle over here. What about this one? Okay, we have a bone-like opacity projected at the level of the premolar. This is a typical image of submandibular gland calculus. You can easily see on a cruiser radiograph or on a cone beam CT, as you can see over here. And this is a case of Ahmad, and this is a stone after taking it out. What about this one, projected at the level of the ramus over here? This is a typical image of the parotid gland calculus. Sometimes it's in the gland, and other times it's the canal, as you can see over here. This one was in the canal. Okay. This is a CD of it, and this is the calculus after taking it out. Other multiple bone-like radiopacities, as you can see, projected at the level of the ramus at the right and the left side. This is a micro calculus of the salivary gland. What about those ones? They have some patterns, as you can see. Okay, here and here. And those ones are the radiopaque image of those, the gem over here over the veil of this young lady. Okay, so we don't have to go into confusion whenever we see such image. We have to be a little bit careful whenever we are doing panoramic images for such patients. What about those one? As you can see, we have multiple bone-like radiopacities on both sides. This is Mariam. She's 88 years old. Okay, so I was a little bit confused about her, and I did some comb beam CT for her, and I saw lots of radiopacity on both sides, on a cedar reconstruction also. So I asked her a little bit what was that, and she told me that at the age of 50 she did some filler for her face. This is the reaction of the body and some calcification and some residue of the filler over here. Okay, just an old dermal filler done at the age of 50. What about this one? At the level, the mandible over here, in front of the angle. This is the pure calcification, lymph node calcification due to a low tuberculosis or cat's cash disease or rheumatoid arthritis or fungal infection or lymphoma previously by radiotherapy. Okay, sometimes they are unique, sometimes they are double, as you can see on this comb beam CT and CD construction over here. Another case, this is the lymph node calcification over here at the level of the mandible, angle of the mandible over here. But if we go a little bit back to what I presented before, we have a ghost image over here. It's blurred, it's veiled, and it's higher than this one. So we have to be careful whenever we see an image outside the mandible and another one on the other side, a little bit higher. This is a ghost image. So don't go and search for it. This is typically an artifact. So if I have to summarize a little bit the extra dental images that we can see on a panoramic, the first one is the phlebolith at the level of the sigmoid notch, condyle over here, or a little bit retrocondyle. We have the calcified lymph node at the level of the angle over here. We have the tonsilolith projected on both sides, the ramus, the right and the left one. We have the atheroma at the level of C4, C5. Those one are dangerous. I'm saying it again. We have the anthrolith projected into the sinus, the cereolith, which is the projection of the calculus or the parotid or the submandibular gland over here. This is also an incidentaloma. This is Joe, 42 years old, and he has some calcification at the level of the soft tissue over here. This is what we call calcineutic scutis. This is a calcification of the skin due to an old trauma or an injury. Another case also, as you can see over here, we have a bigger one, and those one, this was Pascal. She had an accident, a car accident, and she has a trauma on her left cheek, and this is after taking them out. What about this one? This one is soft tissue-like radiopacity into the sinus, and this is the typical image of a mucus circulation cyst. And nowadays we can empty them during our, as you can see over here, if you aspirate, you will have a yellowish liquid done during our during the sinus lift procedure. This is the window, and we can easily empty it during the surgery. Other incidentaloma, this is really an interesting case. As you can see over here, this is a case of 16 years old male. We have an endo treatment here. We have an over preparation over obturation over here. Okay. We have a calculus of a submandibular gland over here. But if you look carefully at the other side, you see that we have a post from a post and core restoration. But if you look carefully at the teeth, we don't have a post and core here. We have a crown on both sides, on both teeth, and on the third one. So what is this? We took a comb beam CT, and as you can see on this cut, we have a relation between the radiopacity over here and the canal over here. So it's an unusual image, as you can see over here, of some paste going out into the sinus. But it was, let's say, too much condensed, and it has a white image, as you can see over here. Now, let's go to the bigger field, which is 23 by 13.5 centimeter for the cone CT and lateral self for 2D imaging. And if you look a little bit over the literature, you can see that Ludlow said in the big field CBCT findings, the most common finding will be incidentaloma. And it will be out of our dentomaxillofacial complex. And so let's go and see some of them. The first one, this one, it's a two-slice radiopacity into the sinus. This is an incomplete extraction that was projected into the sinus, and it is pure incidentaloma. The patient was not aware of it. Another incidental finding, this one, this is a metal-like radiopacity. It's not a new kind of shutting up people, okay? As you can see over here, it's projected over the teeth, but it's not the new way of shutting up people. This is the metal clip of a veil, and by the chance it was projected over here, another bone-like radiopacity on both sides, here, left and the right side, just lateral to the vertebra, and this is a typical image of a calcified stylohyoid ligament. The one on the right over here is complete, and the one on the left is incomplete. Okay, it's the calcification of the stylohyoid ligament. This is how they look on a 3D imaging. This one was a complete calcification from the base of the cranium till the hyoid bone. The second one was incomplete. And this is how they look on a 3D imaging, as you can see. And this is how they look on a node cadaver, as you can see over here. This case is a little bit interesting. I was doing cone CT and I found something into the brain of the patient. I was so afraid about it because, as you know, if you look a little bit over here, the name is Alexander Khairallah. This is my cone CT, and I found the radio opacity into my brain. So it was like I don't know, like coup de foudre for me. Okay, I have something in my brain. I'm gonna die. I'm gonna lose conscience or whatever. So I went and asked neurosurgeons and asked general radiologists, and they say this is a typical image of pineal gland calcification. It's nothing. So I wanted to learn a little bit more about them. So the pineal gland calcification typically calcified over time, especially when we have environmental factors like altitude and sunlight exposure. And I was a little bit relieved because I thought I'm going to have serious problem due to what I found in my head. Another kind of calcification is soft tissue-like radiopacity. This is a typical image of some enlarged pharyngeal tonsil adenoid that prevented patient from having a good respiration, and then it can easily cause some sleep apnea problems. Other soft tissue-like radiopacity, this is a mucosegmental cyst into the sphenoid sinus over here. This one, we have a soft tissue-like radiopacity into the external auditory meatus on the right and the left side, and an axial cut, frontal cut, the right sagittal cut, and the other one over here. And this is a typical image of an inflammatory stenosis of the external auditory meatus, and this patient must be addressed to an ENT in order to solve the problem for it. Dear colleague, who said we cannot find in bigger field some turtles, as you can see over here, or a mouse? No, I'm joking. This is the image of the first vertebra, the atlas, and the odontoid process of the second vertebra, which is the axis. And this is the image of the foramen magnum and two calcified vertebral arteries over here. And finally, to conclude my presentation, I can say we have some radio opacities attached to the root of the tooth. and it can easily be seen on 2D imaging or small field cone-beam CT. Other radiopacities can be attached to tooth or a little bit away and need some panoramic or middle field cone-beam CT in order to see them. And some of them are attached to tooth or a little bit away from tooth and need a bigger field cone-beam CT or a lateral shaft cone-beam CT. And thank you so much for your kind presence first and kind listening to me. Thank you.
Dr. Alex.
Yes, I was on time.
Thank you so much. This is so informative, so helpful. This is an amazing lecture with, to be honest, a lot of new stuff for me. Thank you so much.
Can I take a picture of the presence, Tamer? Okay, I did it.
Yes, of course. Yeah. Okay. Let me start with this because we have so many general dental practitioners with us.
Yes.
Can you give us like a short protocol, for example, as a general dental practitioner, whenever you see
sorry, Tamer, can I put my picture and see?
Yes, you have your picture now. Yes.
So I have to go, and how do I do it? I have to go back.
Yes.
I'm stop sharing or whatever.
No, you're still sharing with us. You're still sharing with us.
But I have to go back and see your image and anyway, go on with school questions, please, Tamer. Yes.
Okay. The question is, for the general dental practitioner, can you give us a simplified protocol, what to do whenever you see a weird finding, radio opacity, for example, on an X-ray or over the panoramic or radioapical X-ray?
Yes, depending on what type of X-ray are you seeing it. If you are seeing it on 2D imaging, let's say a small periapical, and you are sure that it's not, okay, now I'm seeing that you have to do it by yourself. Okay, and you have to go a little bit further into your examination. First of all, you have to ask your patient, or a little bit to know the history of your patient. Like the case that I showed for the lady, 88 years old. So I was a little bit confused. I had never seen something like that. So I had a little bit, I had to ask her a little bit about what she did in the past years, and I knew that she did some filler. And I went and looked a little bit on the literature, and I had these cases. For sure, I asked other colleagues which are specialists in maxillofacial and aesthetic, aesthetic surgeries, and they said this is an object image. Okay, but whenever first of all, we have to address our case to a certified radiologist, because he knows better than, with all my respect to all GPs, the radiologist is more prone to know what he saw. Okay, this is, if you want, my take-home message, my first take-home message. Okay, my second take-home message. My first one was about the history of the patient. So if we don't know what we are looking for, please ask a radiologist or a more experienced colleague. Okay, so for sure, if it is outside our region of interest, you have to ask for a cone-beam CT. Okay, don't be afraid of asking about cone-beam CT. It's not a matter of radiation anymore, because we have now a small field cone-beam CT. We can use a small field, and we can have lots of images about it. Okay, so practically this is what I'll be doing. But my only exception will be about the calcification at the level of C4 and C5. This is really dangerous. Okay, we have to tell our patient to go and see a physician because this is going outside of our region. Okay, and as you saw in my presentation about the article, they are talking about serious complication into the intracranial carotid, internal carotid artery due to those problems. So whenever we look at a panoramic and we see a calcification at the level of C4 and C5, please go and tell your patient, go and see a physician, because probably there's nothing, but the patient must be under supervision from a physician which is more experienced or their field of specialties. It's not our specialty to say to the patient, don't have anything over here. But the other cases are not really very dangerous, okay? Except the one for the renolate, because usually they happen for young patients, and those patients can have easily ENT problems if they are not addressed to proper physicians.
Okay, regarding the calcium hydroxide lesions, yes, this is so interesting. So what shall I do if I see something like this? You show us so many scary cases. So what is the first thing that should cross your mind whenever you see such a lesion?
You know, the matter of the calcium hydroxide, it's it's not what I showed was an old one with some calcium hydroxide into the periapical region without any sign. Okay, this is pure incidentaloma. So the problem was the reaction of the patient directly after the injection of the calcium hydroxide into the canal. It was not, and this is, as I said before, this is not an incidentaloma. This is not an incidental finding. This is like a reaction to our action. The action was, I'm not an endodontist, but the action of the endodontist. Whenever they are injecting calcium hydroxide under pressure into the canal, and some of it passes out of the canal, in such cases, they will have a direct reaction. Okay, direct reaction will be a direct response to what they did. So it's not like I found something after 1 year or 2 years or 3 years, and they have some complication. Okay, so the other one was directly after the injection, and they had some scars, and it's not a big problem, but we have to, let's say, to tell the patient it will pass, it's not a big problem, even the blurry region, but convince the patient that it's nothing, it's a problem for the patient and for us. Okay, but this is really not obvious cases. This is exceptional cases. Okay, but it can happen. But I put them into my presentation only to tell the endodontist, please be careful whenever you are using calcium hydroxide under pressure, and whenever you are really near arteries or neurovascular complex.
Perfect. Okay, what about the everyday use of cone beam CT? Is it okay? Is it healthy? It's not risky to go for? I see many dentists nowadays, they recommending, for example, CBCTs for everyday practice. Is it okay to do that? Is it safe? What do you think about this?
You know, Tamer, I have a presentation about cone beam CT in our everyday practice. It's around 350 slides. We can use cone beam CT in our everyday use. I'm not saying that every case must pass under cone beam CT, but with small field cone beam CT, we can use it. Okay, let's say you don't need to take 5 or 6 periapical in order to do an extraction for the lower tooth, for example, lower resort. For example, one small cone beam CT, it's enough. If I'm talking about radiation, one small field cone beam CT, it's around 2 or 3 periapical. Okay, so it's not a big deal. I'm not saying that whenever you are going to do, let's say, an endo treatment, go and do a cone beam CT. But you can do a cone beam CT whenever you are addressing a problem and you don't know the answer for it. For instance, you did endo treatment and the patient is still feeling pain. Okay, go and do a cone beam CT. don't hazard yourself doing 6 or 5 periapical in order to see a fracture or whatever, a missed canal. Sometimes you cannot see it. On small field cone beam CT with a higher resolution, you can see it. So cone beam CT is used in our everyday practice. I don't advise anybody to do implantology without doing cone beam CT. Okay, especially in big cases. Okay, you can do it on panoramic. I'm sure there is lots of, let's say, very experienced implantologists who can do it on panoramic. But if you have, in one case, a problem, you will not finish with it. Okay, you have to address your problem. So we have this technology nowadays. Why don't we use it? Usually we use our principle, which was the ALARA principle, as low as reasonably achievable. This was a little bit old. Now we are using the ALADA principle, which is as low as diagnostically achievable. So if we need to do 4 X-rays in order to have a good diagnosis and a good prognosis for our treatment, we'll do it. If we need 10 X-rays, we'll do it. If we need 1 cone beam CT, we can do it. Don't do 2 X-rays if you want to do 5, if you have to do 5. Okay, and not, let's say, pretend I'm a little bit worried about irradiation. I will not do a 3 cone beam 3 X-ray for my patient. Please do a 3 X-ray for your patient if the cases needs 3 X-ray. Don't do if it needs 3, and don't do 3 if it needs 2. So cone beam CT can be easily used and must be used whenever we have to.
Perfect, perfect. Just quickly, I have 5 minutes. Can you give us a general guidelines or technical guidelines? For example, if I want to buy a cone beam CT, what is the minimum accepted specifications for the general dental practitioners? We know nowadays we have too many machines with too many differences. So if you can tell us a little about this.
If I have to go straight forward to the answer, I will say buy the cone beam CT that you need. For instance, if you are an endodontist, buy a small field cone beam CT. You don't need a bigger field. You don't need the 8x8 or the 23.5 by 17. If you are an orthodontist or a maxillofacial surgeon, go for the bigger field. Okay. Whenever you buy a small field, you can gain into the resolution, because with bigger field we have a lesser resolution, we have a bigger field. With small field we have more resolution, a higher resolution. So for our everyday practicing, like myself, I'm a surgeon also, I will buy a small field cone beam CT in order to do some third molar extraction, in order to do some implants surgeries. And what's interesting in small field cone beam CT is what we call stitching, where you can do 3 small field cone beam CT and stitch them one to each other. And this is what we call the stitching procedure. So you have both options, the small field and the field that, the 3 small fields that cover the whole maxilla or the whole mandible. But if you are, let's say, a maxillofacial surgeon, don't buy a small field, you don't need it. Okay, you go and buy the bigger field. But if we are going to talk a little bit about prices, whenever the field is beginning to be larger, we are paying more money. Small field are cheaper than bigger field. But if you need bigger field, go and invest in it. Okay.
Okay. So one last question is that again, thank you so much. One last question: can we place implants in osteotomes? This is a question. One of the questions I had.
Sorry, I didn't get the question. What?
Can I place implant in an osteotome?
In osteoma, you mean?
Yes.
In osteoma, the osteoma is a different. What I showed was implant placed into the condensing osteitis. Okay, it's not a dense bone. It's like a condensation of bone, but it's not. In osteotoma, I don't know. In osteoma, no, you don't place. We don't place implant in osteotoma. It's a very dense bone.
Okay, okay. Alex, thank you. As usual, this is so great. This is so informative. Really, we are so lucky to have you today. Actually, I'm gonna say goodbye now, Alex, and I'm so happy to have Milos here from Romania. So we're jumping from Lebanon to Romania. How lucky we are. Hi, Milos. Hi, how are you doing?
Hello, hello. It's nice to be with you again.
Actually, to be honest, aside from the bad stories we hear about the COVID and a lot of people died because of this, we are so lucky to have this chance to see so many speakers, so many webinars. To be honest, it's little boring whenever you open the Facebook or something, you see too many webinars are jumping up.
I just finished one 20 minutes ago. I was for 1.5 hours talking about dental photography on another webinar from ECHO.
So we are lucky here to have you talking about the full digital workflow. I leave the online, the virtual podium for you. You can share your screen with us.
Yep, I will. Definitely. First, I want to share a little bit where I work. So this is my facility, my training center. This is the first floor where we do live patient courses. Yeah, we do a lot of full digital workflow around here. As you can see, I have my setup. We have our Zoomax microscope. I have my Medit i500, and I have the new Program Mill one from Ivocar for chairside. We have also chairside printer, Asiga. And here is our lecture room where we do all our lectures and hands-ons. As you can see, we are having cable phantoms and the meeting room with more cable phantoms. So this is the first floor where I work, and now the second one where is our full digital lab. It's one of the first one in Europe. 2 years ago, we stopped taking any more analog impressions. So we do only digital impressions, and we work only with digital dentists. Yeah, so it's a little bit of mess here, but this is how it looks, our full digital lab. We have over there printers, milling machines. And here is the playground. Yeah, when my wife kicks me out from the house, this is where I come to play. Good. So this is where I do all my photos and my videos and stuff like that. Good. If you have any questions, let me know anytime. Yeah, I will try to answer, but I will not be able to see the questions if I start sharing the screen. So I will ask Tamer to ask me questions anytime. Yeah, I will start sharing the screen, but I will not see the questions.
Nice playground, huh?
Yeah, thank you very much. So this is something very similar what I'm doing with Tamer all over the Middle East. Full digital workflow courses where we present how you can do the treatment plan in half of the day with a live patient. Also, this is a part of my work. It's called The Book. This is my latest release about dental photography, and I have also some tips and tricks about Keynote, about social media and marketing. So for those who feel curious to know a few things about photography, you can check them out on my website, and you can check the settings over there in the book and all these things. I will switch directly to full digital workflow so we don't waste time. We have only 1 hour as far as I know. Yeah, so I will just jump directly to this. Great. We'll start with a short video so you can see how my courses look like. Okay, so this was just a small sneak peek from what's happening here. These are the tools. Let's say, you know, to play a game, you need some toys. So basically, for dentists, I'm really highly recommending to have the following things like intraoral scanner and the face scanner. All my dentists that I work with, they all use intraoral scanner and the face scanner to send me the virtual data about the patient. So basically, I'm recommending the Meditite 500. It's my favorite one. I'm using it since it came on the market actually. And before of that, I was working with Trios a lot. Face scanner is the one that was the game changer. It was the one that provided me all the information I need about the patient. It's actually not a face scanner, it's a digital face bow. And I will try to explain to you in the following minutes what it means actually. We have then the chairside mill if you want to go further, or the chairside print. I'm recommending, highly recommended, is to have the Tiga printer for the dental office. Chairside mill, I'm recommending the Program Mill PM1, the one you saw. There are also augmented reality glasses, chairside CAD softwares from Exocad, T-Scan, jaw tracking systems, and so on. For the communication tool, because we are a team, dentist and technician, we need to communicate very well. There is TeamWeaver, which is okay, viewer. There is a photo protocol, you can make photos, yeah, the Shoot Like a Pro techniques and stuff. There is a Smile Cloud, yeah, Smile Cloud, the design app made by Florin Kofar, my good friend from Timișoara. I really recommend you to check his website, smilecloud.com. And there is the best one, my favorite one. It's for communication and only for communication, because SmileCloud is also for planning. Exocad WebView, and you will see what it means in the next slides. And then the laboratory equipment, I'm highly recommending top printers like SheraPrint P30, the one that we have in our lab, and it's automatic, it's crazy fast and automatically very easy to work with. It's very good. And milling machine, of course, Program Mill, Ivoclar PM7, or other brands that provide high quality milling. Now let's start with the first recommendation about Meditite 500, and the reason why I choose this one was simple because it is cheap. Yeah, we live in Eastern Europe and we are looking always at the price. But beside that, it's super fast and super precise. You can compare it any time of the day and night with Trios and with other competition intraoral scanners. Actually, I couldn't find anyone better than this, but maybe I'm saying too much. No annual fee, free updates. It has PLI since beginning. So basically we were able to take the perfect intraoral scans in color using the new digital dentistry format. Yeah, STL, it's history. We are using PLI since forever. And Trios just recently upgraded their machines to be able to scan PLI and to export PLI files. Of course, scanning tips much cheaper, user-friendly, and best price you already saw. So why I'm saying PLI is because PLI is using the triangle meshes. They are much smaller than STL. So basically the texture and the details, everything comes out much better from that intraoral scanner. Now there are some features in this Medit scanner that makes it to be my favorite is you can mark the margins of the preps. Let's say not in this case, but when you remove an old crown, I think was prep feather edge, and you don't see the margins as a technician, you don't know where the dentist stopped the prep and so on. The dentist can mark the margins directly on the scan and send to you, and it will be automatically marked in your Exocad software. So basically Exocad will recognize where the margins are, and you don't have to worry that you did a mistake or that you did the crowns too long or too short or they will not fit perfectly and so on. The second thing is that to communicate better with your patients, you can print directly using the chairside printer. You can print directly the model in the office in the same day, actually in the same hour. You scan the patient and then you add the base directly in the Medit software, and you can export the file directly to the chairside printer, so you can print directly the model and you can talk and communicate better with your patient, explaining him what is the plan for his situation. Also, I use intraoral scan to document the photos. You know, probably most of you know me. because I do a lot of dental photography. But lately I do dental photography just for marketing and branding and for social media purposes, articles and so on. Not so much for documentation. Yeah, if I would like to write an article and I would like to publish it, then probably I would use dental photography. But if you have to document your cases, day-by-day cases, with a camera, it's too much time consuming. In this way, you can give this job to your assistant and she can do the face scanning and intraoral scanning of your patients, and you can have a full collection of virtual patients with their intraoral impressions and face scans stored on your local server. So basically, you see the quality of the picture of the intraoral scan is really good. So basically, you can document all your cases like that. Then the Medit software also has direct abutment identification system, which is very good because if your technician gets this impression, he will know exactly which implant you are using there and what are the components he needs for finalizing this case. Also, artificial intelligence from Medit can help you create a digital verification jig for all-on-4, all-on-6 cases. And this is the most amazing thing that happened in the history of intraoral scanners, because you are going to be 100% that the impression you took is good or not. You will see it right away. So basically, you have to use this feature of the Medit intraoral scanner. And we did already 3-4 cases, all-on-4, all-on-6 screw retained with this feature. And the dentist's words were just, Milos, it was so fast. We did a try-in, we did the screw, we screw everything in the provisionals, and everything fit perfect from the beginning. So basically, there is no more way that you can do any errors and have any errors in the intraoral impression. You don't have to create analog verification jig. You can skip a lot of steps and just do the normal workflow, the full digital workflow, very, very easy. Yeah, this is the reliability map, yeah, where it shows you if you did wrong or good the intraoral scan. If it's green, it's high fidelity HD resolution. If it's not green and it has yellow and green and yellow and red and so on, it's poor quality. So basically, you will be able to see it yourself right away. Also for the full mouth distortion, yeah, when we talk about full mouth rehabs cases, many are scared and say, okay, but intraoral scan will not provide me accurate enough impressions. That's not true. We did a lot of full mouth rehabs. Me and my doctor from Switzerland, with Stefan Ulbrich, we did like 8 or 9 full mouth rehabs already, and with other dentists. And there was no more problem with impression quality. Now, when we talk about recommendation for the laptop, for the intraoral scans, for the face scans, and for exocad, and whatever you name it, I would start probably from here. So basically, Dell Alienware, it's the favorite laptop that you can work with. It's optimized 100% for Windows system, and it will never give you a blue screen or block, or you will not lose your data or something like that. It's super optimized for Windows systems. My recommendation, it would be to buy the latest ones, let's say not older than 2 years, starting from GTX 1070 graphic card and to the newest one, which is RTX 1080 or something like that, which is absolutely phenomenal. I have both of them. I have the old one, this one that is in the picture, and I have also the newest one, and they both fly when we scan the patient. So it's super, super easy to work with. Now I can also recommend you augmented reality glasses. This is the one I'm using all the time in the office. So basically when the patient comes and I have to scan a patient, I'm putting my glasses on and I'm start scanning the patient, but I still look in their mouth and I see in front of me the projection of what's happening on the screen behind me. So basically I don't have to turn around to watch the laptop screen to see if I scanned good or not, because I will have the virtual projection in these glasses. Yeah. Also, I'm using this MedArt table. Yeah, it's the one that I place the face scanner and intraoral scanner on the same device. And if I have a big clinic with more dental offices, I can move it from one office to another office on the wheels, very easy, from one room to another one. That's the idea. And it's very stable. You cannot have any problem. Now, here I have some tips and tricks. When you take the impression analog way and you suck at it, so you are not really good at taking analog impression, you will not be good at digital impression too. Basically, the technician still needs to see the margins of the prep. Either you will use 2-chord technique, either you use only 1-chord technique like 000 in sulcus, and then DMG retraction paste for about 4 minutes, yeah? and then you clean it, and surface becomes dry. And then you will see perfectly the margins of the prep. That's what we require as dental technicians. We need to see exactly where the margin is. Yeah, you can also mark it with the new Medit feature. Also, when taking digital impressions, I like to use the Optragate from Ivoclar because it keeps the cheeks and the lips away. And also the ScanMate. So if you have a patient with a larger tongue, you can just remove it very easy and keep it away from the scanning. But with the new algorithms of the Medit scanners, you can actually quit using those because the scan comes really good even without removing the cheeks. Now here is the game changer. This is the one that changed my mind about digital dentistry and made me more curious about changing the way we work in analog dentistry. So I quit completely analog dentistry after I met the AFT face scanner. This was the missing link. And basically what this scanner is doing is basically using two scan bodies, one scan body for the head, another scan body for the mouth. And the scan body from the mouth will actually show us the position of the maxilla of the patient maxilla as it is in nature. It will transfer it to digital. So basically, it's not a face scanner anymore. It's a digital face bow. And you can measure the Bennett angle. You can see the Frankfurt plan, Kemper plan, median line, Condyllian guide, and measure all these things and program the virtual articulator with the patient's own numbers. Yeah. So basically, we don't need any more condylography. Yeah, you can use additional Mojo or ProSystem or Zebris, the jaw tracking system, but I didn't feel like I need them because I have this face scanner. So it's super cheap. It's about 3,500 euros plus VAT. And it's not 20,000, 30,000 like these devices for jaw tracking systems are. Also, I'm using a free software called Autodesk Mesh Mixer. This one I use to get the bite. When we have the full mouth rehabs and when we have the patient with the splint therapy, and he went through splint therapy about 3, 4, 5 months, I don't know, and he feels comfortable with the final splint, I will send the patient with that splint for the CBCT, for the full mouth CBCT, so I can see also the condyles, yeah? And then I make sure that I check that we don't have translation of the condyles. I make sure that we have exactly the bite as it is in the splint. And then we take the CBCT and we overlay it with the intraoral scans, and we get automatically a perfect bite of the patient as it is in the splint. And then we transfer these files to exocad. So basically, this is how we take the bite for full mouth rehabs. It's the safest possible way because here you have the soft tissue, you have the hard tissue, and you are safe because you don't do the translation of the condyles. You can check that in the CBCT. Now there are different softwares. We use exocad for designing our patient cases. And as you can see here, we have the virtual articulator, we have the patient in the virtual articulator, we have the design, and we have the functional part. So basically, we are not going to do only the aesthetic part, but we are going to do also the functional part altogether. Now I was telling you about the communication tools. Here you have my favorite one, which is called exocad WebView. And the good thing about it is on the right side of the screen is that you can communicate with the dentist even if he's not in the office. Me as a dental technician, I send to the dentist this case that was planned in the exocad. He can rotate it to any angle. He can make the transparent skin. He can make transparent design. He can make transparent CBCT. He can play with layers. He can zoom in, zoom out, so he can check the planning from all the possible aspects, from all the possible points of view. And this is the ultimate way to communicate between the lab and the dentist. And also the dentist can show this to the patient, so the patient can accept or not the case, or they can work together to get a better outcome. Yeah, so don't forget about it. It's exocad WebView. You can download it directly.
Ladies and gentlemen.
So then I will show you something else. I will show you this video from SmileCloud, which is another designing app and the communication tool.
Ladies and gentlemen, let me introduce to you our future. Our future. Our future. Our future.
To the end of the ceremony. Let's go. Finally, it's you and me. Here shaking like a tambourine. We in this finally. Both sides of the cemetery. Try to catch up. We out here. Let me introduce to you. Try to catch up. We out here. Future hit. Future hit. Now feels like victory. About to live another fantasy. Everybody clap with me. We're about to make history. Come on, attention people, y'all get ready. This is for everybody. Try to catch up. We out here. Let me introduce to you. Try to catch up. We out here. Future hit. Are you ready? Do you believe in magic? Here it's automatic. La la ooh. Amazing how it's happening. Look at how we made it. La la ooh. Our future. Our future. Our future. Our future.
So this is the Smile Cloud. You can find it on smilecloud.com. And you can get more information from that website, how you can plan your cases and how you can have an amazing result. Now I will talk about the chairside printer. Let's say you are working with a technician that is not in the same city, it's not in the same country with you. Then you send him the face scan, intraoral scan, not you can be your assistant. Technician will do the planning, will send you a proposed situation. Assistant can print the mock-up and ask for the dentist to come and just position the mock-up, do the mock-up in the mouth of the patient, and use the motivational mock-up to sell the case, actually. Yeah, this is definitely the printer I would use for the chair side. Then we have the SharePrint 30, which is the one that we use in our lab. It's a high-quality printer that you can have amazing results. It's super fast, super accurate, and we use them to create designs for our patients too when we have our local dentist. Now, you have to remember that you have to stage mock-up. Yeah, first, and my favorite one is the most motivational mock-up printed. Yeah, is the one that you see in the picture. Basically, what I'm doing when I have a new case, as you can see here in this small screen, I think you can see it. Yeah, it's a printed model with printed veneers, like you see in the picture, and we take them one by one and we put it in the patient's mouth. And that's how we do and we sell our case. Yeah, non-prep patient, the teeth we don't touch. We just place this 0.3, 0.2, 0.4 millimeter veneers in the mouth, so the patient can have an idea about how his new smile will look like. And then we have the stage 2 mock-up, when it's the preparation mock-up, yeah, the Galip-Gurel technique, when you have a fully printed model with a new design, with the first exactly the same motivational mock-up print, but here you will do a silicone key and you will do a classic mock-up, so you can use it as a surgical guide, or you can use it as a prep-through mock-up, yeah, so you can do minimum invasive dentistry, let's say. There are different ways, but here you can have an example similar to this one, where you have the non-prep teeth of the patient and with the printed veneers on it. You see the accuracy of the print is very high, and that's how the teeth look in the mouth of the patient. Then we have other softwares. We have Exoplan. Yeah, we have Exoplan where you can plant your implants. We can do a lot of things, and it has a lot of features inside. We have chairside exocad software, where you can design crowns or bridges in the posterior area, inlays, onlays, veneers, even whatever you feel like into chairside CAD. And I'm using the program mill1 as a chairside solution for milling when it comes to milling, yes. It's a 5-axis machine that can mill Empress, can mill Emacs, inlays, onlays, veneers, and so on. And what is nice about this is that you can control it by the app on your phone or on your tablet. Then you can use a sinter furnace or glaze furnace from Ivoclar. To finalize, you can also use the lab materials like Emacs Prime, which is my favorite, and SageMax Multi, which is also my favorite. Two materials. This is how they look like. Yeah, and this is the SageMax, which is actually extremely natural and good looking zirconia. This is full contour milled zirconia, and you can see the quality of the layers. And this is what I'm recommending to you. The sinter furnace, that would be ideal for every lab or dental office if you're milling also zirconia. And now I want to show you some short cases. This is one of the cases I've done recently. You can see the initial situation, small teeth, abrasion, space between the teeth. We did for this patient the face scanning, intraoral scanning. We did veneers. We printed the veneers for him, and we did some photos just to sell the case. Now the case is not ready yet. We are still working on it. Here you can see the mock-up, only for 6 anteriors. Here we have the preps, how they look like. We tried to prep not more than 0.304 in this case. You see, we can document also the case using the intraoral scan. We have all the possible views for the patient. That's why I like to have everything digital. It's much easier for day-by-day cases to document the cases, and they look nice. This is the printed, this is the milled veneers with program mill1. And now I'm waiting for the final outcome of the case. We are finishing it after coronavirus millennium. I don't know when it's going to be ready, this. Now, this is another case, one of my favorites, when we have the, we need to have gum surgery in this case. She has very old bridges and stuff. This is her initial situation. She has metal, acrylic, composites. We did the planning with virtual articulator, as you can see here. We measured the Bennett angle. We did the functional movements. We programmed the articulator with her own values. We did the mock-up. We checked if the mock-up looks good in her mouth. And here you can see the close-up pictures. Here you can see the portrait pictures, and she was more than happy with this design. So we are finalizing her case too. So this is how you are supposed to be doing all the plannings. You cannot go wrong anymore. Everything is 100% predictable. This is my favorite case. Okay, so this is the case. I see I have a question here. What is a temporary material for the initial mockup? So for the initial mockup, I'm using the printer, the Siga printer, the chairside printer, and we are using the B1 color resin for the printer. So it's a printing material. They are printed veneers for the initial mockup, which is the motivational mockup. For the second stage mockup, which is the one with the silicone key, I'm using the Telio of material from Ivoclar and Tilio Beach 3. Yeah. Now, as you can see here in the first slide, this is the initial situation of the patient. Second step was to take the face scan of the patient. So we have face scan number 1, 2, 3, and 4. Number 1 is with the 2 scan bodies, scan body head and scan body mouth. Face scan 2 with scan body head, closed mouth. Scan 3, mouth slightly open, and scan 4, big smile. Basically, this case was recommended to me by a dentist. He sent to me this girl and he said, look, can you check if we can do some veneers for this case? And I said, okay, send it to me. I will check if it's possible. And then I checked the patient. I did the face scan. I did the intraoral scan. I did the temporaries. I did the mock-up. She was amazed by the mock-up. She loved it big time. And she said, yes, I want to go for veneers. I finished the veneers by myself. And I just asked the dentist to come to cement the veneers. So it was really, he was really impressed because he didn't even touch the lady and he just come to cement the veneers. So this is the beauty of the full digital workflow. Yeah. So next question was, with previous patient, was composite buildups given as an option, so as not to prep anything. She had some composite and we had to remove it. That's why the prep was not really that minimum invasive, if that was your question. And we did also the same way, printed veneers and then the mock-up veneers, yeah? Good. Now, the second step after face scan was to scan the scan body mouth, because the scan body mouth is the one that is going to transfer the position of the maxilla in our face scan. So basically, we are going to have a virtual patient, 100% accurate information as in reality. Yeah, so we have here the intraoral scan. Here we have the face scan with the intraoral scan integrated. On the video number 3, we have the new design. And on the video number 4, we have the functional part of the design. Yeah, so we are also making it functional, not only aesthetic. This is the beauty, that we can create it 100% predictable. Now, this is how you get the transfer from the scan body mouth into the face scan, highly accurate. So basically, you will see that we transfer from the left side the intraoral impression into the scan body, and then the scan body into the face scan. And that's how you get actually every single aspect 100% accurate. What about the accuracy for scanning all on X cases in the mouth? Yeah, I would definitely use, and it would be the only scanner right now on the market that I would use for all on 4, all on 6, because it has the automated artificial intelligence verification jig. Basically, you cannot go wrong with this scanner doing all on 4, all on 6 cases. They will be highly accurate. I did already 4 by myself, and they were being just super easy and super fast to do. I will show you a case about all on X very soon. Now you see how we do integration of the intraoral scanning to the face scan. In this case, we printed the veneers again. We printed the veneers, and this is the outcome, how they look in the mouth. So the main challenge in this case was to do only 6 veneers, and that they will lose themselves in the mouth. So you will not be able to see them and recognize them in the mouth. Basically, you know, when you watch these Hollywood movies and you see these Hollywood actors that have only 6 bleach veneers in the front and then everything is dark in the back. So I said, okay, this will be a challenge for me to make 6 veneers, but nobody will notice that they are 6 only. And here you can see 0.4, 0.5 millimeter printed veneers. And she said, yes, we go for the next step. So the next step is very important reason here. What we did, we have the printed model and the printed dies. I removed the printed dies out and I duplicate them with Shera refractory material. I tried 4 or 5 years ago with different GC, with Ivoclar, and I was failing time after time. But with Shera refractory, which was made specially for printed models, you can have 100% accuracy. So basically, you remove the printed die and you put the refractory die inside, and they fit perfectly. Then, the next step was to make the refractory veneers, layered veneers, only using 1 powder. This is Opal Effect 3, yeah? And then I sandblasted the veneers, I put them on the printed die, and they fit perfectly. How do I know that they fit perfectly? Take a look. By mistake, I dropped them down, and they broke. I take the fragments and I put them on the printed dies, and that's the fit. It's incredible, incredible fit of the veneers done with these techniques. So imagine impression, face scan, printed model, everything digital till now. Dentist didn't touch the case. He didn't even see the patient. And then I finished the veneers, and I just asked the dentist to come to do the trying. And here is the trying, and here is the final veneers in the mouth of the patient, without any intervention from the dentist. Basically, I finished the case, I sold the case, dentist came and cemented. This is the beauty of the workflow, and this is when you have to understand that you can sell even seeing the patients. You have a room, dental chair, face scanner, intraoral scanner, when an assistant prepared to do these kind of things from morning to evening, and send the cases to the lab. Lab send back the printed models, or you can print it yourself over there, and just do the tries with the printed veneers and sell the case one after another after another. Out of 10 patients, at least 4, 5, 6, maybe more you will sell. And this is what you see is what you get. It's not a fake thing. It's not an app. It's not a game. It's not a PlayStation. Yeah, it's reality. It's only one time you work and you have the final result in the mock-up, and you reproduce it again in the final restoration. Yeah, this is the outcome of this case. And as you can see, it came on the cover of the magazine like this. And if you are interested, you can send me on my social media on Facebook or on Instagram your email. I can send you a full article about this case. I will show you another one. Let's see how much time we have. We have time. This is a similar case to the first one, to this one. We had a live patient course in Sweden, in Stockholm, for the Swedish Academy of Cosmetic Dentistry. And here is step number 1. So step number 1, 4 face scans. And the 5th one is the one with the scan body mouth, the one that gives us the position of the maxilla. Then documented the case with intraoral scans, because if you have a daily case, you don't need to take photos. You can just scan it yourself and store the images, make prints. We printed the model and we duplicated the dies with refractory material, because patient didn't want to have his enamel prepped and the dentist didn't want to touch the patient again. In this case, we used the same Shera printer. We printed in the course the veneers. We tried in the veneers, so this is before and this is after. We tried in the veneers, the printed veneers. We close the gaps. We make it a little more expressive, more masculine. And then we created the veneers like this, refractory style. What is the bonding protocol and which cement? We were using the Ivoclar cements, Variolink cements, Variolink veneer. I don't know too much about this protocol, technician, but I think any doctor that works with Ivoclar cements can explain it very clear. You have an iTero scanner which you bought last year. Can the same accuracy be expected? I don't want to lie anything about iTero. I have no clue about iTero scanners. I never got any impression from it. I never did a case with iTero, so it would be bullshit to say anything about it. I can tell you about Trios, it's good. I can tell you about Medit, it's amazing. About iTero, I heard that it's okay, but since I never touched, I don't know. Good. So here are the veneers. This is how we send them to the office. As you can see, we have special boxes with a special membrane, and everything arrives safely. And this is the final result of this case. Again, I was using only one powder to layer the veneers, and a little bit of light inside the ledge to create the halo effect, nothing else. Another question, you want to record the video. Okay, so to record the video, you have to talk with Tamer. Maybe he's recording the session, so you can ask him about this. One more question, do you accept accept facial scans from Belus app. So Belus app, it's fine, it's okay, but it doesn't use a workflow. Yeah, you just get a face scan. I can simply take my phone, use the Belus app, and do the face scan of my face. And the worth of this, it's 0. You cannot use it. Nothing, never. Basically, the scan bodies that you have to bite on it. The scan body mouth will transfer you the position of maxilla. So basically, you will have to have an original face scanner from AFT. Yeah. If you want, you can contact later, and I will tell you all the details about how you can get in touch with the AFT guys and how you can find that kind of face scanner. And from these cases that I show here, you should understand how the workflow it is actually. We don't need just a face. We need much more than that. We need a digital face bow. So basically, that's why we are using the scan bodies, that we have the exact position of the maxilla, because then we can play with the height of the teeth, with the width of the teeth. We can measure the Bennett angle. We can program the articulator, and we can create not only a nice aesthetic, facially guided restoration, but we can also get a very nice functional restoration. Yeah. So we don't talk only about aesthetics, but we talk also about the function. Okay, so another case here, short teeth with some little bit spaces here. This case was done a few weeks ago, months ago actually. And this is actually the real situation with the real dental photography. Yeah, you can see. Again, 4 face scans, 1, 2, 3, and 4, and the number 5 is the scan body mouth. Printed veneers, again, for those who ask me, these are the printed veneers with resin, with a chairside printer, a Siga. Yes, I'm in my Facebook page. Yes, you can send me a private message on Facebook page. Yes, we don't need to use Facebook. We definitely need to use the face bow in all cases. I work with face scanner specifically for this because, as you know, less than 5% of the dentists are using a face bow because it's too much time consuming, it's too complicated, it's expensive, it's blah, blah. Okay, I understand that. But face scanner, it's a kid's play. You can train your assistant to do it, and she will just send information to the lab. Lab will do highly accurate design, functional and aesthetic design because of this. Yeah. Now here we have the mock-up in the mouth. These are the printed veneers one by one in the mouth of the patient. And then this is the second printed model. Once we did the motivational mock-up and the patients agreed that we'd like to proceed, we do the second mock-up using a full printed model with a silicone key. And we use this mock-up not only to prep through, but we use it also as a surgical guide, because in this case, we need to use a little bit of electrocauter to make the gums even for the centers. Yeah. So in this area, you can see how we use the mock-up. Then we did the minimum preps, like 0, 1, maybe less. We barely could see the margins in the intraoral scanner. And here we use monolithic veneers without layering. Yeah, this is answer to your question, Amar, where we use Empress Multi-Bleach 3. Yeah, this is the full contour veneers, and this is how they look in the mouth, just milled and glazed. Another question, amazing, okay, special training. Okay, so when you buy the face scanner from us, the AFT face scanner, we can sell it. We are going to include in the price also one-to-one training for a few hours, so you understand how it works. And if you work with our lab, we can give you also the support for the first few cases, so you can be trained very well to use it. Yes, the question is, yes, they can be milled to 0.3 millimeters. I didn't try to 0.2. With PM7, I know it's possible to mill to 0.2. 0.3, 0.4 Empress Multi can be milled with Program Mill 1, the one we have. Definitely, yes. When I have thickness of 0.1, 0.2, then I'm doing the previous technique with refractory veneers on printed models. Yeah. So when I want layered veneers, I do refractory. And of course, yes, if you have a classic veneers with 0.5, 0.6 millimeter prep, then it's classic. You can just mill Emacs and you can do cutback and do micro layering. Yes, the statistics of CAD-CAM can compare, because look, this one, for example, is just fully contoured, glazed, and milled. So basically, I didn't touch the veneers, and they look decent. So basically, they look nice. But I think the beauty of refractory cannot be beaten yet by any kind of milling machine. Not yet. But still, you can create decent, very good-looking veneers. Actually, this is the final veneers in the mouth of the patient, finally cemented. Yeah, and you can see how they look like. I mean, from Zoom app. What do you mean about that? I don't know. Okay, what about MCXL? MCXL was a good toy. I heard they have a new one now, which is definitely recommended. The older one, I never saw very good results about the fitting and about the quality. So I would definitely go for the new one if it's available, or I would definitely go for Programmill 1, which is a very good milling machine for 5 axis. Yes, they can be used for removable implant-supported prosthetics. Of course, this is all on 6 digital. So here you can check it out. Here we have this case. It was planned all the way from the beginning. So we did a surgical guide. Yeah, we were planning this. We printed the surgical guide here. Then we have the scan bodies in the mouth. As you can see, this was the first case done more than 1 year ago. At that time, I asked the dentist to leave the dies, to leave the teeth on place, because it was removed, the old work, and these 3 teeth remained on the arch, so we left them there to be able to have more accurate scan. Right now, we don't need that, but at that time, I asked for that. I did the virtual extraction. So basically, you can see that we did a virtual extraction. We printed the model. We printed the silicon gum. Yeah, the red one, which is flexible. It's like a real gum almost. And what we did, we milled PMMA here in this case. Yeah, so we tried in, and then we can finalize the case. We can use metal with zirconia. We can use Pecton with Emacs. We can use full contour zirconia. So there are many different types of finishing this kind of case. As you can see, all our patients are virtual patients. Yeah. So once we start the planning, we have the face scan, we have the intraoral scan, we have the CBCT, we have the soft tissue, hard tissue. Basically, we can be extremely accurate how we do our case. And there is no way that you can fail or you cannot do a predictable case. And all on 6 here, the dentist left 2 hours for the try-ins and everything. And after 5 minutes, he was calling me on the phone, telling me that, you know, I finished in 5 minutes. Now I have almost 2 hours free time. It was incredibly fast and incredibly accurate. And the impression I took myself with the Medit i500. So yes, Medit i500 can do this kind of cases, not only for prep or non-prep cases, but also full mouth rehabs. Empress CAD definitely better than Emacs CAD from my point of view. Why? There is a simple thing, and I learned this from Florin Kofar. Imagine that you are not very good with the functional part. Let's say not every dentist knows too much about function. So let's say you are an average dentist and you want to make sure that everything that you do in the mouth will be safe. What do you choose then? You will choose full contour zirconia? No, because full contour zirconia will destroy your TMJ. You will use Emacs. If something is wrong with the functional part, it will still affect TMJ. But if something is wrong with the functional part and you use the Empress is not that strong. So it will break. If you have a breakage, it's happiness because you know that you did something wrong. You will check where you did something wrong. And you have the file, you just have to remill the veneer and do it again and fix the problem. So that's basically, it's going to be a marker that can help you understand where you did the mistake. Yeah. Somebody asked me, what is the facial scan? No, where is the question? You do virtual occlusion? Yes, we do virtual occlusion using the virtual articulator with the Bennett angle. How do you record the Bennett angle and the functional movement? If you are not using the jaw tracking system, very easy, very simple using the face scanner, the AFT face scanner. There are some trainings we do for the lab part because the dentist doesn't need to do anything. He just needs to take the face scan according to our trainings, and then everything will be done in the lab. You can measure the Bennett angle directly from there. It takes a little bit too much time, but we have the online course launching next week, hopefully, with full digital workflow, so you will be able to learn also the dental lab part over there. How about BOHPP and Invisalign? Are they good materials? BOHPP I would never use. I was trained to work with it, and it has a very limited situation when you can use it. So basically it's very elastic, and you get crow fissures of the composite when you layer the gums, and it's not good. In time it looks very, very bad. I stopped using it after less than half a year. I had more than 6 patients with broken bridges, so I quit completely. I still like Invisalign from Redent, and we use it with Pecton or we use it on metal frames. How accurate scan bodies for All-on-4 compared to analog technique with verification jig? So basically, if you were listening from the beginning of the lecture, we are having in Medit i500 the digital verification jig, and it's highly accurate. So it's super accurate, maybe same if not better than analog technique. I don't use verification jig anymore. I just use the digital one. So we do only full digital impression technique. I'm using Exocad. It doesn't have an annual fee, and it's more easy and more friendly to use, even for beginners, even for advanced. You can do very good things. Yeah, I see a lot. Yeah, exactly. Mesh mixer, I use it with the CBCT. Yeah, I just explained in the beginning of the lecture. So basically, if you watch the video, recorded video of this lecture, you will understand how we use the mesh mixer. I will show you now a full mouth rehab. What is my opinion about the DSD app? DSD app, I think it's a very great sale tool for the big clinics. When you have a lot of dentists and assistants, they can sell a lot of cases for you, do the motivational mock-ups. It's a very nice and engaging app to create cases and to sell cases. So I would definitely go for it. But if the patient comes and he really wants to start right now, work, go with FDB, with work. So this is the case we had. This is the splint that we were using for this patient. To create the splint, we had to open the bite, and we wanted to make sure that when we do open the bite, we don't do the translation of the condyles. So we had to use a full mouth CBCT where we can see the condyles, and we open the bite with special markers in mesh mixer. And then when we were sure that it's good position, then we created the splint, yeah, in this case. And that's how we got actually the bite of the patient. In this case, this is the initial situation of the patient. Here you can see how we overlay in mesh mixer the intraoral impression and the CBC. Can you see us again? Exoplan system. Exoplan system. Yes, Exoplan system, I didn't work with it yet. I just participate in some lectures about it. It's a great system. It looks very promising, and it's compatible with more than 2,500 platforms. So I will definitely go for it. But when I will have more details about it, I will come back. Good. This is how you send then the information into Exocad. So basically, I have the scan body mount, intraoral impression, and CBCT, and I transfer all these things inside the face scan. Somebody else. Lab location. My lab location, it's in Romania, in Timișoara. I can write for you the website. That's the one. And this is another one. Okay. Now let's go to the lecture. Here we have the beginning of the designing. Here you have the design. Yeah, thank you. Information, yes, because I really like that somebody takes something away and can apply it very next day. This is with the ExoCAD web view. You can see on the right side of the screen, this is how we sent the case to the dentist for approval. And you can see that every patient has the CBCT, face scan, and intraoral scan. Of course, we don't need CBCT for veneers, not for most of the cases. And all of our use of planning. We send this to our dentist to check, prove, ups. In this case, we have the pictures before and then pictures with the mock-up. In this case, we printed the models, full models. We did the silicone key mock-up because we needed to use this kind of mock-up for surgical guide to
Milos, are you here? Milos, I cannot hear you. Okay. Okay,
now.
I see you now. I see you now. Okay.
Perfect. So
can we answer some questions?
Oh, I was answering all of the questions in the chat till now. So everybody has the answers already, and I told everyone if they want, they can just send me messages. Yeah. So this is how you can contact me on Facebook or on Instagram. My new website, dentalpromaster.com, where you can find my online courses and a little bit of information about the book about dental photography that you can check out and learn everything about dental photography, also about the full digital workflow, few tips and tricks. I hope this lecture was great for you. And we still have 3 minutes. Maybe I can show you very fast this case. The last one, this is a very nice case that I did with Jan Kurz-Hoffmann from Germany. We just finalized this case in a live course, live patient. We did this in just 2.5 days, 3 days. Initial situation, intraoral scans, face scans, printed veneers, exactly these ones that I have here with me. And then we did the trying in the mouth using the printed veneers, as you can see here. We did, and we checked that it's functional, pictures before and after with the printed veneer mock-up. This is how we did the motivational mock-up, and we sold the case. The patient was delighted by the quality. And then we proceeded for the final veneers. Yeah, which I still didn't finish my lecture here. So basically, this was the final outcome also with final veneers. Yeah, we used a lot of different techniques. Yeah. This is my lab information for everybody who wants to know. www.dentaltech.ro. Tamer, any questions?
Okay, I have less than 5 minutes. So do you think when will be the time to use printed stuff, printed veneers, printed restorations as a final restorations, not as a temporary or for the mock-up reason?
It's already possible. Yeah, there are still on the market. They just came out the printers that can print zirconia in the layers. But it's still a little bit prohibitive because it's a little bit too expensive. 270,000 euro for the printer, so not everybody can afford it. But in the next 2-3 years, there will be a lot of printers that you can print directly the final outcome. Also, let me give you one more information. We still have 2 minutes. Look here. This is something that we were able to create in our lab, very easy, and you can create it in your office too. This is the simple foil for the office, glasses that you already have in your office, and we printed those attachments that you can put on any kind of glass, yeah, and you can create your own mask like this, yeah. So basically, all you need is to attach these things on your glasses here, and you can transform them into a protective mask when you work with new dentistry age, let's say the COVID age of dentistry. Yeah. So everyone
This is so helpful. Yes, yes, yes.
can print those. Yeah. If you need the files, you can find them on my Facebook page. I have the link over there where you can find the STL files. And if you have your chairside printer, you can print these little attachments so you can use them and create this helpful mask.
Thank
I
you
hope
so much.
everybody enjoyed.
Yes, yes, we enjoyed this a lot. Fabulous work, fabulous documentation. Thank you, Milos, so much. Now I'll jump to UK, okay? So
Yes,
goodbye, Romania. Thank you so much. Thank you so much, Milos.
Thank you.
So, Professor Eileen.
Hi.
Hi, how are you doing?
How are you? Good, thank you so much.
Yes.
I've been waiting for some very good lecture, really good.
Yes, thank you so much. I think you should raise the voice a little bit more.
Okay, I do it. How is it now?
Yes, it's much better now. How is everything in UK? It's still the voice. I don't. Yeah, this is now it's good.
Yeah. So yeah, no stop working. There's a background noise, I think, by someone. So yeah, everything is very good. How about yourself?
It's good. We are in full quarantine. We are locked up, but I think we should keep looking to the positive side. We should be always positive. It's a chance to learn, to relax, to join the family. So I will not waste your time. We are expecting a very nice and informative presentation. I leave the virtual podium for you. If you can just raise the voice a little bit. I think we have a little problem with the voice, and you can share your screen up with us.
It doesn't allow me to share. You can. I cannot share it actually.
I think now you can do.
Let me start. Yeah. Excellent.
Okay.
Wait a minute. Wait a minute. It became so small. Everything became so small. So what happened here? Sorry, guys.
If you can just go to play.
Maybe.
Yes.
Let me see. So can you see now?
Yes. Yes. Just if you can raise the voice a little bit.
Voice. I don't know why my voice is.
Okay, maybe you should be closer to the screen where the mic is. Yes.
Like this. Okay. So is it everyone is clear there? Wonderful. So shall I start? And
yes, you can start.
Yeah. Hi everyone. Is it clear now? So after this wonderful lecture, I hope you will enjoy my endodontics lecture. I'm a passionate believer in endodontics, and I hope that you are keeping well and safe. So let's start with my lecture. I hope I will be, up to the previous lectures as well. So let's move on. So just wait a minute. I can't go to the next slide. So my learning outcomes in this lecture will be, I really want all the participants today to understand the importance of risk assessments at all times, and then explore the prevention strategies. Once we have the complication, we need to be calm and collected and then carry on, and then enhance our knowledge in complications and how to overcome them. So if we start with different stages within the endodontic treatment, we can have complications such as when we do the restorability assessment. If we don't see our risks ahead, later on we can come across with complication. And then during the excess cavity, of course, I will discuss this in a minute, how we can come across with complications and how we manage them. Also, during the root canal treatment, we can have some risks and end up complications as well. And at the same time, what we can do is when we do the irrigation is the essential part of our root canal treatment. Again, we can have some complications. So, after the excess cavity, how about the root canal preparation? What are the complications ahead? Even with the obturation, what is the sort of risk involved? And after the obturation, post root canal therapy as well. So let's go them by one by, without boring you. Restorability assessment. First of all, we need to think why we are doing it, why, and how, and which tooth, and when. So we need to think about all these questions in our mind because we have risk ahead there as well. So what do we need to look for endodontics? You need to think about, after the root canal treatment, can this tooth be in function? So think about your sound tooth tissue, remaining of the tooth tissue in crown, and at the same time on the root surfaces. And also the condition of the periodontal health. How about the bone loss? How about the mobility, the occlusal considerations? I mean, if you have a look at this tooth, so immediately you may say, okay, if I do the root canal treatment, is this tooth going to be in function? Yeah. Then I am sure you will prevent the complications. I love SWOT analysis. I don't know if you know, SWOT is used for business, all business companies and financial, companies, but we can use SWOT as well in dentistry and even in your personal life. Whenever you see a tooth such as this one. Okay, when you discuss the treatment options with your patients, why not think about SWOT analysis? What are the strengths of your treatment? What are the weaknesses? How about the opportunities? And what are the threats? What are the complications you are going to face when you do a treatment? So what do you think about this tooth? I mean, this is, you see, there's bone loss there, there's a long, chunky posts. Obviously, there is some sort of perforation here, suboptimal root canal treatment, it is a breech abutment. So are we going to save this tooth? Immediately, SWOT analysis. During the root canal therapy, what can we have here? So if we are going to have a molar endo, I mean, we love molar endo, right? All of us. So what are the risks here? So let's think about it. Immediately, when you see a molar tooth or premolar tooth, so main posterior teeth, you can consider that kind of orthoband or molar band if there is one marginal ridge missing. And this may be, you may say, of course we remove the dental caries, but sometimes, we clinicians, we just want to enter the root canal treatment. We want to start the root canal treatment and we ignore that dental caries at the margin or at the proximal parts. What happens is coronal seal is compromised. if we do this, you know, if we use that kind of molar band, in the picture it's shown, we can prevent the tooth fracture. So you will not have that kind of fracture, vertical fracture, and complication ahead. So everything we do, we need to have the risk assessment and then prevent that complication. And if it happens, I will give you this kind of like root fracture. If it happens, there is no going back. It's irreversible, but you can prevent it. So when it happens, I will discuss later on during root canal treatment how we can overcome. Excess cavity preparation. I mean, the first one, to be honest with you, I hope it never happens to you. But if it happens, if it ever like you are extremely busy, something happened to your, and you had so many patients and this happened, immediately we need to inform our patients. We have to be honest about them, and we have to manage that tooth. To prevent, what you can do, you can speak to your dental assistant, why not, and say that, can you please remind me which tooth I am doing for that specific patient that I am doing the root canal treatment. Or just, you know, print out the pictures of the tooth. You have intraoral cameras nowadays in practices, and then print out your radiographic image as well, or just put it on your screen and see that, okay, I'm going to do this tooth. So it's prevention, right? And failure to remove dental caries, it's a big issue. You may think that sitting there at your homes, oh, what is this, you know, Island Bison is talking about? But genuinely, you know, most of us are eager to do some more intervention, you know, surgeries, root canal treatment, and dental caries. We think that it's okay, you know, just a little bit decay there. It is not. This is a compromised coronal seal. And what happens is when the patient comes with symptoms, maybe increased symptoms, and I said, no, I did my root canal, I started my root canal treatment, I did my irrigation, I don't think so there is anything wrong with this tooth. But when you look at the radiographic image, or when you look at clinically, you see that there was a caries lesion and the seal was compromised. Okay, damage to extraoral coronal restorations. This is again communication. Dentistry is, of course, we love our manual dexterity and we want to do. Now, when we are sitting at home, we are eager, right? We want to do something, but communication is our gold sort of material that we need to hold. When you start doing a root canal treatment on a tooth that there's an extracoronal restoration, metal ceramic crown, it doesn't matter, and you are going through this crown, then communication. Just mention to your patient, look, I am going to do the root canal treatment through this ceramic because you had this ceramic recently and it was so expensive and there is nothing wrong with it, but the tooth is non-vital and there is an infection at the end of the root. We see this, right, in our common practice. And you say, I'm going through it, but just in case, I am warning that you may have to replace this extracoronal restoration. Then the patient is clear, right? And they are expecting that it may something happen to that extracoronal restoration. However, if you don't mention and say, okay, I'm going to do the root canal treatment, and then this happens, how you are going to communicate with your patient, right? So later on perforation, I will discuss with my next slides, and tooth fracture, I think I covered, especially with the posterior teeth. Please think of some sort of support, as I mentioned, with orthoband. If you don't have the orthoband, with the molar band. Okay. Yes, of course we can manage. How we can manage is with well-designed excess cavity and retaining tooth structure where possible, and with good communication, clear communication with our patients. Now the irrigation and complications. Irrigation with sodium hypochlorite is our gold standard in endodontics. We cannot avoid this at that stage. Okay, and you may be wondering why I put these pretty pictures Yes, I have some pretty pictures in endodontics lectures as well. So I have this red parts areas and the green areas. So what I am showing here is the red parts are the ones that not reached with your mechanical preparation. So it means that you use your rotary files, whatever you use, or maybe single system, it doesn't matter. Whatever you do, the mechanical preparation is not going to clean these areas. So you need your irrigation. Okay, fine, irrigation, but there may be a complication. I'm not going to get into details with that slide. I just wanted to put it. I don't want to scare you as well. I am sure you have seen these in the textbooks, and I don't want to be that boring. But what I say is, yes, there is a possibility of sodium hypochlorite incident, right? Okay, so how we can prevent this? Prevention is the key here, like everything in dental diseases, to be honest with you. Rubber dam, no rubber dam, no endo. And I am aware that some parts of the world are still not using rubber dam. And I am not sure how you can do a root canal treatment without rubber dam. It doesn't make sense. So essential armamentarium for root canal treatment is number one. Of course, you need the patient, but second, rubber dam. Isolation and optimal coronal seal, this is your deal, because it is essential, as I mentioned, and if not done, malpractice. Why we need this rubber dam? Because we are dealing with sodium hypochlorite, we are dealing with instruments that it may, it can have an ingestion, and also saliva. For infection from the saliva, better access, comfort for the patient. And if you notice, some of our patients, they love to talk, right? When you do your treatment, they want to talk about their personal life, they want to chat with you, but you don't want to do this. You want to just get on with it. And it's a medical legal requirement as well. This is, I'm sure you know, Oracil is like my, my next sort of material after the rubber dam. I love Oracil. It protects, it seals very well, and you don't see any sodium hypochlorite leakage as well. Great. We have where I work, we have a very safe, I am very into protocols, and we have a very clear protocol on safe and effective irrigation. What is it? Side venting needle. If you love endo and if you want to do more endo in your practice, side venting needle. And we shouldn't bind the irrigation needle in the canal. So just gently use your irrigation like, you are doing a meditation nowadays at home. If you are doing the meditation, just gently, never excessive force, inject. So we are not in the gym and working out. Very gently use of irrigation solution. And the ideal needle is 0.40 millimeter, an external diameter of this. And please use high volume suction with surgical tip. So the surgical tip is not only for periodontal surgery or implant surgery, it is for endodontics as well. And to have an effective irrigation, every time you change your instruments, such as, you initially, you had your excess cavity, you did your, you are just investigating negotiating your canal orifices, immediately 2 to 3 milliliter of irrigation. And then every time you change your instrument, again, 2 to 3 milliliter irrigation. With that way, I promise you that you will not have issues with flare-ups, with, continuous symptoms with your patient. Irrigation is the key for of course, mechanical cleaning important, but for removing the biofilm and for removing the infected tissues and microorganisms. If you are doing couple of stages of root canal treatment, first stage needs to be really concentrated in the irrigation part. Of course, you can use chelating agents such as EDTA as a lubricant as well, for curved canals and fine canals, and for any canals that you are going to introduce your rotary instruments. Okay, so let's move on. This time, root canal preparation and complications. So I hope that it is so far is clear for you, and I'm going to accept the questions later on. But let's move on to the canal preparation and what kind of complications we could have. Initially, I wanted to start with positive part of the endodontics. So if we have any kind of magnification, we can really, I'm telling you, eliminate or reduce the complications. And you may say, oh, in my practice, I have a microscope, or I don't have a microscope. Then how about the loops? There are wide ranges of magnifications available in the loops nowadays. Why do we need this? Because missed canals can cause complications, especially with the upper first maxillary molars, right? Untreated MB2 canal for these maxillary molars that were often overlooked without magnification seem to decrease the long-term prognosis. So you may find the MB2 with your magnification, or if you cannot locate the MB2 and there is an MB2 there, your patient will have, soon or later, will have a complication. So procedural errors in endodontics. If we have the incomplete debridement, what happens? Of course, short working length and not sort of to the point of cleaning the canal, missed canals and continuing infection. Patient has symptoms, and the symptoms can get worse as well. In that part, you may have an obliterated canal that you cannot establish the patency. Then the best approach is irrigation. Do irrigation as much as you can, even if you cannot reach your apical patency. Or just an error that you didn't notice about the working length determination, and you don't use your electronic apex locator, which I highly recommend it, then you will have a problem later on. And then you may say, oh, what am I going to do? I have a complication here. Missed canals, I think we confirmed. So magnification is quite important with the missed canals. Perforation, there are different types of perforation which can make our lives as clinicians a little bit challenging, but the issue is again prevention. However, if we have the perforation, I will just discuss in a minute how we can manage these perforations. And of course, zipping and transportation as well, I'm going to cover in a minute. Ledge formation. Of course, we don't want to have this ledge. You know, isn't it? You know, you just started your root canal treatment, and then you had your working length radiograph, or you use your electronic apex locator, everything going perfect, and then suddenly that ledge. From my experiences and teaching over 20 years, I tell you, yes, sometimes ledge is, you know, unavoidable. But however, if we are calm, patient, we introduce the instruments carefully with a sequence. There is a sequence. The rotary instruments are great. Single file is great. But the thing is, initially, we need to have the tactile sensation. We need to have that pathway, our root canal system pathway, and then we can introduce our rotary instruments. So without establishing your pathway, if you try to introduce your rotaries, you may have a really ledge like this. How we can, okay, what is the solution then? What we can do is immediately stop. If you feel that your instrument, your files are not going to the desired length, don't force, especially with the rotary instruments, because this will make your life more miserable. Stop, calm down and say, okay, I need to immediately, these are all happens in 10 seconds in dentistry, right? It's not going to stop and calm down 10 minutes. So stop and I say, okay, I'm going to irrigate now and see if there is any debris, etc. coming through, and I will immediately move to my patency filing, size 10. Yeah, so K-flex size 10, patency filing, try to negotiate that ledge, and very gently, size 10, using EDTA, copious irrigation, and then introduce your rotary instruments. But please, the rotary instruments make that ledge worse. Okay, so let's move on. Apical zipping. This is a big thing and part of the endodontics, especially with inexperienced clinicians. And of course, if you are using just two-dimensional conventional radiography, it is not going to show on the two-dimensional radiography. But what happens is you are changing the whole apical region. We have here apical constriction. We want to complete our root canal treatment there with this zipping and elbow formation. This area is all changed and it is widening, undesirable widening of the apical constriction. Unfortunately, this is an irreversible change, but what you can do is once you have that over sort of preparation part, you need to be careful when you do your obturation. So with your alternative obturation techniques, if you are using warm vertical compaction, you need to make sure that you are not you are 1 millimeter away from your radiographic apex, because you already widened this area. So if you are not careful, your obturation will be extruded. Then it's a complication, right? So one complication can bring another and more complications. Once you notice that, okay, this happened, and how you feel it, you feel with your tactile sensation and with your files as well. When you place the files, say your master apical file or your master GP, desired master GP is not going to fit there because the area is enlarged, widened. Then you say, okay, I need to make sure that my length is very well determined and my obturation is going to be at the level, that desired level that I want. Ideally 0.5, 1 millimeter away from your radiographic apex. All right. Strip perforation. At this case, you can see on this picture, this is again irreversible. It's really large area, so you need to really ask a question. Is it worth to repair this? There's a breakdown here, furcation area. As we know, when there is a breakdown in the furcation area, the survival rate of these molars reduced. So you need to ask your question, is it worthwhile to do a repair in this case, or am I going to do the extraction? If you come to the extraction sort of plan and management strategy, then you need to clearly communicate with your patients, even if you cause the complication or another dentist caused the complication. It's not the case that to discuss what previous clinician done ethically, it's not correct. But what you can say is, I wasn't there, I wasn't in that position, but how we can help you, these are the management strategies for you. So if we say, if there's a complication there, and if we are going to manage this complication, we need to complete the story. We cannot say, okay, this is an extraction needed in that area, but how about the replacement options? Okay, if you are an endodontist, you may not want to do the whole restorative management in your clinical dentistry, but we need to give a clear pathway for our patients for their mental stability. Otherwise, they will get worried. Okay, extraction, what am I going to do? How am I going to fill this space. Okay, so if there is a complication, it's fine. Just clearly explain to your patient and manage the situation. In this case, this was a referred patient by one of the dentists to me and saying that, could you do the root canal treatment? To be honest, when I looked at it, I said, okay, there is lots of wrong things in that tooth. I mean, I wouldn't jump in immediately to the patient to say, yeah, yes, I can do your root canal treatment. I can save this tooth. No, just collectively, okay, I need to do my clinical examination. So with the clinical examination, I know our lecture is about complications, but it is important to understand the holistic approach with the root canal treatment, with endodontics. So immediately you check the periodontal support here, because, you know, you say, there is something here that for endodontics, they are asking me the root canal treatment. Of course, I don't have the periapical radiography initially, but I need to do my clinical examination, and clinical examination involves the periodontal examination as well. That the crown looked fine, but however, when I looked at the 6-point pocket chart for this tooth, there was a 9 to 10 millimeter pocketing at the mesiolingual and midpoint at the lingual side. So immediately this gives me a sort of alarming notification. Okay, there is something going on there. Why the rest of the periodontal support is good, but however, at that one point, there is a 9 to 10 millimeter periodontal pocket breakdown. Immediately, okay, periapical radiography, and then periapical radiography, we see this part. So what is it here? There are quite few issues here. The issue is, look at this area. Why we have this furcation area there, radiolucency. So it shows something, and it sort of complements my clinical examination as well. And then large root canal obturation, root canal preparation and obturation. So I go back again, I check it again. When I touch with my periodontal probe, WH probe, at that lingual side, I see like something is catching there. And I say, there is no way that this tooth can have root canal treatment. And then extraction, of course, management strategy involves following the extraction. What are the replacement options? You can just briefly discuss fixed, removable. Nowadays, of course, we go to the fixed option if there is a available bone and financial situation of the patient. And then you discuss these advantages and disadvantages, and then you extract the tooth, you see this. I mean, why we have to do that kind of over preparation? Nowadays, our rotary instruments are very effective, so we don't need to do hundreds of times preparation with our files. And also, please, just remember that canals are not often located at the center in mesial roots of maxillary and mandibular molar teeth. However, located close to the furcation. Then what is the prevention? We have a prevention strategy as always. Anti-curvature filing, so away from the furcation wall and just avoiding the over preparation. So perforations of the root canal, burrs in floor of pulp chamber. How can it be avoided? This can be avoided. How? Firstly, we need to understand the complexity of root canal treatment through the crown. Once we have the crown, as you know, the preparation, etc., all the orientation of the pulp chamber, the canal orifices change in a way, because we wouldn't know exactly where is the mesiobuccal cusp with the initial tooth, where is the mesiolingual cusp, where is the distal canal. So this is we need to appreciate. And if you think that you have the knowledge, experiences and expertise to do the molar endo through the crown, okay, it's fine, you can do it. And then the anatomy of this area is quite important. I mean, the burr is just, you see, this is a burr, isn't it? Burr sort of preparation towards the furcation. What are we looking here? There is no root canal treatment there. The root canal, there is no, root canal system there. One root canal system here, mesiobuccal, and the other one is just parallel to the mesiobuccal on the other side, mesiolingual canal orifice. And then the distal is just on the other root. It's nothing to do, nothing is there. There are lots of accessory canals here, but there is no root canal system there. So knowledge in anatomy, another important point as well. Post-preparation. Firstly, do we use posts in our clinical practice routinely nowadays? I mean, I did my clinical training for 7 years in restorative, including endodontics, etc. And I rarely done posts in the anterior region and even in the posterior region. It's okay, there is an indication. But what is this? You know, there's no root canal treatment here. And then this post is, of course, there's no root canal treatment. I don't really understand how we can have, without the root canal treatment, we can put the post. And then, of course, post is misaligned here. So how we can prevent this? This is a complication. And if the patient comes like this, what we can tell our patients? What we say is, okay, what I will do is I will dismantle the crown and the post and assess the restorability. If I can if I can restore this tooth, repair can be an option, but there is a here breakdown of, again, periodontal support here, you see. And then if I can repair, then you have to do the root canal treatment as well. Or on the other hand, extraction, unfortunately, and discuss the management options for replacement of this tooth. But these can be prevented, as I mentioned to you, like the burrs in the floor example, anatomy, understanding the anatomy, choosing the materials correctly. So do we need that post? Definitely, for that chunky post, short post on the tooth. So these are the questions that you need to go through when you start seeing a patient that requires root canal treatment. Perforations of the root canal treatment. So here, diagnosis. Once you have the excess cavity and then you negotiated your canal orifices, immediately you see this bleeding, but it's a different type of bleeding. It's not like infected vital pulp bleeding. It's just non-stop. You will feel it. You will feel it. It just doesn't stop. With your paper points and patient, when you try to negotiate your canal orifices, patient has immediate pain, and it's a different pain. It's not like infected canal orifices you touch and then patient feels like a soft tissue type of pain. Okay, and of course you can have that kind of instruments just outside the excess cavity. To be honest, I don't understand the reason of this radiograph, because when you do a working line radiograph, you ideally place all these files. It's not only one file. But maybe they were thinking of what is wrong with the tooth. This is why it just happened. I cannot communicate. This is not my radiograph. I'm just trying to explain to you what happens with the perforation, especially with the furcation area. And also, if it happens, the perforation happens, and then the dentist didn't notice, or you didn't notice, after some time there is a breakdown wherever is the perforation, as I showed it to you in my previous slide as well. and there will be a radiolucency around the either furcation area or around the root, in the root that they had the perforation. So these are the diagnostic sort of aids for you to understand what is going on there. Treatment, okay, management-wise, you had this complication and you say you had so much bleeding, and what are you going to do? Best approach is reassurance and communication with your patient. Say that, look, this happened, and I'm going to assess if I can restore this tooth. Of course, prevention at the first place, but it happened. It's a complication. It can happen. It can happen to anyone. If it didn't happen to you, this means that you haven't done enough endodontics. You haven't treated enough root canal treatments. Then, okay, am I going to restore this tooth? If I am going to restore, what is my aim? The aim is sealing the area. Seal is the deal again to prevent the infection. And also, is it in your capability? Do you think that you will be able to do that repair? Or would you like to refer to a specialist? Or even you are a specialist, do you think that it is not in your sort of ability, that you don't feel comfortable? Just you can refer it. Nowadays, the materials are mainly GIC and MTA, mineral tractide aggregate. And what are we trying to do here? We want to have the success, right? Even if there is a complication, the management, we want to have the success for our patients. Otherwise, the patient is going to lose that tooth. What are the factors affecting this success? So the earlier is the better. If you notice and if you have the ability to repair it, please repair. If you can't repair it, and if you have anyone else in the practice that they are experienced than you, just speak to them. If you are in a hospital environment, immediately speak to your superiors, leads, etc. Size, the smaller is the better to success. This is a common stance. And location-wise, below crystal bone and away from the canal orifices, you will have more chance to have a success. Excellent. So I just wanted to give you a few examples here. I want you to concentrate on here. So do you think what is going on there? We have a post here, and there's something going on here, right? It's a little bit radiolucent and it looks over-prepped. Obviously, they were looking for post-placement, post-preparation, and then why this is so much over-prepped here? Why we have to use these gooseneck burrs, etc., to remove the GPs for our posts? And then, of course, this happens. This is a perforation. This is a large perforation. Okay, immediately patient felt symptoms. She was so symptomatic and she couldn't sleep. It was so painful. She was very close to the complaints. And then from another angle, with this time, so the permanent post is taken out because it wasn't very clear why the patient has that much issues. And then temporary is placed. Of course, there was bleeding, but they thought that if we can put the temporary, it's not a very good practice, to be honest with you. And then what I did is I removed this temporary. I assessed the situation here. I feel it with my instruments, especially with the again WHO probe, and under the magnification. Without magnification, I don't know, you must have like wonderful eyes or bad eyes or something that you can do. I can do, maybe I'm getting old, but I cannot do a perforation repair without magnification. With magnification, look, vision, and of course, elimination of the blood from that area, because you need to have a good vision there. Use a type of material at that stage, you could use an MTA. It's below the crestal bone. So I used MTA and repaired. So in that case, we managed, and then the student did the post-core, and I mean, ideally, I wasn't very keen on the post-core, but they started, never mind, post-core and metal ceramic crown. I think it's not only ceramic crown. So the patient is happy, didn't complain, everything went well. So what is the lesson from this example? The lesson is initially, of course, the prevention, but when there is a complication, instead of, you know, we just leaving and see if, you know, the nature heals this, you speak to someone that can help you, or yourself, you can do the repair. If, okay, you may say, if the repair wasn't successful, what are we going to? As we mentioned, the last option is the extraction. Okay, another, this is just to have an example. This is not my case, but I just wanted to show that mid-root perforation repair here, using again MTA, and after 27 months, it works and the tooth is still there. So there is of course, a possibility that repair works. As I mentioned, the success factors as well. So the complication, yes, we don't want the complication, but when there is a complication, we have ways to deal with it. So we shouldn't be very nervous and say, no, I don't like endodontics, etc. I mean, I love endodontics, and people think that I am a little bit mad. Maybe all of you are like me as well. Okay, separated instruments. So, separated instruments and root canal obstructions at that stage. So how we can avoid this? First of all, as I mentioned to you again, I have very limited time, but it's coming to the end. It's again prevention. Okay, we couldn't prevent and happened. Preferred choice is removal. And ideally, at the coronal part, you have more chance compared to the mid portion, and the apical portion is impossible. So don't promise your patients at the apical portion with non-surgical root canal therapy that you are going to remove that separated instrument. If you need to remove it, because sometimes you can bypass separated instruments, or you can accept that instrument and you obturate your root canal system afterwards. Maybe if it is the separation is done after your preparation and irrigation, the success is high there. But if you are at the just like initially you just started your preparation and separation happens, the chance is a little bit lower compared to the previous stage that I mentioned. So here, what is the aim? The aim is to remove the obstruction without unnecessary removal of canal walls, because while we are trying to rectify that complication, we don't want to cause another complication such as perforation, right? Or such as extrusion of this material as well. So complication comes the double. We don't want this. And as I mentioned, the important to remember, if you have done the cleaning, as I mentioned, it has a better prognosis if you cannot remove that separated instrument. So removal of separated instruments, the armamentarium, if you can have it in your practice, maybe you may not have all of them, but if you ask me what you need for essentials, definitely magnification, some sort of form of loops, if you can afford, if you have it, use this daily practice, microscope, operating microscopes. I use this for my daily practice. And then other parts as well, tweezers. At the coronal part, you can pick the file sometimes, and burrs, you may need it. I rarely use it really, but sticklets, forceps, I'm going to show the picture to you how it looks like. The essential is ultrasonic. definitely you need P-zones, these endodontic tips that it will help you to remove the separated instruments, and also for re-root canal treatment. So if you are doing lots of endodontics, I think you need to invest for one. And braiding of headstrong files may help as well. I'm going to show you, and different types of post-removal kits as well. So sticklets forceps can help you once you identify, you visualize the separated instruments. So this means that they need to be at the coronal part. Otherwise, you are not going to sort of retrieve that separated instrument. Braiding, if you have a silver point and fractured, in the UK 15-20 years ago there were lots of silver points. I'm not sure in other countries they have, but nowadays luckily we are not seeing anymore. If you have any separated silver point like this, the headstrong files, braiding headstrong files can help you to retrieve this silver points. And then tie to screw wrench to unscrew the fractured post or egg-lar post puller. Of course, you are not going to have all these equipment in your practice, but if you want to choose one of them, Masaran kit that we have at our workplace. So if you wish to purchase any of them, it is helpful to remove the posts like this. You can see in this picture, but as you can see from here as well, initially you need your ultrasonic tip to sort of disengage that post from the dentinal walls, because you have cements here, so you can disengage these cements from the dentinal walls. Okay, finally, obturation related complications. Yes, we are aware of there are some complications, but we can have troubleshooting guide. How? First of all, we need to know when to obturate. If we know these 4 factors, that if they are, if the root canal system is dry, and then if your preparation is complete, if the patient doesn't have any symptoms, and if there are any sinus or swelling, there is a resolution in this. So if you follow these steps and do your obturation, I don't think so you will have a problem. But if you just ignore all these factors and then you just want to obturate, you will have a complication, because the patient will feel still pain, symptoms, the infection will be within the root canal system as well. And then 3 factors that we look for optimal, satisfactory obturation. So if we think about the complications, if we don't respect the length, if we don't have we discuss the length determination, then of course you will have a complication. You will have a short root canal treatment like this, or you will have an extruded if you don't determine your length very well. Nowadays, with the alternative obturation techniques, we are not having so many voids, which is great for us. So I'm sure you will eliminate this with your obturation technique. And taper, as I mentioned to you, with the rotary instruments, if we overdo everything or if we underdo our preparations, you will have a problem with your taper as well. Of course, taper is not going to maybe directly affect your appearance of your root canal treatment that much, or immediately your success. But if you left with your under tapered root canal system, if you left any infected tissues, then you will have a problem. Or with the over preparation, you may cause a perforation as well. So these are all preventable. Just to give you another example again. So we have this molar tooth up to working gland radiography. It looks fine, and something happened here. So here we were fine, here working gland radiograph, and then what happened here there? So extrusion and apical transportation. This is again not sort of following the steps for working length determination and then definitive length determination and then extrusion with over preparation as well. So as I discussed previously, these are all preventable. And then even at that stage, the master GP radiography stage, this could have been preventable, but it wasn't noticed very well, I suppose, and ended up like this. So extruded. Now we have a apical transportation. It means that the apical constriction is not there really. It was over there, and so it's not the tooth is not obturated to the apical constriction, and there is a large area there. So we need to see the infection area there. So we need to see if this patient will have issues later on. So at that stage, even with our Combeam CT, we noticed that there is an overfilled area there. We need to monitor our patients, and the management wise, if the patient has symptoms, luckily so far they don't have any symptoms, but if they have symptoms, this means that we need to do the re-root canal treatment. But this could have been preventable because look, at the working land radiograph, everything was fine. So again, you know, impatience, not respecting the length determination, even with the master GP points, rectifying the issues. These are all, we shouldn't rush. We just need to be patient and be collective. Okay, here another one very briefly. Here it's like a Christmas tree. What is going on there, God knows. The extruded GPs all over the places, and then following the root canal treatment, it is still there because this needs a special technique. You need to use the headstrong files again and braiding option and take everything in one go. Otherwise, you will have this option. So what happens with this patient? Initially, root canal treatment is going to be completed and assess the patient's symptoms. If the patient is symptomatic, then it means that we have to do a root and surgery. You see how the complication is adding up and coming to that stage and these areas. Okay. So how about here then? What is going on there? What the clinicians were thinking of here? It's extruded and very well defined radiolucency here. It suggests a cyst formation. So again, this needs a surgical approach. You see how one complication, you know, adds up to more severe complications. Finally, coronal seal versus apical seal. We endodontists, we think that its apical seal is enough or only coronal seal. So both sides, we need to do up and down strategy. So we need to have a very good coronal seal and at the same time, very good apical seal. Trop is a wonderful endodontist and I genuinely like, it's very old paper, but it's still, it's a gold standard milestone paper. So it shows the success rate. Look at here, 91% once you have the coronal seal and apical seal at the same time. And again, Sorenson and Martinov's paper is great to show that this is evidence there. Once you have premolar and molar root canal treatment, cuspal coverage is required. So you need to discuss with your patients regarding the financial situation of these teeth as well after the root canal treatment. And sharing more experiences just very briefly. So here we had the resorption. This is a resorption case. This was a complication and the dentist out there, primary dental care, did the root canal treatment, didn't work. We have a large area there and then I did a MTA plug and root canal treatment and look at, it's much better, the resolution of this area, and did the ceramic metal crown as well, and the patient was happy because patient was symptomatic when they came to me to see me. Another case, resorption case, very briefly. So here we had this case that initially it was a dental trauma case. A patient had a road traffic accident and came to see me. I was going to do a root canal treatment, and then suddenly, once I took the that radiograph after 3 months, I noticed this. And this is the sort of clinical picture. You can see there is a missing tooth here. So we debated that, is it good to repair that resorption, or she was going to have the implant restoration? Why not to have both of them, because the prognosis is poor here. So sometimes, you know, you go with the extraction route and do this implant retained cemented crowns as well. So we endodontists, we do the implant crowns as well, if you wish. So finally, a large amalgam restoration here. If you come across with that kind of tooth with a large amalgam restoration and area here, immediate risk assessment and warning the patient. We need to warn the patient in case there is a perforation here, or there is when you are removing the amalgam, there may be a perforation, but luckily we were very careful. We removed that amalgam with ultrasonic tips and we managed to do the root canal treatment. So the another, just one more case. I know I have a limited time.
Okay, we have 2 minutes. 2 minutes and no time for questions.
I want to share all my sort of exercises. These are, I have lots of cases, but these are like, okay, let me see. So we need to be very careful with, if you are doing the 2-visit endodontics, you need to be careful with your calcium hydroxide placement as well. We shouldn't stringe in very heavily. This happens, you see extrusion, and some school of thought that, oh, it is fine, it degrades. In our case, yes, it happened, it degraded, but there are some cases in the literature saying that extrusion of calcium hydroxide like this, that amount can cause numbness as well. So finally, we need to discuss with our patients, if we don't want any complications later on. The success rate is not 100%. And if you are doing re-root canal treatment, it is less. And also flare-ups can happen. So if the patient has some flare-ups, they can take some painkillers as well. We need to warn them at the beginning. And finally, the survival of root treated teeth are important if you are doing the root canal treatment and then promising the patient with that kind of long bridges, which I don't really ideally recommend this. What is the reason for that? Nowadays we are doing implant placements, right? So this is a failure. This is a sign for you, a failure. Okay. And
okay, Eileen, I know you want to give a lot. This is I'm so thankful for you.
Thank you, and give a chance to heal up as well. And that's it from me, to be honest with you. And I hope that you enjoyed endodontics. I mean, it's my passion, my lecture, and I'm happy to answer your questions. Thank you very much for listening.
Wow, Eileen. First, I should thank you. Thank you so much. This is so amazing. We have more than 1,700 viewers.
Wonderful.
Okay. Yeah, but let me tell you something. You have more than 120 questions.
Oh my
God. Okay, so this is the bill you pay, you know. You have so many questions. The participants, they loved you. They enjoyed every minute. This is so informative. But I will ask you one question only. Can you please answer those questions privately? Yes. Because you have a lot and you shared a lot of information. You can go down to the question and answers section, and you can answer these questions. I'll appreciate this. I appreciate your efforts. Thank you so much. Thank you so much.
So I need to do private drill right now or later?
No, you just type the answer and just click enter. That's it.
Okay, I do it now. I do it now then. Thank you
so much. Thank you. I appreciate it.
I am enjoying this online stuff, to be honest with you. Thank you. Bye. Take care.
Okay, bye. Thank you. Okay, another great speaker, Christian.
Hello, can you hear me?
Hello, my friend. Yes. I hear you. Everything
to see
is
you.
fine. Yes. How is Italy? In which part of Italy you are?
I live in Milan, as you
In Milan.
know.
Oh my God! Keep safe, my friend. In the morning we had a friend from Napoli, and now we have Milan and Bergamo. Hopefully you're doing great now.
Yes, we're still in a sort of nightmare time, but we are fighting so hard. So we hope.
You are a strong nation, and I believe we will have now a great speech from you, a great presentation on microscope of the daily dental practice. I will leave this virtual podium for you, and hope we all enjoy this together. Thank you so much for being with us.
Oh, thank you. Do you have to share the screen? Are you?
Yes, you can now share your screen. Yes.
Okay, that's it.
Perfect.
Can you see? Everything is working.
Perfect. Thank you so much.
Okay. So thank you, Mr. Chairman. Good afternoon to everyone of you. It's really a great pleasure to be part of this wonderful webinar. And thanks, of course, to all of you for your, we have so many registrations for today's. Do you think, Tamer, we need a small stadium? What do you think about it? And of course, I have to thank all the entire inviting committee for the wonderful and amazing organization, particularly those three guys and friends of mine, Hassan, Walid, and of course, Mr. Chairman, Dr. Tamer Tib, for their job. Wonderful. I'm going to share with you this one of my favorite topic this afternoon. I'm going to speak about operative microscope in every field of dentistry. I'm trying to do my best. It's not easy to speak about this topic in 45 minutes, of course, but we will try to share several cases. This first, I show you this symbolic case because it summarizes and encloses many concepts we will speak together. The first concept that I want to share with you is that if I see well what I do, then I will do better what I see. And many times, speaking about operative microscope, colleagues ask me, Christian, I have so many doubts and fears about that. Why should I use it? What about costs and learning curves? These are the constant questions. And my constant answers are these. We are living in a sort of era of professional evolution of the dental office, and my constant answers are about clinical operational needs, willingness to differentiate myself, ergonomics, and communication. I like so much to communicate with patients, assistants, colleagues, and students in my office and everywhere, and attenders, of course. So it's very easy to answer and to share with you those concepts about the magnification in dentistry. What about magnification in dentistry? Yes or not? Of course, yes. Why? Because the oral cavity is a blind and dark cavity where inside of it we have to respect anatomical structures. We know perfectly that there's several published and we have several articles available, and I want to dispel a myth related to the relationship existing just among the microscope and endo. I'm trying to show you why. We live in a minimal invasive era in dentistry. We know perfectly minimal invasive. It means that we have to respect absolutely the dental structures. We must not forget that. And again, we have available many concepts related to microscopy that are also related to the evolution of our instruments, small and delicate, micro sutures, micro blades, micro holder, needle holder, micro scissors, micro ball burnisher, compactors. You know perfectly what I'm speaking about. So light and magnification, in my opinion, are the two real key factors in the modern microdentistry, where we work. And when we work with strong coaxial light, we mean that we are working without shadows or graining effects. We know perfectly what's the difference between the xenon or LED lights or halogen lights. And let's jump into some examples, some movies. Think about how can you check. Don't misunderstand me. I'm not saying that you have to perform the entire therapy with the operating microscope, but think about the possibility to check just the epitechtomy phase or the retrofilling or the retroprep phase. It's really amazing and wonderful to check, and it's absolutely advisable and predictable to have this through these controls, these results with this follow-up. What about perio, for instance? In my opinion, the indications for the use of the microscope are maximum in cases like this. For instance, I'm approaching in a minimal invasive way this infrabony defects. I performed just a small vertical revision, beveled incision, sorry, in the mesial aspects of this canine. Of course, I'm using microscope because I'm treating this favorable quadrant, and as you can see, no probing on the palatal, on the lingual side. So I didn't touch anything on the lingual side, just working on the buccal. You know perfectly what I am doing. I'm just cleaning the surface, the root surface, and applying before our conditioning agents, breath gel and amylogenin, then placing the graft, stabilizing it into this not so well containable defect with a resorbable membrane, and paying attention to the suture that it takes very delicate precision and attention. That is something that you can obtain with loupes, of course, but with the operating microscope, we know that from Gianfranco Carrevale, from Maurizio Tonetti, and from Pierpaolo Cortellini, that we have much literature testifies that the minimal invasive approach and the microscope can be successful. Shopping time, Galilean and prismatic differences, as you can read on the left and on the right, several, but the most important difference is the focal length, fixed with prismatic and variable with Galilean. It means that with a prismatic one, you cannot move without lose the focus, and in the other situation, you can move yourself. So the suggestion is that for the beginners, it's better to start with a Galilean system, for instance. When you want to move using the operating microscope, you know that the important thing is to overcome the learning curve, of course, and you know that you surely have to overcome this beginning learning curve by avoiding leaving it unused. It's a shame. So, in my opinion, which magnification value is advisable in the daily practice? I suggest to find your orientation and positioning in the operative field until 8-pair magnification from 8 to 16. This is, in my opinion, the ideal operative range, and more than 16 just to check verification and for documentation. As I mentioned before, I like we should altogether work with coaxial light. What does it mean? It means that when you look into the mirror, the light goes perfectly inside the root canal if you're doing endo, but in prosto or in perio, it's the same thing. Particularly coaxial, it means that you works, as I mentioned, without shadows or grainy effect, and that is very, very important. We know at in November, in October, November, at the last ILAD meeting from a friend of us, Galip Gurel, that we live in the communicating era. So a symbol or a logo must summarize concepts and meanings related to him. We know perfectly that, for instance, a polarizer, sorry for the pronunciation, is something very special to take super professional photographs with our devices, with our photographer machines, but sometimes we need something very smart, and we need to speed our communication. So in this situation, for instance, I need to call or to send a WhatsApp to my dental technician with a photograph, saying to him, hey, look at this rubber stroke during finishing. Because, dear colleague, one thing is to say it, but quite different is to show it in a widescreen, and that is perfectly valid also for our patients. Since some years ago, on the top of our microscopes, so we have to adapt reflex cameras or camcorder, but nowadays are perfectly available from companies. These products, they produce models compact, clean, simple, with no visible cables, easy to use and fun. So really, it's very easy nowadays to communicate through, for instance, some dedicated app connected to our devices. Simplified patient interaction is absolutely easy. We can show to our patients what we are saying. Think about diagnosis, for instance, because it's easy to say to our patients, dear patient, you have 9 millimeters of probing depth on this tooth, so we have to extract it and substitute it with an implant, and the answer usually is what, why, and you know, it's one thing. I repeat, the concept is to say something to the patient, but different is to show it, or different is to demonstrate and to show, for instance, in those cases where it's difficult to have a correct diagnosis in these interproximal situations, where it's not easy to interpret in the right way slight chromatic variations. Not so easy always. And details, it's the keyword in restorative, in prosto, as we know perfectly. Think about fiber posts, think about the world of the postology, think about the phase when you have to prepare the post-space preparation to perform it. And the question is, when the post-space is really clean and ready for the adhesive procedures. It's clean, really clean, when the dentin is mirrored, simply. So it's absolutely common to have some problems and to have an initial learning curve. You don't have to be discouraged at the beginning. You don't have to try, for instance, to do the entire therapy with the operating microscope. We know that teaching and running courses, one-to-one too. That's most common at the beginning are these distance adjustment, diopter adjustment, joint adjustments, working positions, find the correct interpupillary distance, and that's why we need training courses, sometimes one-to-one, as I was mentioned before. And that is clear. This is me with Giovanni Olivi, my big friend. Let's share together some concepts about basic microscope anatomy. Have you ever heard about stereopsis? What is stereopsis? Is a complex and physiological mechanism not so clear at all, due to the fusion inside of our brain of the two images created in each one eye. And that's why in the modern operative microscope, we have single objective with parallel optical pathways and coincident focal planes. We all have to know that inputs captured from one of the two eyes can be dominant, and that's why we all have a dominant eye. It's very easy to understand if we're, for instance, through this very easy exercise, if we are left or right dominant. And another important, very important concept is this. Think about our colleagues, otorhinolaryngologists or neurosurgeon or ophthalmologist or again gynecologists. They are still and motionless during the work. The patient is still too, but at the contrary, we have to follow. We have to follow slight movements of the patient who instead move himself doing dentistry, and we have to move ourselves and move the tool in relation to the job position and sectors. At the contrary, our technicians in their labs, they use some desk microscopes. So it's important to consider all those concepts. Between them, among them, of course, important is the depth of field or penetration power. It depends on the lens. Look at the green point to understand the definition. The penetration power or depth of field is a distance from two limit planes, front and behind, simultaneously kept in focus from the objective. It's very easy to understand it, and that's why on the top we need to have two eyepieces, and that's why we speak about stereo microscopes. Two eyepieces to guarantee the stereopsis. We all know that we have mechanic parts and optical parts, but another important concept is that our microscopes, operative microscopes, are particular because particulars are the objective. The objective are dedicated to dentistry because we need to move our hands under the objective, so they are ultra low magnification objective and super long working distance. They are particularly to work with them. And think about the varioscope, for instance. This is a very interesting device from Zeiss, and look at the spin posture and the position, the working position of this colleague. In the COVID-19 era is very it's very nice to have the possibility to stay away from the oral cavity at about 45 centimeters. So you can consider to work with the operative microscope directly into the operative microscope, such as in these two prostate cases, where I'm using a focus of 200 millimeters, so 20 centimeters away from the oral cavity. Or there is also a music. or you can decide to wear, for instance, an helmet or loops, glass loops, prismatic in this case, and to use the operating microscope, of course, in a favorable region. This is a canine, lower canine, to document it. So you unscrew the focus 200, and you can use a focus 400 millimeters using the microscope, such as an elegant and expensive camera. Very easy. These are phases of a graft. I don't want to invade the topic of Hassan. That is going to conclude the day. Other two very important concepts regards the possibility to keep in focus the vision. So we speak about parafocality and particularly about diopter adjustment. Parafocality, we learn and we teach the parafocality very well during the courses. It means that one focus at the maximum magnification, what you are looking remains in focus in other grade of magnifications, and that is very, very important. You can combine the parafocality test with the diopter adjustment from -5 to +5. It's very difficult to explain those concepts, these concepts in a few time, but believe me and trust me, it's necessary to follow 4 steps that we explain during the courses. You need just a piece of a sheet of paper with a drawn cross, and you have to follow 4 steps, and you maintain the diopter adjustment and verify it every 2 months, because your eyes are tired at the end of the day, of course. This is another important tool called foldable tube, provided from Zeiss. In this period, you can move away or come closer. You can even avoid turning your neck and getting tired. On the contrary, you can rotate the microscope, but not the 2 tubes without having rotations of the working field. Very, very interesting. We all know the concepts, complex concepts of the ergonomics, about ergonomics, of course. It's very long. It's a very long discussion. We know, of course, physical ergonomics and cognitive ergonomics, and I can say that, of course, if you don't wear anything, you will tend to work curved. If you wear some loops, you will tend to stay straight. You will be straight, relaxed, comfortable, calm, and serene if you use the operating microscope. And I like so much to involve my dental assistant, for instance. So this also applies for hair. And I like so much to have everything under my control during the daily practice with the operating microscope. So this is another important gadgets or goodies or option. A special chair designed specifically for sick microscopists like me. While you work, you can rest your fingers on the patient's teeth and your elbows on the chair, moving them, so you feel so comfortable. You are very, very precise and very serene about what you are doing. Working positions during restorative prosthodontics. We know that we are procedures where we know that we are very mobile because we need to change the vision from direct to indirect and vice versa. Usually I work at generally hours 9 or 11 during endodontics, where the operative field is very static, at the contrary, and again not so stable, and changing my position, like to change my position during oral surgery and periodontology. Let's jump about restorative. Look at this case. Gaetano Paoloni is going to follow me, speaking about direct restorations. And so question is, how do you how do you finish so carefully without magnification this 5-class restoration? Is impossible. Is impossible. Surgery. I'm not saying that you have to perform the entire sinus lift with operating microscope, but think about to have the opportunity to check the translucency of the bone, the thin bone. Under the bone there is the membrane and the vessels. You feel comfortable. You feel that you are checking everything. It's very easy. Of course, not for the entire therapy sometimes, but if you have it, you use it, you need it, just for check. Restorative. Direct restorative dentistry. We have to be very precise in limited spaces and control everything. Hooks, wedges, matrices, rubber dam. We have to feel the control. The patient have to feel that we maintain the control. Indirect restorative dentistry, the same. Personally, it's impossible for me to check those surfaces, think about if they are or not so smooth, well finished or not. And personally, I like so much to note the absence of unsupported enamel prints, for instance, in these situations. Some concepts about preparations are changing, we know, and we have to adapt our treatments to the materials available, such as in this case. This is a subtractive anatomical reduction. The tooth is ready to receive an overlay, a lithium disilicate overlay. So, in my opinion, the least common denominator is to touch as little and well as possible the dental structure in prosto. This is a video. I'm going to share with you a video because a video speaks better than 1,000 words. I'm using the operating microscope to treat one decay. I detected this decay on the mesial crest in this right lower mandibular molar. Has happened very, very often when you open a cavity, you find something also on the neighborhood one. And in this case, in the distal crest of the 6. Here I'm approaching the decay using, of course, a very small bore, diamond bore. In a few seconds, I'm going to place the rubber dam, of course. I agree with all the concepts that has been explained so well from Eileen by Zan. This is the cavity in the mesial crest, in the distal crest of the 6th one. Here I'm beveling the prisms, as I mentioned before. And you know, I feel so comfortable also in posterior regions if I have the opportunity through the microscope to check what I'm doing. I place the hook distally to have freedom positioning the matrices and the wedges. So usually the isolation in endodontic is the single tooth isolation, while on the contrary in restorative dentistry generally the sector or quadrant is isolated. And it's very easy to explain why it's important the use of Britten microscope in these situations. Also finishing them. Can go on. This is the moment where I feel and you understand me, the sound, the magnific sound of the floss, because everything was done in the right way. Well, okay, endo being, I could really show you several cases, being an active member of the Italian Society of Endodontics. We speak about, Eileen speak about perforations, false roads on dental stripping. Of course, this is a very complex case. To describe this case, well, I would need a long time, but look at the healing in the forecaul region, and look in particularly at the follow-up. This is my wife, one of my wife's tooths. So trust in me, this is the follow-up, 20 years follow-up that I wanted to extract the tooths. Without microscope, it's very, very difficult. I would say that it's impossible without microscope to treat these tooths. Broken files, I'm speaking about broken files. This broken files, separate file is in the apical third of the tooth, in the palatal roots. But if you can have the control, if you can see the file, you can easily remove, of course, through the use of the operating microscope and with tips, dedicated tips. And you can go on, you can obtain in a very predictable way good results, trust in me. Lashal forceps to remove caries base. Have you ever heard about thermophil system? Yes, of course. It's impossible to remove caries-based system and to retreat some teeth without microscope and without these tools. Wonderful, very easy. This is the moment where the retreatment will start. Very easy because you can see, you have the control, you have magnification and light, and that's it. Prosto, going to the end of this running. I used to separate and to distinguish these four phases in prosto: preparation and impression, temporaries, checkout, closure, and cementation. Let's look about together the preparation. We live nowadays in an era where today, vertical preparation is back in fashion. The modern postdontist, in my opinion, must know how to do both vertical or edgeless and horizontal, micro shoulder or micro chamfer, and above all, know when they are indicated. This is something that we know perfectly. We have to apply biological, mechanical, and geometrical principles of prosthetic preparation, such as in this frontal case. These ladies, before and after, we correct through therapies the occlusal plane, the vision on the cast of the crowns, lithium disilicate crowns, always everything performed under microscope. So speaking about dentistry in general, and particularly about restorative and prosto, we have to say that we work in an environment very particular because we haven't got restitutio ad integrum. We have so to preserve the maximum amounts of dental structure, controlling everything and checking everything. And this is the group technique that we learn many years ago from Spain, and that we apply. We have to understand, and we have to know perfectly what burrs, calibrated burrs we are using, or sonic inserts, both in additive and in subtractive cases, of course. And jumping in the case that I show in the frontal, this is the lady. She was dissatisfied with her overall smile aesthetic. She refused an ortho treatment. So we found through this device how to separate the arches on the cast, on the articulator, to increase the vertical dimension and to perform a full wax-up in the lab, transforming the wax-up through using a rigid silicone trays to impress the mock-up into the oral cavity, as Guglielmo this morning mentioned very well. This is the mock-up based on the wax-up. Externally and in intraoral view. These are the temporaries of the patient: prepless, composite resin temporaries, complete crowns. We cement them and we prep them through the groove techniques. So very, very conservative. Everything under microscope, checking everything. These are the final preparations, very thin, thickness control, checking everything, and the moment of impression. Impression, it doesn't matter if you prepare, as I was saying before, as I mentioned before, an horizontal prep or a vertical one. Of course, the ideal situation is where you are able to capture beyond the finishing line. I learned from Leibovich this technique that I love so much. I use usually 2 wires, but the second one, I don't push the second wire into the sulcus for the entire diameter. I leave it floating for half diameter. For instance, to share with you these concepts, I show you this case. We consider in this case treat previously orthodontically the patient joining the incisor, making the diastema disappear and recreating symmetry and alignment. This is the situation at the end of ortho. We applied also the speed bleaching technique. We published with my group this technique in the last year in the International Journal of Aesthetic Dentistry to bleach the pillar prior to the prosto treatment. This is the moment of the final impression. I think I have also some music. I think you can hear the music. This is the first wire I insert. Usually it's at the beginning of the impression, time of impression. The first wire displays just horizontally and vertically the tissues. The second one, if you use applying the Leibovich floating technique that I explain, have just to displace horizontally the gingival tissues. So you can obtain, removing the second wire a few seconds before of the impression, you can obtain a sulcus very, very open. So you work in an ideal, real ideal. Look at the second wire, it's floating for half diameter. So when you remove it, it doesn't matter if you use analogic conventional impression system or a digital one. The sulcus is there. You can capture your finishing line and beyond the finishing line. So you can transfer to the lab indications, very important, about the profile, the imaging profile of your restorations. And we go on, the time is enemy. This is the constant results that you can obtain through this technique, through light and through magnification. Again, very, very predictable. This is the final crown. This nice lady. How do you support the gingival tissues, and how do you condition the gummies? Usually through temporaries, of course, because if you have to manage a previous preparation, you are bound by the presence of a prosthetic margin already present. Often this margin is deep. Of course, you don't have problem if the margin is away from the tissues, but you need it. You need to create a margining and edging of the provisional if you have to manage a previous preparation. So you have to detect this area. Sorry, all we have to do is delimit and fill this concave area by turning it into a convex one. And again, the use of operating microscope, it's very, very important. I usually do this procedure in front of the patient himself under microscope. The patient looks at the monitor, and usually they appreciate your passion and your precision. You have to bond between the two lines. You have to fill the two lines, transforming the concave area in a convex area. Why? With a flowable resin dedicated to this procedure, of course. Why? Because then you have to finish, of course. We have to finish externally without exceeding 35 or 40 degrees of imaging profile to sustain the gingival tissues using, of course, discs, rubbers, brushes, everything under microscope. Coming from the lab, I'm a dental technician before my graduated in dentistry. I worked in the lab, so it's easy to understand those concepts for me. I grow with those concepts. You can use everything, curettes on the margins, of course, and at the end, lacquers. Am I in time, Tamer? 15 minutes, I think. In 5 minutes, I'm going to finish for the question time. Lacquers, I was saying, under microscope, checking everything through the microscope. This is not an operating microscope, but this is a desk microscope, of course, in the lab. But the concept is the same. Okay, this is the moment of the fitting before of the delivery of the provisional. This is the situation before of the removal of the provisional, the temporary, in the appointment dedicated to the impression. Healthy pink tissues, absolutely absence of inflammation, absence of cement, no bleeding, perfect adaptation, no gaps. Everything is very, very nice. And how can you check it without microscope and light? It's possible. Check of closures. Check of closure. We know perfectly from McLean what is the clinical acceptable average marginal gap according to the literature. We should remain, hopefully, in an ideal situation under 100 microns in cases of full crowns. And again, you you still have to check the closures through the microscopes using high magnification, using light. This is not correct. Impossible to go on. This is something that will work, of course. And again, working. Check out the closure, porcelain laminate veneers, the same. Post-cementation. I want to share this final concept about cementation. At the Milan University, we ran several tests to understand where to place the cement to cement full crowns. Companies provide to us some stamps, transparent copings. We studied 4 options: positioning cement only within the margins, on the walls, so margins and walls, on the top of the stamp, on the internal vertex of the coping. And we consider that these last 2 options, on the top of the stamp and on the internal vertex of the coping, were the ideal situations, because remain very thin thicknesses of cement, no bubbles or defects. We all know that exists some hydrodynamics problems during cementation, and everything is easily cleanable and removable at the end of the procedure. And again, if you have microscopes, such as in this video, you can check and control everything. I think that you can feel at first that have you seen that is evidence the use of the microscope by the change in magnification visible during the procedure. I think that you can have and feel my serene during the procedure. I can check everything. Of course, in this situation is a sort of ideal situation. I'm cementing a lower central incisor. This is a lithium silicates painted laminate, but the procedure through the use of the operating microscope is very, very serene. Everything is under my control. I can check everything. I'm watching the procedure, entire procedure through the 2 eyepieces. So control, precision about the thickness of the cement, precision about how can you remove the cement. Everything is clean. It seems easy, isn't it? The final sound, magnific sound of the floss. No cement. Curette scalers. I remove the cord, the wire placed before the hook, using at the final this 12 blade. Okay, and this is the X-rays. Sorry, comparison before and after. This is the complex rehabilitation of the lady, of the frontal upper. She did the lower and the posterior too. So these are the adhesive and semi-adhesive cementation, everything under microscope, adhesive and semi-adhesive cementation plus screw retain implant crowns in the posterior, adhesive cementation lithium silicate layered in the frontal upper. Look at the excellent relationship between the crowns and the lips of the patient. Monolithic lithium disilicate veneers pressed and painted in the lower due to the bruxism of the patient. The frontal and the lateral view, pre-op and post-op. The occlusal view with the check of the occlusion before of the finishing, of course. The grooves, summarize the phases, the sextants of the prosthetic rehabilitation, and I love so much these pictures because we cannot have aesthetics. We can't speak about aesthetics without function, protrusion, and laterality. The final view, intraoral and extraoral, and most of you, I know that you know, some of you know these pictures for all the reasons that I explained. That's why me and my big Italian friend, Professor Giovanni Olivi, also run courses about microscopes during ALD occasions, such as 2 years ago in Doha, 2 years ago in Dubai, excuse me, and last year in Doha. So let me say at first, thanks for sharing. Thank you for sharing. It has been a very nice run. Thank you, Tamer. I want to send you my best wishes for your future, to you and to your family, and to the families of the colleagues that are watching in this very special and so delicate moment. So this is the moment of the question time. Thank you so much.
Thank you so much. Thank you. We appreciate your efforts. This nice presentation. Actually, it was inspiring. So I will start with the questions myself.
Yes.
Out of 10, how much you think I should have, or I should get a microscope?
Well, I think that's usually some colleagues ask me, but during your real daily practice, how long does it take, and how long do you use it? I say I use in my office in the center of Milan. We have 2 microscopes, operating microscopes. I love the ceiling of configuration, so I cannot move the model from one study to other box, but I choose, of course, to perform that therapy in that room where I know perfectly that I'm going to use the microscope. So I still have pleasure to treat and not to delegate to my collaborators difficult cases in endo retreatments, as I mentioned, as I shared, or during prostate therapies. I know that you are an excellent Tamer prosthodontist, and you know, it's like when you start to drive. If you drive a small and basic car, you feel and you appreciate the secrets of driving. Then you feel the way, and you want to increase your level to go up, and so you choose not a Formula One, of course. You choose something better. I think that after 10 years, in my case, especially because I was a dental technician. You know that dental labs, they have got every dental labs have got a desk microscope to check the phases. So in my case, it was really a natural thing to choose and to work with operating microscope. And I think that after 10 years of work, if you want to grow, you need it, absolutely.
Okay, I have a tough question. I don't think we have the time, but how to remove a broken instrument in a curved distal canal in a second upper molar?
This is a very nice question. The best question could be surgery, surgically, because operating microscope is fantastic, such as Eileen explained before me. But in the case I showed, the root was straight, and I could easily remove the separate instrument, because the root canal wasn't curved. Of course, when a curve is present, you have to pay attention. You have to consider if the case is an orthograde case or if it's a retrograde case, so a surgical case. I think that it should be the best question. Of course, there are available in the market for Taft endodontists some devices, such, for instance, the devices talked about Moriguchi and other devices to remove broken instruments. I think that there is a real close connection between operating microscope, skill of the operator, and tools. This is the best way to answer to this question.
Okay, we have 2 minutes. Do you rebase the temporaries? This is one question.
Yes, of course.
You rebase the temporaries. Okay, when you raise the bite, when you fix the bite for this patient, was the line correlated or parallel to the interpupillary line or another?
Can you repeat slowly the question, please? If I reline personally the temporaries, of course, when I deliver the temporaries, which is the question.
Okay, in your case, to fix patient's bite with brips, was the line correlated or parallel to the interpupillary line?
Yes, it is. Yes,
it is.
Yes, it is. Yes. In the specific case, I explained that if you have to manage a previous preparation, you have the you must to manage the tissues. Of course, you can prep in a vertical side, in a vertical way, and so you can cancel the shoulder. But the secret is always consist in how can you manage the gingival tissues through the relining procedure. And I think that in this specific procedure, the use of magnification and secrets, some tick and trips are something that can help the prosthodontist at all in all those situations.
Thank you, Christian. This was so great, so inspiring, and so zoomed. Thank you so much.
Thank you so much.
Thank you for being with us. Thank you for sharing your time. We will stay in Italy. We love you, Italian guys. You know how much I love Italian people and Italian food.
We know perfectly.
But this time we go to Rome with a great friend of mine, Dr. Gaetano. How you doing?
Yes, can you hear me? Yes, I'm doing.
Yes, I hear you perfectly.
Okay, Tama. Yes, I'm quite well. Shall I share my screen?
Yes, now you can share your screen. Yes.
Yes, now I can share screen. Where is it? Yes, share and play. That's it. Okay. So shall I start, Tamer?
Yes, yeah. The podium is yours.
Well, first of all, thanks for the invitation. It's a very great honor for me to share some time with you. This time that is strange because we are used to travel. We are used to spend time together, especially with Tamer when I visit for the BAIRD courses, Middle East, and we enjoy a lot dinners talking about political situation and all this stuff. By the way, we will continue in the future to do it, but in the meantime, here we are. And of course, I live like Christian, and I want to congratulate him because he made a great lecture. We live together with Christian in a country that has some issues related to the COVID situation, and fortunately, I live in Rome that is experiencing a little less issues than in Lombardia. And so I live here in the center, in the central part of Italy, and the big issues are in the northern part. And since today things seems to go a little better. So hopefully we will try to fix our situation, I think, before other countries that now are experiencing this kind of issue. And I would like to just introduce myself. You can follow me on some social networks. So I will show also on the last part of my lecture. Well, I belong to some groups, some international and national scientific society. And I live, as I said, in Rome. It's quite famous city. Just a few pictures before starting my my lecture about aesthetic direct restorations, which is some topic that I generally lecture about and do and run courses here in Rome and all over the world. So we hope to continue traveling very soon so that you can come and visit my city. And I now do virtual lessons. So I do lessons for my university students on the on internet, but I teach in Milan, and so now it's not possible to go there. And so I teach through virtual lessons. I record them and I share with them the contents. Despite this, the lecture is about aesthetics, which is something something that we can obtain in several ways. And today we will talk about aesthetic restoration with composites. But aesthetic, of course, is related to the anterior region, of course. But we will start with some important stuff. We will start with some aesthetic treatment in posterior, because of course we have to think about caries removal. We have to think about health of our patient, but why don't we think about providing, for example, aesthetic results also in posterior? This is a simple treatment. And we have to master it as best as possible, because what I generally do is try to doing every time something that can make me happy as I receive it from my dentist, for example. So I have to be satisfied. By the way, before talking about aesthetic restorations, let's talk about a little about literature, which is very important. If we watch if you see in the databases like PubMed, the annual failure rate, so the failing every year of our direct restoration, we see that in posterior, these are the percentage, which are quite good. And the main reasons for failure is caries and bruxism. So we have secondary caries and also fracture. These are the main two reasons for failure, and we should always consider these. So if this is a high risk patient, we should think about which type of treatment, and also if we have some parafunctions, if it's heavy Braxer, for example, we should understand which type of material shall we use. And of course, the secondary caries is the main reason for failure the failure of direct restoration in posterior. And of course, we have to consider that this is due to issues related to technique sensitivity, for example, to the shrinkage of polymerase that we have when we cure our composite, and also the interface can be ruined. We can have a degradation of the interface, and a biodegradation, and also mechanical degradation. And we have to remember that making a filling is not just put composite. It's very important to treat the operatory field in a very delicate way, in a very precise way, and especially pay a lot of attention in the adhesive procedures. And because it's a very sensitive technique. And so we have to avoid contamination of blood, we have to avoid contamination of saliva. And the best way to obtain this is with absolute isolation. This wonderful meta-analysis from Heinz showed that the best results for posterior restoration, or well, for composite restoration overall, are obtained through the enamel etching technique. So we have to etch enamel. I'm not sure that everybody does it. And together with the rubber dam. And sometimes a rubber dam is not used so much, but I always show this picture that I also had the luck to publish in the book that I will show you later, that some patients in the latest part of the 18th century are wearing rubber dam. So the rubber dam is the oldest tool that we use every day, despite we are using every day new scanners, new materials, still we use this kind of amazing tool that has only changed a bit, but is still there and is still, fortunately or unfortunately, sorry, the best way to isolate. We are talking about posterior, so how to isolate posterior easily? Well, I generally do a sector isolation. What is a sector? From the second molar to the central. It's quite easy. You can use whatever template you want. This is a template that I developed some years ago, and it's quite funny. I developed for my students, and it is useful to isolate the three scenarios. So anteriors, single tooth, and quadrant. In this case, it's quadrant because we want to treat, for example, a class 2 on a first molar, on a second molar, on a premolar. Then there are several techniques. Of course, we punch the rubber dam. I generally use a medium-sized hole. I don't use several types of holes because I push my students and the course attendants to isolate. Then they will master, for example, the size themselves because they will understand how to choose the diameter. But if you start with an average hole, it's more than okay. So there are several techniques. You can put the clamp before and then the rubber dam. You can put before the rubber dam and the clamp. What I generally teach also during the BAIRD courses is to place together the clamp and the rubber dam. And this is because it's easier and you can also do it yourself when you are a single operator. In this case, I am helped by an assistant, but you can do it also alone. And then with a spatula or with a sharpened instrument, you can you can move the rubber dam from the wings, and then you apply the frame. The frame can be on plastic, on metal, is not that important. I generally put it behind the rubber dam because I was taught before. I think also Asios Gaitsas is listening, is the one that taught me to use this rubber dam frame, thanks to Vasilios. And then we focus on the SEPs, which is the most difficult part, and it's sometimes quite frustrating. So it takes a little practice, but all the advantages, also the egoistic. So because when you use a rubber dam, you can work without the noise of the suction. You can work without the patient speaking, which is, better than me, sometimes very useful. By the way, let's go back to the topic about direct restoration and aesthetic direct restoration. What about the layering techniques, for example, in class 1 or in class 2? Let's talk about class 1 first. Of course, one of the most asked questions is how many layers shall I place for my restoration? Well, this is something that has changed a lot during the year, and before we placed a lot of dentines, dark dentines and nice enamel. Nowadays, the trend is to use one single shade, because it has to be very nice, but has to be also simple. It's better to focus on the anatomy, so it's better to focus on the details of the shape, on the morphology, because from the morphology we have the function. So look at this. This is without color, this statue, but is absolutely more colored than any other kind of painting, and this is just one shade. So it's very important. It's much better to focus on the shade rather than the colors. And what about which kind of shade if we want to use just one shade? Well, if we use a dentin in posterior, well, it is a little too much opaque. It covers too much. You will see too much the material itself. If we use an enamel, as you see on the right, it will be too grayish, low value. The best option nowadays is to use something in the middle. They are called universal. They are called body. There are several types. Of material. Of course, I prefer to use something that use the color of the substrate, but sometimes it's not that easy. Sometimes we have some substrate that has some pigmentation. So it's better to use, for example, a very opaque material on the bottom. So what are the occlusal modeling technique? After that, we have chosen one single material. There is not so much time here to explain the approach, but generally we have two types of technique. One is subtractive and the other is additive. Subtractive means I place the material and I cut it like we did it in amalgam. Instead, additive is that when we place one single drop, like the technician do when they place wax. And so this is a subtractive technique that it was introduced by Didier Dici and Roberto Spreafico about in 1997, 96. Why in that period? Because in that period, people started to use composite also in posterior, and before was considered something very not very nice to do. And this is a technique very easy to learn, and I consider it fantastic in medium-small cavity. Or there is the additive. So when we place one cusp after another. So in this case, we use a randomized application of the increments, and slowly we complete our occlusal anatomy. But what happens? What happens if I'm not good in proportion? In this case, for example, as you see, the proportions are good, but I can also make some errors. The mesiobuccal can be smaller, the mesiobuccal can be big, so that I can have a lot of errors right from the beginning to the end of the restoration. So that's why with my friend Salvatore Scolavino, we wrote an article about simultaneous modeling technique, which is in which the concept is, let's place more than one increment and let's model them together, and let's keep them separated, so that when we are happy with the proportions, we can cure it, and so we have a smaller cavity to fill. Then you can choose to do a subtractive or to do an additive procedure. But this is a very nice way to put more composite, but without shrinkage issues at the same time, in order to reduce the possibility to be wrong in the proportions. And so this is, for example, a workflow completed through the use of an additive all the way down. And of course, we always have to remember to spread the composite on the margin in order to avoid excesses. And let's see an example. For example, a second molar, which is built in this case with first 2 increments and then other 2 increments, so that in 2 increments we put 4 cusps, and then we add a last step to correct the final central portion. And another first lower molar, 3 increments, then 2 increments, and then again the last increment to go and close the final part. Then, for example, a premolar also can be treated like this: 2 increments, 1 buccal and 1 palatal, and then we finally close. So let's see also some clinical case, quite a simple treatments, selective edge, then increments, simultaneous increments, and slowly we close all the anatomy without making so much errors in proportions. And of course, we have always, because everybody has to make occlusal adjustments, but if we follow these simple tricks, we can reduce also occlusal adjustments. Of course, if we come back, we see this picture. What does it mean? At in posterior, things are quite easy to deal with, but we have issues of post-op sensitivity. And generally, what I do is a selective edge procedure, and then a self-etch 2 steps or a universal in order to reduce post-op sensitivity. Nowadays, with the universal adhesive, we can obtain a very big success without post-op sensitivity. But of course, what we don't want generally is to etch dentin. That is one of the most tricky and risky part for post-op sensitivity. What about class 2? Class 2 is something that is the most important and most difficult thing to obtain in a posterior, is to obtain a predictable contact point and a nice anatomy. And the contact point is the most difficult part to obtain. And of course, there are several ways to obtain it. And I consider that the best option to obtain a contact point in posterior is through the use of sectional matrix. Sectional matrix is the best way, because with the circumferential matrix, like for example the outro matrix, that I love it, but not for obtaining a contact point. With the sectional matrix, we can place the contact point where we want. There are several cases like this, and also here we have a control of the X-ray. We have short time, and I didn't place all the X-rays to check. What is the technique that I generally I use also together with Salvatore? We try to move from a class 2 to a class 1, which is considered, and this technique is called centripetal build-up technique. So moving from a class 2 to class 1, so that then we can finish our restoration easier. Of course, there are several approaches. You can also do your horizontal layering, but it's important to perform a technique regularly. I prefer to build before the wall and then model the occlusal surface as we are in the class 1. Remember always that in this situation on the right you can see enamel. We are like in heaven, everything works perfectly. But when we lose enamel, so where we are below the cementum enamel cementum junction, we are in the we are with the devil. So we are in hell, because things are not working properly, because adhesion doesn't work in a very predictable way. In fact, if we see if we see the literature about it, we see that this article is amazing from Cooper. It says that if we have the margin of our restoration below the cement, below the enamel junction, so when we are in cementum or in dentin, our restoration risk to fail 30% times more, which is really frustrating, of course. I think that this is a very important thing to outline. When we have deep cavities, we have to be very careful on isolation. We have to be very careful on adhesive procedure. We should use light that can reach very well on the very bottom part of our restoration, the light that doesn't have to lose the power. We shall use multi-LED light because they can activate every type of initiator in every type of material. What about in this difficult part, the cervical portion? What about the use of flowable? Because sometimes people can think that using in the very deep cervical portion, the flow can allow to reduce the marginal leakage, and this is something that is not always true. And if we see the literature, this article from Van Dieken has stated that the use of flowable resin did not result in improved effectiveness, and this is quite important to say. So also this from Borusiniat, this wonderful meta-analysis says, okay, you can use the flowable, but this doesn't improve anything. So if you are good with it, use it, but it's not mandatory to use it. Sometimes I use it because I want to see that I have material on the critical part, but don't think that using a flowable it's mandatory. So if you want, use it. If you don't want, you can avoid to use it. We can, yes. So that's the scientific response to this is that from this article you can see in the bottom. They say that the development of secondary caries is not related to micro leakage. So it's not important that you seal perfectly. It's much more important the risk factor of the patient and many other factors. Of course, macro leakage is very important. So this is something that we shall remember. What about another thing that happened very often when we deal with class 2? Because for simple cases, everything works. Everybody is able to treat. But what about this? I show several times this type of case when we have, for example, a failing class 2 with secondary caries. We have to replace it. Well, what we do, we generally apply rubber dam, we remove it, and in this case, we are going to reduce also the mesiobuccal cusp because it's undermined. There is a lot of decay, you see here, underneath here. So, but if we lose this cusp, and we have to reduce it because otherwise it will have a mechanical failure during the function, when we lose this cusp, we lose a lot of wonderful and amazing information. So what to do before reducing is to make a silicon index. So we register, we record the shape, the size, the height of the cusp, the emergence as it was before. And then we prepare the cavity, we reduce a little the cusp, and then we are ready to restore. And before restoring, we can mold the cusp as it was before. So we scratch a little the silicon index with the missing part, we place the material, and after adhesive procedure, we mold it. This is a technique was introduced by Danny and Cobb and I just little modified. And then here it is. We have our wonderful cusp back as it was before. And now how can we close the interproximal area? But as always, with a sectional matrix, a wedge, and a ring, and then we have our centripetal build-up technique performed so that we can then complete our restoration as we did before. And that's the final aspect, and this is before and after. So, and this is some control after some years. The patient is not cleaning very well, but things work, and we are very happy with that. After this, I would like to just show you another case with the same technique. So sometimes it's a technique that is useful when you have to deal with situations where the patient, for example, can't afford more complex cases or can't afford more expensive treatments. And so you can mold and you can save a lot of time, but of course there have to be the indications. This was my last slide about posterior, and I would like to just make a little promotion of our upcoming book of direct posterior restoration that is being translated and in this period, and unfortunately we have facing a little delay because of the COVID-19, but hopefully I think that just before or just after summer we will have our English version of this. So let's move to anteriors for my last 20 minutes of my lecture, which is very speedy lecture. By the way, I hope just to stimulate some interest in you in direct restoration. And although there are several other topics that have been covered during these stay-at-home ILAD Congress that were amazing. Let's see this. This situation can be obtained in several ways, of course, but our anterior direct restoration, something that we still have to perform, because sometimes I see that we are moving more and more to indirect restoration, digital indirect restoration. But I think that there are situations like these, that of course need to be treated in a direct way. So despite we are moving to a digital world, we still need to use our hands to perform direct restoration. So there are direct restoration that works quite well. There are direct restoration that works a little less well, but if we know how to manage them, we can have some satisfaction. Of course, in the literature, unfortunately, there are not so much data about the success about direct restoration. And if you see the failure column, there are a lot of big data of failure on respect of posterior. Why? Because of course, we have also to consider the aesthetic failure. It's a pity that we have so few scientific data and clinical trials. And I hope that we have to, in the future, we will have more and more data about the longevity and the success about our restoration. And we see that the why our restoration can have different outcomes, because if you see here, the failure is different. We can have 100% failure, 100% success, 45% failure. The reason is because the composite behaves differently from operator to operator, from patient to patient, and because also of the oral environment. And of course, there are a lot of things to consider, especially in anterior. One of the most important things, because we don't have time to talk about color and other stuff, it's the translucency. Translucency is the key of success is something that we should always remember. And another trick that I can share with you is that we always have to deal with an hydrated substrate. So if we see this case, it's quite a really significant about this issue, is that, for example, this restoration was simply performed, really nothing special, but this was before and this was after a week. You may say a very good result, yes, but I will show you after rubber dam removal. And so I still remember the eyes of the mother of this type of of this patient that was not very friendly, because she didn't understand, and I tried to explain that the teeth change color when we treat them with cotton rolls, with rubber dam, and so we should always consider this. Let's see another case. This is the initial situation. We generally help ourselves with the use of some picture modified with Photoshop in order to understand more the optical properties of the restorations. We also use polarized pictures, even if it's not that mandatory, but it can help. Then this is the preparation after the isolation, the silicone index, the palatal silicone index that helps us in molding the palatal and incisal portion. And then there's the result. You see, we use different opacity of materials, and despite there is a very fashion period now of monoshade restoration, sometimes we can't use monoshade, one shade restoration, because they are not able to mimic exactly what are we going to show, what we want to show. In this case, an opaque dentinal frame, and then the incisor frame, and then we have the translucency in the middle. And this is the final part after finishing and polishing. And I may say that is much more important at the time we spend in finishing and polishing rather than in shade selection, because the shape is very important, reproducing the transition lines. And this is the technique that we teach in order to obtain a nice result, either from an aesthetic point of view and also from a shape, an anatomical point of view. This is a little video about this case. There was a direct mock-up and then and silicone index prepared directly in the mouth of the patient. The preparation, in this case, there is an horizontal rounded preparation. We can smooth a little the margin. Then we do the adhesive procedure. In this case, in anterior, I prefer to use a total etch approach because I want maximum bond strength. In posterior is completely different. Then this is the peak etch and rinse approach, which is an adhesive with correxidine. Then, as we saw before, we mark, as we saw in posterior, and then we place the shades, translucent material, opaque materials, make some adaptation, and then we shoot with the curing light. Then we put some flowable, and that's it. Now we have to close the interproximal area. So how to do it? Well, we do a little wedging in order to separate a little the teeth and place, as Goyal, an article wrote by Goyal, that wrote this technique of using a posterior matrix in anterior. Then we place the material and we model it as precise as we can be. And then we have the box. Now, this is a technique I generally use since many years. is modify the box before completing, then you can put some adhesive and apply next some dentin. I'm sure that a lot of questions will be raised about this technique. It's always something very controversial, but this is something that I generally perform on a daily basis. And also I do it in posterior when after the centripetal build-up, so after moving from a class 2 to a class 1. After the dentinal body, we can place some stain if we want, or we can put the enamel layer, and then we model it in order to give the final shape. It's important. You can help yourself with brushes. I lately started not to use brushes anymore because it's not so easy to make disinfection, then the application of glycerin, and then the finishing through the use of diamond burrs and discs, and then rubbers. In this case, I use Jiffy rubbers, which are 3-step silicone points, first green, then yellow, and then white. And after that, also on the palatal part, you can remove with some silicone, and that's the aspect about after rubber dye removal. You see there is the dehydration, and this is after the control. Of course, in anterior, you can also use some other techniques rather than the drill. Let's see, like this, for example, from brown spots, I sometimes use some very nice tool, which is 6.6% hydrochloric acid, which is called commercially Opalustro, which is used for microabrasion. And you see that very easily there's a special cap to apply on the handpiece. You can really obtain a very nice and smooth removal of the first layer, so that you can avoid to use the high-speed burrs. Then, of course, ultra etch, and then adhesive procedure, and then you can obtain a very minimal invasive dentistry this result. Let's see another case. Also in this case, you see a lot of translucencies. You see opacities that made with like mamelons. So we're going to use just one shade here. No, this is absolutely impossible. So we have to select the correct shades. And so also here we have the isolation. If we remember, the isolation in posterior was a sector. Now we can isolate the central, the anterior that goes from generally from premolar to premolar, and then we are with the technique of the silicone the palatal silicone index, we can mold the last part. Total etch approach, as I said, and you see the technique is quite standardized. Of course, it's different from material to material and from thickness to thickness, from patient to patient. Then again, as Goyal taught all us, we can use the matrix in a vertical way, avoid excess and all the other stuff we have seen on the other case, so we can skip this part and focus. Let's see, this is the kind of brush that I use now. So I don't use any more brush, but I use a solid brush. This is from U3D's, called solid brush, and comes with our kit, which is the with a story kit, which is just the 3 instruments for all the composite restoration. And this is also the same instrument available in the same kit to define better the details of the internal anatomy. then finishing and polishing, as we said, and we can use disc, we can use silicone points. There are several techniques, several approaches, diamond pastes, and then this is the final result. I have 8 minutes left. I want to focus on some important part that is, it's very important to it's very important to focus on the biofilm of our restoration. I joined a study about the importance of the biofilm formation on composite after different finishing and polishing procedures. Well, it's not that important from the biofilm point of view, but of course, we have to make them as much as possible in order to avoid the retention of plaque. And then I also joined another study about the use of glycerin, the oxygen, to avoid the oxygen inhibition layer. And of course, we have some advantages if we use some oxygen inhibition layer procedure, but after some time in saliva, these advantages goes away. So maybe it's not that important. Again, the importance of opaque and translucent material, very, very, very important. You see, you can obtain a very nice result if you know how to handle and how to manage the materials with the correct techniques. In this case also, for example, the use of fewer materials and just understanding the opacity to use, and I generally use since a lot of time another tool, not only the color chart but also the opacity chart, which is very, very important to understand which type of material to use. And this is the result after the execution, and this is the real truth after several months of clinical service. Is not shining anymore, as you can see on the right, but it's still a nice result that can be easily repolished. Of course, composites can be also used to make some treatment about shape modification. Of course, this, for example, can be a veneer case, but sometimes we are in situation in which we can't use ceramic, and Dr. Tamer is a master in veneers, so I think that he would do, together with Guglielmo, a wonderful treatment here. But in this case, of the socioeconomic status of the patient and also the age of the patient pushed me to make a direct restoration and a shape modification. And so I removed all the old fillings, and then this is the situation to start with. And with the wax up, we have a silicone index, so that we have a project. And if we have a project, we can mold slowly the palatal and incisal part, and we close interproximally with the sectional matrix. And this is the result afterwards. There was also a shift on the midline that was changed, and so sometimes it's also important to take a face bow. You may consider taking a face bow crazy for a direct restoration. Well, sometimes if your final result has the midline inclined, you are not very happy, and the patient will not very happy. So so it's important to consider also this part. You see, first there was an inclination of the midline, and on the right is fixed. So I would like to finish my my lecture with a case I made with the strange guy. So what you have seen, it's something that it's the result of brainstorming, continuous brainstorming, continuous development of ideas, instrument, and together with this other guy, we wrote 2 books, one on direct anteriors and one on direct posterior, and the direct posterior is being translated in English in a few, and the direct anteriors is gonna be delivered in a few months, in a couple of months in Italian. I think that what time is it? I think there is time from some question, but before of this, I remember if you want to join another direct anterior webinar, feel free to sign up for the 15th of April. And 2 more slides about, if you liked it, we have also a channel with video lessons. You can visit this type of site. And for whatever you want, you can also reach me to the social media crazy machines, and these are my address. So thanks for watching. Tamer, if there are some questions, I'm more than happy.
Yes, a lot of questions. You hear me very well?
Oh my God, yes, I can hear you. Oh, please avoid the tough ones, so that when we will see, I will pay you a beer, you know.
It was great. We have more than 1,600 participants from all over the globe. Yes. I'm so glad that you are here with us. I'm so thankful and so blessed to have this technology jumping from one place to another. It was so great.
Absolutely.
Having all of yes.
And when you ask me, yes, tell me.
Maybe this is one of the advantages of COVID-19.
Also my kids know how to use software to video calls.
Yeah, it's the same, I think, for all of us. So, okay, I will start with some questions I have. Let me check. There are so many. Okay. The fractured part, how you can complete it by silicone? Do you use wax up or do you just fix it with your hands?
Well, if the missing part is very little, I think 1/5 of the tooth is missing, I can do it freehand, of course. If more than this is missing, I prefer to use a silicone palatal index. Well, a silicone palatal index is something that it's helpful, and you can do it on a workshop, but sometimes you don't have time to make impression, to ask the lab technician to make a workshop, because maybe you are a consultant in your office or you have to do it very quickly. So one suggestion is to make a direct mock-up. How can you do it? You dry your teeth, you apply some composite that you are not going to use, for example, you model it with very quickly with the spatula, and you light cure. Even if there is no adhesive system, it will stay there. So you can also adjust it. You can also remove excesses, and then you can make the silicone index with this. But this is something that can be done very easily with a direct mock-up. But if I can, I ask for a workshop, of course.
Perfect. They are asking also about the instrumentation. You mentioned that this is the kit of We Restore It from Hugh Freddy, right?
Yes, there's a kit. The code is We Restore It DIN. Sorry,
okay.
Restore It DIN. And if you want to contact me at the address before, I can be more specific, and I can tell you the.
Okay. Also, the box, from where they can get the box.
The box. Can you? What do you mean the box?
Your box, your text box.
The books. Yes, it's from Quintessence, but you have to be patient because they are translating them. But I think a couple of months they will be available through Quintessence USA.
Okay. Where can we finish the dentine in relation to the bevel?
I missed completely your question. Where?
Where can we finish the dentine in relation to the bevel?
It depends on the material. So this is depending on the material, because there are some dentine you can finish a little before, but generally we cover the preparation. I don't bevel too much. I just made a little smoothing, and so I generally finish with a dentine and with enamel on top. But there are also some other types of material that you can just go with one single material. It takes a lot of time to explain this, so I'm sorry not to be more specific.
Okay, how you treat minimal enamel abrasion on molars, for example, due to hard brushing?
This is, of course, if there is space, if from the causal point of view, there is space, or if you are referring to a class 5, I do a selective etch, so I just etch the enamel after a slight preparation, and then I use or universal adhesive or self-etch 2 steps, and then apply a little amount of flowable and then composite on top.
Okay, do you put glycerine before or after curing?
I generally made the final curing, so everything is finished. Then I apply glycerin and I make another light curing.
Okay, how can I avoid the sensitivity of the C factor? Any advice?
Yes, use a self-etch approach or universal approach, or universal adhesive with a self-etch approach. So never etch your dentine and use a self-etch approach. So selective etch only on the enamel, then rinse, so 15 to 30 seconds on the enamel, rinse the etching that is only on the enamel, then apply your universal bond, scrubbing very hard on the dentine for a long time, then dry, and then light cure.
Okay, how do you keep your resin soft? My nurse usually passes it to me so stiff to control.
The composite?
Yes.
I don't like to use ovens, you know, the heaters. Sometimes, of course, you should keep them in the refrigerator, but this is very not easy to deal with. You can remove from the refrigerator in the morning, and then you can I can say that I prefer a little more stiff than a little more soft, because I want to my shapes to be kept. I don't like very much flowing composites. By the way, if you want, you can warm a little or just a few minutes before using them.
Okay, how do you treat sensitive abfractions under the cement to enamel junction level?
Well, this is dentin. This is dentin. So you, when you have sensitivity, the best way is to use desensitizer, but the best desensitizer is a self-etch adhesive. So I use a self-etch universal adhesive, a rabbit, dry, and light cure.
Okay, how do you deal with post-operative sensitivity on mastication that remained for 1 month?
Okay, if it remains more than 2 days, you have to do only one thing, that is remove your restoration and perform it once again. Unfortunately, it happens, and that's why I don't want to use anymore a natural rinse approach in posteriors, but as I said, selective etch approach, and then a self-etch 2 steps or self-etch 1 step, which is more or less a universal adhesive.
Okay, I have less than 5 minutes. Okay, if development of recurrent caries doesn't relate to micro leakage, so how recurrent caries occur?
They occur for macro leakage. So if we have a bigger hole in the margin, of course, there you can have secondary caries. Micro leakage is the the leakage that we obtained in laboratory through the use of some colored media, some silver nitrate powders, some colorants. So we saw at the beginning that it was going on in the interface, and so we thought, okay, if the colorant is going in the interface, we will have secondary caries. It has been demonstrated that it is not related. Of course, if we lose, we keep a gap, a big gap, of course, the bacteria can colonize that part and have secondary caries.
Okay, one last question. Where is sandwich technique used in cases with cavity margin that is apical to cement to enamel junction?
I don't have experience with, I think that the question is related to CVI. I don't have so much experience with CVI. I prefer to perform adhesive procedures. If I can't perform an isolation with rubber dam, I choose to do either orthodontic extrusion or crown lengthening in order to have, as soon as possible, isolation to perform adhesive procedure. Or I can choose completely treatment, and I can also do, for example, a crown with a conventional cementation.
What do you think of injection molding technique?
I have no experience with that, and there are no articles scientific published about that.
Gaetano, you know how much I love you. You know how much I love Italian.
You too, Habibi.
Everything Italian. Cars, clothes, food, dentistry. I love your passion. I love how passionate are Italian dentists. I know plenty Italian dentists. You did a great job. Thank you so much for being with us.
Thank you for the invitation. Hope to see you in the near future over there in the region. Yes, come on. It's just a matter of time.
Yes, it is a matter of time. Thank you so much. Now I will be jumping from Italy to bye. Ciao, Gaetano.
Ciao.
To the lovely place of Morocco. How you doing, Morocco? So you know how hi Jafar, hi
my dear.
We are so glad we have a great speaker sharing his knowledge with us, his unique and innovative technique on guided implant placement. To be I'll be a little bit more to your side, because you know you are one of my idols. I love your experience. I'm a so big fan of you. I will not take a lot from your time. How are you doing in Morocco?
Fine, my dear. I think things are going well. We are a little bit. We had a lot of chance to take the problem from the beginning. So we had the experience of Europe. It started in Europe. And then the government really took all the security to start everything from the beginning.
Great. So I will stop sharing my screen and I leave this virtual podium for you. I'm sure we're gonna learn very interesting things. It's all yours, my friend.
Thanks, my dear. Thanks. So I hope that everything is okay. Stay with me until it's okay.
Yes, we see your video, but not the lecture.
Okay. So let me go here.
The green button, yeah.
Yep. And then not this one, this one. Okay. I move quickly.
Perfect.
Is it okay for you?
Yes, perfect.
Okay, let me go to the full screen. Excellent.
Perfect, all yours.
Okay, thank you, my dear. First of all, good evening or good afternoon or good morning, everybody, because I know that people from all over the world are following us. First of all, I really want to thank my dear friends Tamer and Hassan, and for sure all the team of BAIRD and ALD for inviting me. I'm Jafar Moui from Casablanca, Morocco, and all those guys behind this platform are close friends, and I really congratulate you because it's quite amazing work. So now I have a quite difficult topic to discuss in 45 minutes because it's a new guided surgery. But before I really want to talk about this situation for a few minutes, I did a kind of stupid parallel between this dramatic situation and peri-implantitis, which is just a small chronic pathology in the mouth. I said it's ridiculous, but let me just tell you my feeling about all that. You have to know that peri-implantitis is a pathology. It's not the topic of today, but we will come up to guided surgery, and it's something which will help us to have tooth in absence of any root to use, and this magic solution for edentism comes with problems, with chronic pathology. And you all know that the COVID-19 is a chronic pathology of the lung. So in those studies, few years ago, Nozari and Sloats, they show that the difference between the periodontitis and the peri-implantitis, which is due to not a normal root or a normal perio problem, it's due to a biomaterial, a foreign body with a foreign body reaction. So if we go to a consensus conference by Albrechtson and co-workers in 2012, they are talking about 3 things in charge of peri-implantitis. Sorry, I missed something here in the middle with the implant, the implant, the surgeon, and the. But I will try to explain. The problem of infection of this kind of infection is due to 3 things: to the implant itself, the quality of the implant, the quality of the surgeon, and the host. And we all think that every time we have a failure, an implant failure, it's related to the host response. Now some facts. In the left part, it's the clinical problems related to peri-implantitis, and the right side is the quality of some of the implants we can find in the market, which are dramatic with regards to the quality. And this is the Clean Implant Foundation, which is a foundation who is working on this kind of problems related to quality mark and implant qualities. Just to talk about the situation today, if we replace the implant by human being, we can say that the host is our earth. The tool or the implant is everything we are using today to have everything we need to live. Factories, all the tools we are using to have all the comfort we need to this crazy life we are living. And now the last thing is the quality of the surgeon. The quality of the surgeon. Sorry, the photo I have here was very clear. I can explain all those things, but I'm doing without. So this is the quality of the surgeon, which is mandatory to have a good implant and a kind of success in implantology, and to avoid any pathology. If the quality of the surgeon and the quality of human today in this earth will use a very bad quality implant, which is all those things we are using to kill our earth, nothing, absolutely nothing can be positive in our future. So this is just between comer before to go inside my lecture. This statement from this consensus conference show that this inflammatory problem is related to two things: the quality of the material, surface properties, but also the surgical and prosthodontic experience, skills, and ethic, which is something will brought us, all of us, to guided surgery. Sorry, I think I have a real problem with my it's crazy because I have everything on the bar here, but nothing in I'm going to the screen. It's like I lost all the photos. Can you just give me 2 minutes to try to fix all that? So sorry. Okay, this is really strange. Really strange.
Just go back to the share screen button. Dr. Muhi, you hear me?
Samir, are you here?
Yes. Yes, I'm here. I see you, but I cannot see the presentation. It was working perfectly.
I'm really sorry.
Problem,
don't know
no,
what
don't worry,
happened.
don't worry. Can you press on the green button
We did,
again? The share screen button
we did
again.
the testing with timer.
Can you just
Remember, I don't know what happened, my dear. So everything was okay.
Can you put the green button?
I
The
don't hear you.
share screen.
I cannot
Can you
hear
have
you.
the share screen button?
Yes. What do you say?
Can you press the share screen button? Okay, now I see your screen.
I never had this kind of problem. I have just like.
Okay, just if you press, I think you are out of the presentation. If you can have it again.
But I try to open it again, and it's.
Okay, can you open it again?
I have here in French PowerPoint cannot read the presentation.
Okay, it's fine. If Anyway, if you press on the share screen button, you will have all the windows open, so you can select which one you need. I see your screen perfectly. Yes, I see your whole screen.
Yes, but
so maybe it's on a different desktop.
No. No, not that. Absolutely not. It's really crazy.
Okay, I think that it's just the PowerPoint ended the presentation. We need to reopen it again.
I shut down everything, and
yeah, I'll send you what I see. I see myself.
Incredible. It do not open at all. Do not open at all the. Amazing.
Okay, you can open the French version. We speak.
But I try to open it. The problem is that when you try to open,
okay,
see a problem, and when I try to repair it, it doesn't work.
Can you open it with the keynote?
Let me see if I can open it with keynote. I don't know if it's probably a solution. Hope so. The format is not valid.
Okay, if you can.
Amazing. Amazing.
Okay, can you restart and you join again?
Okay. Crazy thing. Okay, I restart and be back to you. So sorry.
Okay. I will wait for you.
If one of the next lecturer is ready, and if you can give me the time to, or it's not possible. I never have this issue, this problem.
So. No worries. This can happen. Always, this can happen. We will wait for you. Okay. Okay, so we just, okay, it's okay to have a break because we've been streaming for almost 9 hours now. So I think Dr. Jafar will be with us in 5 minutes. So it's an opportunity to all of us have to bring some coffee, go to toilet. 11 hours of streaming is not easy. We need to be patient, and with this technology thing, we always have some issues. So I think this will be solved very soon. First, I need to thank our colleagues and our partners in this, the American Academy of Laser Dentistry. They gave us a great value. Also, our scientific partner, the Saudi Dental Society. By the way, we are currently organizing a great event in collaboration with the our Saudi scientific partner. You will be able to join this activity also for free. It's in the coming 10 days. I'm sure we're gonna provide the same, or maybe this even higher quality lecturers, and it will be another great and successful event with the Saudi Dental Society. So we will announce this very soon. Also, I'm so thankful for our sponsor who provided us with this platform to share all of these speakers with you. 33 speakers, 11 hours of continuing education. It's unbelievable how we did that, jumping from one country to another, having such amazing speakers from all over the planet. Such a great audience. We have more than 27,000 viewers on Facebook, on Zoom platform. So we are so thankful for, I don't want to thank COVID-19, but I will thank the chance that brought us together, staying home, staying safe, praying for others, and enjoying this high quality learning experience from BAIRD and other education providers. Actually, we should thank all of the lecturers from all over the world, not only BAIRD speakers, from all the societies, the academies, Facebook pages, Facebook platforms, on Instagram. What we see nowadays, it's unbelievable. It's like we are back to school again. What's interesting, I was so looking to Dr. Jafar lecture, to Dr. Jafar speech, and hopefully he will be back soon. This innovative technique he invented for guided sleeveless implant placement systems, and the surprise we're having after that, we have a lovely speaker from Cyprus, and she will speak with us about marketing protocols, about standing by clients and our prospective clients through these tough times. You know, many of us nowadays, they are afraid of marketing. Shall I do marketing? Shall I stop marketing? Shall I wait? Shall I not? What shall I do? So I think we will get clear answers from Antigone. She's a lovely speaker. She's passionate also about her business, which is marketing. So I'm so glad that we have such an experience among us today. Also, I'll say this in Arabic. We will have Misk al-Khitam, Dr. Hassan. Dr. Hassan will be with us after almost 2 hours to speak about implant placement in the aesthetic zone. So this is, as I said, a dental marathon. We are waiting for Jafar. Jafar is back with us. I think he's back with us. So again, for all the audience, stay with us. Keep learning. I know we have a tough day, 11 hours. We have a tough day. But it's such an experience to have all of these speakers together from all over the globe. Again, we will continue with Dr. Jafar, and we will go after to Antigone from Cyprus, and we have also Hassan at the end to finish with this day. So hi, Usama. I see Usama. Oh my God, we have 1,000 participants now live on Zoom, and almost 27,000 people who watched us today on Facebook. So thank you so much for joining us. Dr. Jafar, are you okay now? Are you back?
Yeah, I took another presentation, but it's quite the same. We can.
So can I stop my screen and give you back the screen?
Yes, please.
Okay, it's all yours now. I have a big face, being so close to the camera. So, okay, I will leave the, yes, I can see your presentation.
Okay.
Okay, it's all yours.
I'm back to this consensus conference. So sorry, guys, I've never had that, but it's okay. We can still make it. I still have 25 minutes. So this consensus conference shows that there is two problems who leads to peri-implantitis. The first one is the implant quality, and the second one is the implant positioning. And this is the photo I miss in the other presentation, where the implant, the clinician, and the patient-related factors, the host response, are the three things bringing the implant treatment to a disaster. Now, today we will talk about the implant positioning and how we can help ourselves by using implant guides to go through those positioning problems. So if we see this kind of situation, which is dramatic situations, we cannot accept anymore this kind of things. Kissing tooth, kissing implant placed, but we cannot use them because they are too close. Implant we cannot use, but we just place it and we don't use it. Injuries for the nerves, injuries for the implant inside the nasal nerve. All those things are really dramatic. And this kind of cases where the implant are outside the line, the crestal line, when we need to put the implants inside the keratinized tissue, all those things are for sure a situation which will lead in time. It will take weeks or months, and those implants, for example, close to the frenum will always give a problem, and this problem will lead to a soft tissue problem and then to a hard tissue problem. So placing implant and respecting all the what you call the noble structures like nerves, it's a really big issue. So if we want to place implants like this and we want to be really safe, the best thing today is to go and choose the best implant guide to help for those situations. This new consensus conference is talking about the same thing also. It's 2018. It's a group of very, very interesting scientists in the field of implantology, and they're all talking about peri-implantitis problem due to malpositioning of the implant as one of the first etiological problems. Another interesting paper from Wang and co-workers in Michigan surprisingly showed in studying 30 papers, 36 cases, that 4.5% of the peri-implantitis problem is due to implant positioning, 21% to thin tissue biotype, and 29% to lack of keratinized tissue, and then at the end, 9% other factors: poor oral hygiene, systemic disease, smokers, alcohol abuse. All those things are really in the last position regarding the etiology. So before going on guided implant surgery, what are the good questions to consider before any debate on the consequences of bad implant positioning in implantology? This case on your left, is it an unhealthy patient or a dramatic implant positioning and tissue handling? Those things are just amazing. All those implants are outside the crest. All those implants are too buccal. This young patient, 24 years old, is it a healthy, young, non-smoking patient or an excellent tissue handling and perfect implant positioning who leads to this beautiful result? Is it a healthy keratinized tissue or a good soft tissue management and perfect implant positioning? All those things will be discussed with videos and all the details in the following lecture. Is it an excellent lab technician or a very easy case for him because the implants are in a perfect parallelism and positioning, and the distance between the premolar is respected between the molar also, and the distance between the top of the implant and the contact point is also respected. The system I will share with you today is quite different than the sleeves. We know the standard guided surgery system with the central sleeves. This system was invented by a guy called Philippe Demoyer, who is a lab technician, a Belgian lab technician. And he started in early 2000, and then around 2013-15, when we started to have the laser sintering technology to 3D print metals, he goes for a very genius guide, which is totally open with 2 external sleeves. And 2017, we started to have a quite interesting resins, and we use them for to print quite solid guides. So this is the evolution of the system. The system just required 2 pieces for the hand, for the contour angle, and with these 2 pieces, it's done. You have the system to guide, because you will use your own drills, your own surgical kits. You don't need a special surgical kit for this kind of guide. And then, if you can, as you can see in this part, the guiding is outside the surgical field, so the drill is totally free to go inside the bone. And for sure, it means that you can use conical implant, cylindrical implant, you can use Versa burrs, you can use whatever you want, because there is no single problem related to the sleeves or to the guiding system. So what is interesting here is that there was an evolution, or now the head of the contour angle can go in between the 2 tubes, and then we can really save the space in the posterior area. You can see that for a 13 millimeter drill, for example, or 13 millimeter implant, you need 51 millimeter, for example, for the sleeves guide, and we have a drop down of the needed space to 29 millimeters for this external guiding system. Replacing teeth with implant-supported restoration represent both surgical and restorative challenges, and we all know that it's not an easy task to do implantology. Those challenges can be related to operator skills. And how can it be possible to see this kind of endo treatment? If the colleague can do that, for sure it's easy for him to do this kind of problem with implants. How can you imagine that this kind of situation can still happen with all the devices we have, scans, 3D imaging, 3D manufacturing? All those things cannot end with this kind of dramatic situation. For sure, the problem is the 3D positioning. The 3D positioning, you can really do it freehand without any problem. But for this kind of case, you extract the tooth and you have to put the implant inside the socket. It looks easy, but the best thing to do is to study that on the computer, and then you will play between the primary stability of the implant and the space to graft outside the implant. And this is something quite difficult to do freehand, but very, very easy to do on the computer, because you will find the best place where the implant will be totally stable, and then you will stay away from the bone and maintain this critical size defect to be filled or not filled, because it's a minimal space, and then to succeed to have a very nice outcome, prosthetic outcome. For the 4 incisors here, the best position is this one, the position exactly in the cingulum. And those things, and the space between the 2 central incisors, the space between the central and lateral incisors, between the lateral incisors and the canine, is totally calculated precisely on the computer. That's why you can have this kind of perfect implant positioning. We cannot accept this kind of thing today. Here, the colleague placed 2 implants, but he needs to remove the tooth. So is it logical to remove the tooth and place 2 implants and remove the tooth? It's quite crazy. So this is how it works today. You can see that you place the implant and you will be blocked here between these 2 pieces. So you cannot go deeper than what you decide on the computer. And the orientation with these 2 implants is very precise. The implant is placed inside the socket in really the best position to have the best osseointegration. So those challenges are also related to the site conditions. The site conditions can be the lack of space, the root convergence, the bony defect concavities, soft tissue concerns, emergence profile. All those cases will be detailed with videos. So this is a case of a very young patient who came to us and want to remove this Maryland bridge. You can see when we remove it, it's quite clean. The soft tissue is not really perfect. We need to put 2 implants. The orthodontist refused to continue, refused at that time when they put the Marylands a few years ago. He refused to continue because he started to have some resorption of the roots. So if you want to do this kind of case freehand, you need to do this kind of flap. And this flap will permit to see the profile of the roots and to start to drill. And then you will start to drill the pilot drill first and do the first radiograph to see if you're not kissing the canine or the central root. And this is because the space is very, very, very tight, right and left. This is really the best case. We decided to do it flapless because the papillas are very, very thin. And if we do an aggressive surgery, we have a risk of a black triangles. So this is what could happen if we do not perform either a flapless or a very, very, very clean flap. So this is a study in the beginning, and this is how it works during the implant positioning. We did a kind of a roll-up technique to have the best immersion profile. By the way, this young lady was outside Morocco studying in the US, and she had to do that during the vacation, the summer vacation. That's why we do not graft the 2 centrals. So you can see here that the 2 implants were placed very, very perfectly in between the central incisors and the canine. And you can see here the implant positioning. You can see here how it fits with the tubes of the guide. the situation just after the surgery. This is a mistake from myself. I was a little bit hard when I removed the detach the soft tissue during the roll-up technique. This is the situation week after the surgery, and this is the situation after 4 months. You can see that the papillas are totally safe, and they can give us this kind of aesthetic result. Okay, now one of the major factors leading to implant failures are thin tissue biotype. I just show you a quite good case of that. But the other thing is the lack of keratinized tissue. We cannot perform any kind of flap when we have this kind of closed tray guide. But when we have an open tray like this, if we have a lack of keratinized tissue, for example, on the canine, on the first premolar, we can do the implant placement flapless on the molar region and premolar, and then canine and central incisors. We can do our flap inside to put the keratinized tissue in the buccal part. So this is something you cannot do when you're in closed tray and you don't have any control on soft tissue. That's why you have this kind of disaster. This is the case, this one. When you use the punch to do it flapless, for sure you will kill all the keratinized tissue in the buccal part and in the lingual part for this one, which is also a dramatic situation. So when you have an open guide like this one, you have the guiding system. Imagine that you put the implant here and you use the punch. You will for sure have your implant in all this area on the non-keratinized tissue or free gingiva. So this is how it works. The implant inside. What is interesting also is that you can suture. You do your flap and suture the flap to the guide, and then your assistant have a free hand to help you for another things. So in this case, we did a Summers technique for the two posterior implants. For the we did a Summers technique for the first and second molar. Here before grafting and before the bone, I always use the PRF just in case if the membrane was harmed and I cannot really control it. And then you can see that the two implants can be placed and totally protected from the tongue and from all the surrounding contamination. What you can see here is a photo I took in a meeting in the US where the gentleman showed that he was grafting inside an acrylic guide. So you can imagine the amount of saliva between the guide and the maxilla, and he was pushing the bone through the saliva inside the sinus, which is just unbelievable. So this is the situation in the beginning of the case. This is after the implant placement with the gingiva, the keratinized tissue moved to the buccal part, and this is the result. So this kind of quality, of soft tissue quality, can really last in time. So this is just a kind of Moroccan style on this slide. The same thing when we are in a very large edentalism or full arch edentalism. You have to know that when you are in a full arch or partial large edentalism, you need to fix this guide with screws. So you cannot remove every time the screws to do your soft tissue flaps or this or that. So this is the situation where we do not need, we have a very small keratinized tissue around 2-3 millimeters. We just do a small incision to have this keratinized tissue outside the implant. And you can see that it's very easy after that. And you can use it to, you do it with either a metallic guide or resin guide. So this is the case, a very large edentalism in the mandible. Here we'll start to show you the planification. The planning was done using the Lego bricks. The Lego bricks are very, very important for us. It costs nothing, and you just need to put it on your impression tray, and then to take the scan with that in place. And then this Lego brick will do the link between the bone, the edentalis model, and the wax-up. And now you have on one file everything. You have the bone and the wax-up, and you can really place the implant in the best position with the best emergence profile, with the best emergence of the screw, if it's a screw retained rehabilitation. So this is the result of this case with these 4 implants quite perfectly parallel. This is the situation during the study, and this is during the implant placement. You can see that it's quite easy. You need to follow. You see that we did a small flap to preserve the keratinized tissue. Now we place the implant. You just need to go until the 2 sleeves come to this step, and then you are on the perfect depth of your implant. So we put place 4 implants each side, perfectly 1.5 millimeters down to the crest. And you can see on the right slide how perfect is the keratinized tissue around those implants. And it just took us a very small part. You have a very small entry in the guide, and you just need to do a small incision to preserve the keratinized tissue. And you can see here the quality of the soft tissue in this particular case. So after that, we will put the scan bodies and do the impression to finalize the case. So this is a case where we did the upper part also, and you can see here a situation between before and after, using this Lego to have the possibility to study the case perfectly. So for I don't know if so I will go through this case just to have the procedure of the workflow. I can announce for the on the title. So when we did this, so excuse me, just go back. So this is the situation in the beginning. You will see here a case on a 3D simulation and exactly the same case done in real. So the impression is done with a tray with the Lego, and it's mandatory only in when we are doing a full arch rehabilitation. When you are doing partially dentalism, it's not really a problem. So it's okay. So this is the scanning of the wax up and everything, and then we come up the case to put the implant in the perfect positioning. So this is what we call the dry surgery. I mean, if we want to prepare the provisional, we need to do the same thing on the model. Now we have full digital workflows to do that, but this will give you an idea about how to prepare the provisional. So everything is done exactly like you can, most of the dentists, they do that to train before the real surgery. And then you can see that they the procedure, the surgical procedure is done like for the dry surgery, and then the provisional is prepared and the provisional is placed at the end of the surgery. This is how it works for the dry surgery, how we place the provisional and how we do the implant placement of the model and the provisional. So this patient is a quite strange story. This patient placed 12 implants in the US. He lost 8, and then he adds 5 in France, and he lost everything. The 4 remaining ones, I removed them during the implant placement. So this is the model. We started by doing what we call the dry surgery. We put the implant on the model and we fabricate the provisional. So we decided at that time to put zirconia implant because this patient was convinced that he's allergic to titanium. So it was my first case with zirconia implant. He refused totally to have titanium because he thought that he's allergic to titanium. We did the testing, but the testing was negative. We sent that to Switzerland, and it comes negative. Means that this is something we just answer the patient to his demand, if you want. So on this model, we fabricate zirconia caps because at the time it's a one-piece implant. You cannot use anything, any drills for the parallelism, nothing. You need to follow the axis, and all those implants are totally parallel thanks to the guide. And you can see that here we use those caps to move the deep junction to the soft tissue level. And then we prepare the provisional on those caps and we start the surgery. So you can see here that we will fix with 3 screws the guide and the bone. We remove those totally non-integrated implants. You can see how we can remove them very easily. And then we start the flapless implant placement. One-piece zirconia implants. Trust me, it's not the speed I work with. So then we will graft the previous implant positions. And here we have our provisional placed on those implants and relined. So this is the situation in the beginning, and the 9 implants placed. We use a software to color the bone. The bone is green, and you have to notice that all those spaces are artifacts. And there was in the US some terrible stories, colleagues sued in court because of those black spots here. You can see like there's no bone in between the implant, which is not through. The artifacts are very, very heavy with zirconia. This is the provisional, and this is the final restoration. And you can see here the simulation and the results. It's quite the same. Okay, this particular case, I don't know, Tamer, if let me know when I have to stop, please.
Yes, we have 5 minutes.
This is another case with a huge bone deficiency in the lateral area. We decided to put implant, but here when we did the study, we can see that the implant are even the thinner ones have the dimension of the crest. So we decided to have a mix, like my previous lecturer, my friend Imad Saloom was talking about, is to do the split of the crest and even do graft to the buccal parts to be totally safe. So this is what we decide to do, and this is the surgical field. You can see that with this open frame, we can use the piezo, we can do whatever we want. And here we use the pilot drill, and then we use the osteotomes, screws osteotomes. By the way, it's the only guide who permit to use osteotomes, screwed osteotomes. You cannot imagine to go inside the sleeve with the screw osteotomes. So this implant was placed after the crest splitting. Now what is interesting is that we can simulate here with this part the level of the bone needed. And here we place titanium meshes to protect the bone, and everything can be really done with the guide in place. Here, the guide was totally screwed on the tuberosity. So this is the situation at the beginning after the surgery, the situation just after the surgery, the 2 implants with enough keratinized tissue, and the situation at the end. So a last case, just to have some, I'm sure that you have some questions, and I'm sorry again for this problem. This is a case where we needed to extract a premolar because of an endo problem, like you see here, and you will see a mix between the real surgery and the 3D surgery. So we remove these two roots. We try to preserve the cortical bone, and we try also to preserve the septum. But to preserve the septum, we use the versa burrs. And during the planification, the axis of the drilling was the palatal root. So we push, you can see it here. We push and we create a kind of, you can see it here, a kind of neocortical, buccal cortical bone. And then for sure, grafting, filling, everyone will use his proper solution for that. What is interesting is that at the end, we will choose the right abutment, we will do the provisional, make the provisional, and then just after the implant placement, we will place the provisional and have this kind of healing. You can see here the situation 1.5 year post-op. So to finish, what is important with this open frame guide is that the irrigation is really, really perfect, which is totally impossible when you have a closed tray like this. It's absolutely not possible to irrigate the bone, which is 5-6 millimeter below the level of the guide. And regarding the instrumentation, when you have a closed tray with sleeves, you need spoons, you need quite complicated surgical sets to achieve the surgery with this kind of guides. Here you need just 2 pieces, absolutely 2 pieces to finish the story. One of the most important thing is the height in the posterior area. You can see that like this in this publication, the conclusion was that the mouth opening limitation is really a problem and can be a problem if you want to use guided surgery. That's why when it's open like this, we really have the possibility to go from the upper part of the guide down, and we can really gain more than 25 millimeters, which is very, very interesting, the posterior area. So this is a case in the posterior area where we put 3 implants, and those 3 implants were placed in a very, very difficult part of the mouth where the opening space is quite zero. The last case, another case with the Summers technique, and you can see that we have a stop here, exactly like you see on the radiograph, exactly on the sinus floor. And then when we remove the sinus floor, it's very, very easy because we have a very thin part. And then we remove the spacer you saw in the beginning here, we remove it to place the implant in the position decided during the planning. So this is the case at the end. The last, very, very last thing, and I'm so sorry, Tamer, for to disturb your plan, your perfect plan. You were on time, and I came and killed everything. They clean, talking about the clean implant foundation, I was talking about in the beginning. The surface of the implant as received from the manufacturer. How can you imagine that you put the implant by scratching all along the sleeves before, which gives some problems of the implant surface. When you are with an open frame guide, nothing is the implant surface is not destroyed by the guide. So other papers showing the accuracy of this guide comparing to the sleeves guide. This is the last paper we published with the valuable scientists like Francesco Mangano, Maurice Salama, and a big team from Russia. All those things you can find them on internet, or please send me a message and I will be back to you for any kind of question. And I'm so sorry again for this this problem. It's I'm quite
no,
today,
it was so valuable, Jafar. Thank you so much. Thank you so much.
I really
most of the questions we are having, it's about the system or where we can find more information about the system. If you can type the website or in the chat section, if you can write the website for this guided system, the planning program, most of the audience, they need more information.
Do you hear me?
Yes.
What is interesting is that there is a e-learning platform on the site where all those details are explained. So with videos, with everything, it's quite interesting, and they can really have informations and then be oriented to even to you, because in our last discussion we were supposed to do courses with your scientific society for guided surgery. So
yes,
they
will go back very soon.
I will give all the informations to your office, and they can really answer also.
Yes, if we just can write them down on the chat section.
Yeah.
So the website, it's amazing what you are doing, guys. And to be honest, I'm so honored that all of this is coming from Morocco. I'm so glad of this. I'm so honored to have such a respectful scientist and speaker among us today. Thank you, Jafar. This was incredibly great. Thank you so much.
But really, my friend, I'm so sorry for what happened. Really, this is computers. And
it's the digital world, huh?
Yes, just last thing. All the courses also are available on Digital Dentistry Society. I know that we have also discussions with you guys to have a kind of venture for the Digital Dentistry Society. But people who want to go digital, there are many platforms where they can find the right informations, and they just they have to refuse any kind of marketing around something that doesn't work. They really need to read and to go to courses to really understand what happened in the digital field today. And I was pleased, and so sorry to take 1 minute more. So sorry to. I saw that the guy who was comparing digital and analogic for veneers, he was so clear and so honest. We have to watch out. Everything in digital today are growing very fast. There is serious things and less serious ones. We really need to follow the mentors. We really need to go to courses and to have a clear idea before doing anything, before buying devices, before going on procedures. So this is my final words, and I'm sorry for what happens. I had a special lecture just for BAIRD and yourself, my friend, and I'm sorry. So we'll make it another time.
Inshallah. Thank you so much. We are so proud of you. Thank you so much. Hopefully we'll see you again. We'll see you back in Morocco or maybe very soon in the near future in our region. Thank you so much. Have a good evening, Dr. Jafar. Thank you.
Thanks
now, okay. Now I will have. Let's talk about positivity. Let's talk about marketing. We have a special guest here from Cyprus. Antigone, do you hear me?
Yes. Yes.
Perfect.
Can you hear me?
Perfect.
Yes.
Perfect. Yes, I hear you perfectly. So when I say your name, I remember positivity and very nice things you're doing for not only for the dental community, for everyone. So we are sorry we are a little bit late. So if you can share your screen with us, okay?
Of course. Let me. Oh.
How's everything in Cyprus?
In Cyprus, we are all on isolation. Our government is taking excellent measures and we're very proud of them, to be honest. It is very challenging at this time because I have 2 twin boys and we have to run around in the house all the time while we work. But allow me to start because I'm very excited with what we're going to do today. Okay. And I'm going to talk about, if I may start by saying a huge thank you to the British Academy of Implant and Restorative Dentistry, BAIRD, and the ALD, the Academy of Laser and Dentistry, for organizing this amazing ILED Stay Home Congress, because I think actually it must be one of the first that are taking place right now. And I feel so honored to be here. To be honest, it's a little bit challenging for me not to be in front of an audience, because usually I get that feeling, that power from people, and I give back so much more. So I'm hoping with all these great messages I've received in the last hours, and all of the 27,000 viewers I'm listening, I'm hearing, I'm reading from the messages that are viewing this, I hope to get this power from you and give you the best of myself and of my proposals. So, my dear participants, we're going to talk about standing by our clients and our prospective clients. I know it might sound a little bit strange at these times of COVID days. My name is Antigone, and I'm here because I want to talk about this topic. But many of you think, what is this topic all about? And fairly so. I want to show you the way to take the conversation with your client and prospects online as well. Because sometimes we focus on the information. Take my conversations online. What? To lose the personal touch? No. To take them online as well. And also, as a little bit of a bonus that I figured out these days, I want to talk to you a little bit about cash flow, because I am an accountant by nature and a strategist by experience. And I want to talk to you about this crucial matter as well, because it is very important for all of us, for all of us to survive.
Can you please raise the voice a little bit?
Of course.
Yes, little bit.
Like this, is that better?
Yes, thank you. Thank you so much.
Excellent. So I want to talk to you a little bit about how you manage your cash flow as a practice. So we're going to have this, you're going to be thinking like, but why are we having this conversation now? You know, I felt humbled after watching so many amazing people coming in this online congress and sharing all this technical information. But we're having this conversation because, you know, maybe you're thinking like, why shall I talk about staying close to my clients? I'm already close to my clients. They've been my clients for such a long time. They know me. Yes, but we're going to talk about what they need from you, or not what you think you want to give, or what you think you want to, you must give. We're going to take a deep dive into their heads. Why do you need to take action as a dentist? Come on, trouble your head a little bit. I love questions, by the way. I love questions because they force us to give an answer. Why do you need to take an action as a dentist? Why? Because COVID-19 might take a while to go away, and your clients need you because they might not be able to see you, or everybody gonna be able to see you. So it is gonna be 3 to 6 months down the line until people start, you know, feeling comfortable to come to your practice. Then you need to take action now. You need to connect with them. You need to start your conversations now through all the possible means. And why online, you're thinking? Because look at these statistics. I'm taking everything from very reliable sources you can see on the bottom of the page, because internet use is massive around the world. You can see the statistics, they speak for themselves. I'm sure now you're looking at your country. I was kind of looking for Cyprus and there wasn't a percentage on it, but it's a tiny country. But yet again, I could see so many other bigger countries with huge percentages. And trust me, all these percentages mean that they're using social media. Even Isaiah was telling us recently that 66% of social media users, they intend to increase. They feel that just because they're stuck at home, they're going to start using it more. Isn't that amazing? And now we have also statistics in increasing usage of social media for Facebook and YouTube as well. And look at that. People with higher incomes are more likely to use internet. That's a useful statistic for dentists. Why am I in this position to talk to you about these matters? Why? Because I am a sales strategist. I work with doctors. I work with the Ministry of Health. I work with the Ministry of Finance. I work with the tax authorities. I work with so many different companies in order to help them get close to their patients, to their clients. And this is so important because we've tested and tried different things and we know what works and what doesn't. And always at times of, how shall I call it, times of risk, instability, and this unique thing about health, people need you to be closer than ever before. So these are our numbers. We have all this experience that we carry within our consultations. We've been around so many people and discussing and sharing views and been part of so many events. These are some of our clients. I'm just giving you an overview of the ministries, the police, and we've been discussing it and helping them to get into conversations with their own clients. But I don't want to make you tired with this. I just want to say that these are important days. These are important days because the ways you decide to manage yourself, the ways you decide to address your existing clients, and the ways you decide to touch your prospective clients are going to define you as a doctor, as a human, and as a businessman and a businesswoman. Because in the end of the day, yes, you are a doctor, you are serving all these people, and sometimes you lose control, right? You don't even know who your clients are in the end of the day. But in the end of the day, you're all of the three. You have to make this work. So today is an important day because we're going to talk about the actions you must take now. If you don't take them, some other dentist will, and they'll gain in the long run. And you can make all the difference. So some get worried, oh my gosh, it's going to talk about marketing, about relationships with clients. No, I'm not going to talk about, I'm not a psychologist. I'm not a marketeer. I'm a strategist. So I want to share with you those simple, systematic steps that you have to take to make the whole difference, to be different. So we're here to talk about what's going on in the heads of your patients, and I want you to capitalize on that for the future. Some of you will be tempted to sit back on defense and say, you know what, this is the time that I self-train. I'm going to watch all these amazing people teaching me technical stuff. I don't want to do anything else, you know? The clients, I'm going to talk to them when they call me. I'm going to call the ones I have to call, but don't want to do this. But think about it. Everybody's discussing that after COVID-19, nothing will be the same. Things will go digital. The things you do after this seminar, after this keynote, they're going to define how prepared you are to take your relationships digital. So if you teach yourself now, this is another technical seminar on how you have to upskill yourself to learn to communicate information in the new scheme of things. I know it sounds a bit scary that we have to communicate digitally at some point. You're not going to be carrying out, your treatments digitally, but don't fall in the trap to lie back. Take action. Take action relevant to what's happening now. Okay, and let's boost your client base. So I want to share with you this. So we're going to talk about 2 things you must communicate to your team right now. 2 things you must communicate to your clients right now. So these are the things I'm going to talk about strategically. 1 relationship spoiling mistake you need to stop doing right now. I'm going to talk about customer experience in servicing emergency situations. So how to make people feel wow after you've been servicing them in emergency situations. I'm going to talk to you about marketing you should stop doing right now if you're doing it. Marketing you should start doing right away. And how all of the above attracts prospective clients. So all of these actions, they don't have as receivers only your existing clientele. They will have people, there will be people out there who are researching and they're looking for somebody they can trust, the dentist they will trust for the future. So you're going to be touching them too. I'm going to be giving you wording and a step-by-step approach, and I'm going to also answer all of your questions. And then I'm going to talk a little bit about cash flow, and we're done. What do you say? Shall I go for it? Let's hit it. I'm talking to myself here, but I feel the vibe. I can think of some faces.
No, we
right
hear
now.
you. We hear you.
So we have to be prepared for chaos at some point, because clients have been, halfway through treatments. Clients have been going halfway through cosmetic treatments, and some of them have been going through severe issues. So expect a lot of questions, persistent worries. Some are going to be devastated, right? Some of you are even, you've already faced those. So please put them in the comments and type in your comments and tell us. Some will even get angry with you. They're going to say, I told you to start this earlier, and now we got caught by this. Some of them, they will blame you. Some, they will just feel overwhelmed. Some of them, they will repeat the same questions over and over again, and you're going to be thinking, what's going on? And some, they're going to feel worried about complications, and they will have every right to. Some of them will disappear, not because they don't want to pay you, but they will be going through a drama of their own. They might be jobless. Some of their family might be sick. And some, they're going to push for visitations. Can you think about that? They're not going to realize the risk. If people realize the risk, it wouldn't be spread everywhere. So people are going to be pushing you for visitations. Be careful. So I want to tell you first, before we focus on clients, I want you to focus on your own house. My dear Ron Padgett, the American poet, said, straighten up your room first before you save the world. So, and then save the world. So the 2 things you must communicate to your team right now are the following. You have to address information about themselves. And I'm going to give you a sample email that you have to send to everyone. And if they don't have email, you can say it on the phone to them. So information about themselves, 2 things. You have to address their fear in case they are afraid. I don't blame them. And you should address their job insecurity. The second thing, you have to help them how to deal with patients and prospects. Because right now in their head, everything is chaotic. In their eyes, you are the leader. You're the person with all the answers. Does it sound strange? I guess not. Because you're a doctor, you know that people look up to you. And if you work in a small operation, maybe you're a solopreneur working alone, then these are discussions you need to have with yourself. So how to deal with patients and prospects, they must be prepared for certain behaviors, what they must say exactly in order to be one voice, and how to deal with emergencies. Let me give you an example. So I'm going to make all of these resources available. Also, this video is going to be available by the organizations, but I'm going to put a special report on my website. Anyone who wants to get it, I'm going to have it available in the next 2-3 days. But let's hit it. So you prepare an email and you say, "Dear Catherine, Mark, Peter, Hassan, as the events around us continue, it is important to have a video chat." Boom. You don't want to talk to them on the phone alone separately. You want a video chat with everybody. And we need to coordinate our next steps. So understand that your whole world is shaking right now. So you need to be empathetic. But we must stay united as a team and walk out of this situation steadily, safely, while giving our best advice and support and care for ourselves first and then our patients. And when you have the video, I have in the parentheses that you can talk to them that this is a meeting because as described when we get on the plane, when we used to get on the plane, we have to put our masks on first. So this is a video meeting because we need to put our masks on first. So I would like you to have a special video. Please download, date and time. But what I want to stress on this email are the 6 points. So here's what we're going to discuss. 1, how you feel about the whole situation. So you want to hear about their feelings. How our work is affected in these days and actions we're going to take. And as soon as they read this, they start panicking because they're worried about their job. And then boom, you put number 3 and you say, how is our employment status affected and steps we will take to protect it? If you use the word protect, then instantly they will know that you're trying to save their jobs. Here is a stage that you have to speak to your accountant to get some information regarding any schemes that the government has and any special funds available for keeping and maintaining your practice and your staff in. So prepare before you go in about those. Number 4, which cases to consider as emergency, which is really important. Not everybody knows what emergency means. Even though they're experienced, they will need to hear it from you. And then present them the care protocol. We're going to see some customer experience protocols, and then you can enhance it with the more medical stuff. And then number 6, what other work we can produce at home in order to support the practice. What am I talking about here? I'm talking about all the things we're going to see in this keynote. You can take them and give them to your administration staff to work from home. So you don't have to do them yourself. If you have a team working together, you can split them amongst yourselves. That's amazing. So have I lifted some of the stress during some unknown areas yet? Yes. Okay, I'm just guessing. So I'm moving on. So on the video call, let them see that you're confident, that you're positive, that you care, and that you're prepared with your documents. Sorry, I moved too fast. Okay? You have to be that person that nothing has touched them. And then you have to tell them that it's natural to be afraid. Come on, let's face it. Fear is when we don't know. So explain to them. You feel afraid because you don't know. Now you know how we're going to do this, how we're going to deal it. We have a plan in place as a team. So you don't have any reason to be afraid apart from the whole virus thing and your family and everything. But I'm going to take all the steps to protect you. You're going to tell them that how to deal with panicking, angry, or stressed patients. You're going to give them the words for it. And then you're going to explain to them how to deal with collection problems, collecting the money that people owe you. We're going to discuss this very soon. And now that we've taken care of our home, it's time to discuss about two things you must communicate with your clients right now. It was mind-blowing these days because I was furiously on all the social media with my team, which is another 2 people, looking for posts from dentists, letting their people know what's going on with the practice. I was so disappointed. But again, I found a few that were amazing. So who do you want to be? Do you want to be that amazing person that lets people know? Or do you want to be that amazing practice that doesn't let people know, so they don't really know where they stand with you? You're still amazing, but you haven't taken your conversation online. So now that everybody's at home and everybody has spare time, don't believe the news. Not everybody reads the news every day. They don't want to hear about COVID-19 anymore. People want to think about positive stuff. They want to think about the checklist, you know, what they want to do in the future. And they're thinking, you know, I would like to have that lovely smile that my neighbor has. You know, let me research about dentists. And boom. That's the things you must communicate to your clients right now, to be present, to be there, to be foundable. So the first thing you need to communicate is how you're delivering support right now. This means you're reliable. So you have to make sure they know you're still available for emergency cases. And then you have to define emergency. You have to define emergency in words that patients and prospects can understand. Why do I talk about prospects? Because you're going to see in the next samples that I'm going to show you how many people share your posts online. And those shared posts are viewed by prospects whose dentist forgot to let them know what's going on with their appointment and if they're going to be still open or how they're going to be supported. So you're going to be the person that they're going to be having in their head as soon as this is all over, as a responsible, responsive, has a plan, very serious, there. You might be all this anyway, but if you don't put it online, they don't know it. It's like it doesn't exist. Isn't it horrible? I know. Some of you may be thinking, you know what? I have an established business. Leave me alone, Mrs. Just leave me alone, Antigone. I have my established business. People believe in me. I'm the 3rd generation of dentists. I'm the 2nd generation of dentists. People know me. I know, and you're lucky enough, and I'm so happy. But there are some other people who are starting now, or they're in the middle or at the peak, and they want to take that extra effort to do that. So make sure make them know you're available and define emergency. Communicate how you're handling visits. Don't go into detail. Just say that you have, you know, set up a plan to keep them safe and keep your staff safe and the room sanitized. And you have to ask for patience. So if you are the dentist with a big portfolio, have great emergency demand volume, then you have to post online and send an email that be patient with us. You're running around like headless chicken trying to service you because we love you and we care about you. But let them know. If you don't say it, people will not think about it. That's how it goes. And then an extra thing is that give an individual call to people at high-risk cases. Why am I saying that? Because you saw before I said that some people are going to disappear. But some of these people might be faced with something risky. They might have been through an operation with you recently, or they're going through a therapy, which raises some post-treatment risks. You have to touch base with all of this. Let's see some examples, because I promised some examples. This was the one I didn't like. I'm sorry. So says, following the recommendation of blah, 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 we decide we'll remain closed until further notice. So official. You're a doctor, you touch their hearts. And the decision has been made because it is important to comply. So they talk about compliance, and they say, for very urgent cases, you can contact the doctor. Come on, give me the two mistakes. Urgent? Urgent, it's not emergency. Urgent, it's, how do you call it? It's a very subjective feeling. Yes, it's urgent. Of course, it's urgent. I'm getting married in August. You must give me you must give me an urgent meeting because I need to look amazing. My teeth need to be totally whitened. Yes, but this is not urgent. No, it's urgent. So you have to use the word emergency. And then the second mistake is you can contact the doctor at. It's in third person. No, you can contact us. You're the family. You can contact us anytime at. Thank you for your understanding. Let's have a look at a better one. This one had 213 likes with similar crowd following their page and 46 shares, and let's check it out. Our valued clients. We take your health very serious and safety seriously as we take our own. And then it says, blah, 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 we have to close down. And then it says, we know how this may make you feel, especially if we are in the middle of the process. Do not worry, in capital letters. We shall be giving you a call in the next days to guide you about the next steps. That's nice, right? I like it. We are here to help emergencies. You announce it, and then you put down the list of emergencies, the list of things that you'll be looking at, and you say, painful swelling. It swelled, but I'm not feeling pain. So you're checking it out. And then look at that, 213 likes. That means that these people are going to keep receiving it, receiving information from you. Sorry, this thing keeps coming out. So these 213 people are going to keep receiving and keep seeing information you post online. So this is great. In some situations, I've seen practices, dental practices with thousands of likes. This is even better. And let me show you the magical number. Look at that one. 46 shares. What does that mean? For those of you who use Facebook, it means that. So those people who are probably your clients and they have shared it, Facebook says that an average user has at least around 500 friends. Some of you have thousands, I know, but an average, because I don't want to exaggerate. So 46 shares times 500 friends that each of the 46 may have, if it's more, you reach out to 23,000 prospects that are going to see that you care, you inform, and you are present, and you're foundable. So let me drink some water. What do you think about that? So when you were considering and you were wondering, why did you put staying close or caring for our prospective clients? This is it. Because maybe somebody who hasn't been receiving any news or is faced with a situation and doesn't have a regular doctor, they will come to you knocking on your door. And guess what? They're going to become your client for life. This is another nice one. I'm not going to go through it because I want to save time and move on to more to the further topics. It's a beautiful message by a doctor that actually expressed how serious he was about deciding to close it and that he's done extensive research. He's attached a YouTube video that everyone should see. And he has also put inside the comments area. I couldn't put that one as well because there was too much usage of names and I wanted to protect their confidentiality, their personal data. So he explained with wholeheartedly why he decided to do it, and that was very touching, and people loved it. So those were some examples. And you must be thinking, how do I communicate? You communicate with whichever medium you have. It can be an email, which I really like because it makes things more official with your clients. An SMS. An SMS should be a little bit shorter. Facebook, LinkedIn, Twitter, Instagram, and bulk SMS, and call. I would say the first three are the most important, and the last one is the most important for your clients who are at risk. Okay? And then the second thing you should be doing with your client is this: how you dentists are going to keep supporting them throughout this. Because if you do this only once and you let them know you're there and then you disappear, it doesn't go a long way in reaching out to them and making them feel safe in the long run. Remember, things are shifting, the economies are changing, the communication of people and social distancing, it's here to stay for a while, and we have to adopt in new methodologies. So how are you going to help them? So you have to make frequent updates on your status on the channels. You have to give them guidance continuously, calls, posts, emails. You have to prepare Q&A, like common things that people ask you, and just create a video and post it. Okay, it's so easy. You know, the first time I posted a video, I remember I just picked up my phone, stood right there in front of it, and I said, look, I've seen people making these mistakes online, and I just want to say this: 1, 2, 3, 4, thank you. Do this instead. 1, 2, 3, 4, thank you. And the reason for doing them is because of this and this and these results we get from other clients. And I put it down, and boom, I posted it. I suggest you do the same. Just go for it once if you haven't done it too often. I know many dentists, they do it quite often and they're comfortable with it. And many people ask me, how do I know what topics I tackle in my posts? You have that question? If you have it, I hear it all the time, and this is the answer. You have to use your clients as a source, their questions, their concerns, their anger, and your experience. So whatever one person or two person ask you, turn it into a video, turn it into a post, into an email, send it off. These are excellent resources. You know what they don't tell us? All those influencers on social media, do you know how they find their topics? They find their topics from their followers, because followers put under their posts different questions every time, things they want to hear about. And they give them food for thought, and they give them the content titles for the future. Let me give you some examples though, because I want to give you. So let's say a client tells you, I would like to meet you at least online. I want to hear your opinion about a few things. Come on, go and make an online consultation. You have Zoom. Zoom is very easy, but you also have WhatsApp video. You have Messenger video from Facebook. You have Viber. You can name anything else. I mean, I'm using those for now because they're so easy. You can use those. Just set up a consultation online. Just make sure they have a camera, they have enough light, and they show you what the problem is. And remember, you do that once, then you know how it's done. You know the process, and you're ready for the future. Those of you who will sit back in defense, they will not be prepared, and they will be running around when everybody else is doing it. So, also another example, address their fears. Make a video post talking about specific treatments or things they can do at home. I'm going to show you in the marketing section some things. Or somebody's afraid that he's going through an emergency, whereas he's not. Post a video. Show some photos of what the emergency looks like in a photo and what a similar thing looks like, which is not an emergency. So use your creativity. It's not rocket science. You already do that online, many of you. And you know what else? Gather up all those questions you received in 1 week and create a Q&A session live on Facebook or LinkedIn. Or if you have a YouTube channel, post it on there. Send it in an email. Or make it live so that people can participate. People love that kind of stuff. So some examples I wanted to share with you, again, on protecting the identity of people, is this doctor that, first of all, he put this video on and he explains to them, because he cares for his client, how they can sanitize, if I may say, their mouth if they feel that they have been exposed to too many people in that day, how they can use like a special resolution to a solution, a special solution to gargle and cleanse their mouth. And he explains it, he shows the solution, and he tells them that he loves them and he cares. Then the second one, which is this one, he shows them how he carries out free online consultations. If they get out of hand the online consultations, just say that it's first come, first served, is from this hour to this hour, book me, for that particular date. But look, he's done it, he's put it online, so people, guess what? People say, oh, he's doing it, I want to meet him. It's very nice, the video shows he cares. I have this concern, let me book a free consultation. So it's as simple as that. You would do it. I mean, look at all these people who joined this Congress now. Why have they joined? Because they care to improve their technical skills. It was there, it's available. The advertisements were everywhere. People were talking about this, and also it was for free. It's amazing. So all for that. If you need more help to structure this, we can help you with a lot of material and a lot of free advice. Until the end of April, we're providing everybody with free online consultations. So use us if you want. And this dental clinic here, I really like this one. They show a video of their patient who's visiting and how they help him to sanitize, to protect himself. And also you can see the lady who's servicing him, she's really nice. She has taken all of the precautions. She's even wearing a mask. So this is an amazing message to send out to people, that you're taking all the necessary measures. Before you do anything, you must prepare. Okay? So the first thing you need to do is prepare a list of your clients. You must know what your clients are. I was these days on a webinar with some accountants from the USA who are dental accountants, and we're discussing some issues, and they have some posts online, and they were saying how dentists really lose control of who their clients are. So they focus on the ones who are repeaters, so this is your opportunity. I mean, it's natural to happen. So if you prepare this list of clients, you're going to remember all the people that walk through your doorstep, but you never had the time to build a relationship. This approach gives you the opportunity to build that relationship. They're going to be so happy to hear from you again. So prepare the list, put their phone numbers and their emails. Some of you have CRM. CRM is a customer relationship management system where it takes all these things out automatically. If you don't have one, don't worry. Just prepare an Excel sheet, put them up. It's only once, and you will have your list there to be able to act. And then prepare a small list of the posts you want to make. Prepare only 4 to begin with. Okay, we can help you again with this. Please use my ask for apply for a discussion with me through my website. I'll be very happy to help you out and set out your plan anytime you want. And then you must take 3 steps. First of all, you have to create a Facebook page, Instagram or LinkedIn. So what I'm telling you here, take the conversation online. Use the medium that you want. I know you're worried now. How am I going to handle all of this? I'm going to give you a tip towards the end that's going to resolve all the worries you may have. So create the medium, the way you're going to communicate, invite all the clients you have prepared in your list, and then start posting. Come on, it's so simple. Just do it once, and then the second time, it's like a bicycle. You never forget how to ride it. Oh, yes. Now that we've discussed on how to stay in touch with your clients, I want to tell you how you can spoil the relationship. So if you want to do all that and then destroy it, I have a recipe for it. So if you feel self-destructed, I have a solution for you. So there's one relationship spoiling mistake you need to stop doing right now. And I'm going to guide you through it. Sorry. You see the world on global lockdown, and you predict that your clients are going to be reachable. They're not going to be reachable for much longer. Am I right? You're thinking about that. What do you start worrying about? Come on, put it in the comments. I'm going to go in later to see. What do you worry about? Boom. Collecting what clients owe you. I guess when some clients, they go into more pricey treatments, maybe you give them a payment plan. Usually that's what everybody does. So collecting what your clients owe you, and then you fall in the trap. Don't fall in the trap. You become obsessed or pushy on collections. You know, you give them a call, and in the end of the call, you know, you say, it would be nice if you could just settle that. It's not a big amount, please. And then all of a sudden, you spoiled it because the client was feeling great that you gave them a call, and because you ended the call with that, you made them feel that you called them for the money and that you care until you get the money. And that spoils the relationship. You would feel exactly the same now if I called you and I said, oh, I read your comments on my keynotes during the Congress, and I think you're doing an amazing job, and I would love to help you. And you say, yeah, let's book an appointment. I was like, yeah, great, let's book an appointment. And then at the end of my appointment, I say, by the way, I have this amazing online course. I would love you to buy it. And you go like, oh no, she did all this to push me to feel grateful to buy her online course. I don't have one, by the way, yet. You know what I mean? You would feel horrible. So going hard on collection is a huge mistake right now. And now you're going to say, what are you suggesting, Mrs. Rocket? That's my nickname. That I don't pursue my fees? I have worked for them. I have paid my vendors, my suppliers, my staff. What are you saying? Come on, it's okay. I agree with you. I agree with you 100%. And you're absolutely right to feel that way. But we're not talking about not asking for them. We're talking about how to ask. That's exactly what I'm talking about. How and when. So it's the wrapping paper around your words. And some of you may think, why do I need a wrapping paper for what is legally mine? Am I shouting, Mr. Tamer? Sorry. But think about it. Because you're in a cure and care business, it is essential to say things with empathy. Even if you're upset, even if you're worried yourself, you're dying to get some money in your hands because you have your bills running, I understand, but you have to put the wrapping paper. So these are the steps. And listen to them carefully because each one has a little twist. So the first one is you have to make a list of the outstanding fees per client. If you have a CRM, again, this produces it by itself. If you have another system, why do you do that? Because you're going to decide who you're going after. You're going to decide who you're going to pester with the next steps. Because you know your clients, you know, when you sit on that relaxing chair back there, you know, you tell your dentist many things. I tell my dentist about my kids, about the things I want to do to my teeth. And he listens to me patiently. So you know your clients. You know who is the person who's probably not going through crisis and they have a steady income from somewhere, or they're rich, or they're well off, or they're capable generally, and you can go after your payments. Then you send a clever message via email or SMS. But you don't do this, and I'm going to show you a sample now in the next slide. You don't send the email. You don't put your name on the email. Your admin stuff does it. If you're working by yourself, you have to put your name. But if you have admin staff, the admin staff's name goes on it. You have to distance yourself from the money asking thing, but still you have to ask for it. And then you follow up with a call. So it's first the written one, second is the call, and let's see our example. Dear Antigone, you owe me money, bring it tomorrow or I kill you. No, I have expenses running, Antigone, the bill is running, come on, come by the office and pay me. No. Dear Antigone, I realize your whole world is shaking right now and you have a lot on your plate and a lot of stress, and the last thing you need is someone like me calling in to try to collect outstanding fees. So I just wanted to let you know that the last payment didn't come through yet. If you get a chance, call me back to help you if you need any different arrangements. It has to all be packed up because it builds up the emotional, the emotional stress. And it acknowledges the fact that the person is going through something. And then you call. If they don't respond, then you go with a bigger version where in the middle, you explain that we have been there here. We have been there by your side every step of the way to treat and support you throughout your treatment. We feel very grateful because the reason of our success is your loyalty and appreciation towards all our ample supports. Yeah, I just wanted you to know though, so you explain here that you support other people as well that need to be there to care for you when you need them. And then you say that you're going to call them and that you have a great plan in place. And then you call. Okay? And you use similar words to the email, but you don't make your call yourself. Your admin staff does. If you're a solopreneur, sorry, you have to do it. Managing your cash flow, woohoo, money matters. How many of you feel a bit scared to touch that topic? Oh my God, money, debit, credit, thinking, okay, I'm going to make it really simple for you. I'm going to show you a very simple way that you can manage your cash flow, which is perfectly, an 8-year-old can do it. How does that sound? So, how to plan for the next 3 to 6 months, because we're talking about the depth 3 to 6 months to 9 months. So I want to talk about the first 3 to 6 months because now we're in the 3-month period. I want you, the first thing is to talk to the clients to create monthly payment plans. Be flexible with them, okay? So you keep the money coming in, but first you email them, then you talk to them on the phone. So you keep the money coming in. A little bit from everybody is better than nothing, and it might pile up to a lot in the end of the day, enough to keep you going. Step number 2, you talk to your suppliers and suggest a smaller payment in installments. You have to do it reverse order here. You have to call them up first and say, hey, Ahmed, how's it going, man? Yeah, you see what's happening. You listen to them. You say, I'm calling you because, we're at a business now, and I was wondering if it's okay with you to allow me to pay our outstanding balance in installments and the future things you're going to be bringing us to support emergencies, because I need to pay the stuff. I need to keep this thing going. What do you say? I just called to hear what's your take. If they say yes, you send an email. If there's no need to send an email and they understand, it's okay, but it's good to have something in writing. So, and the last one, talk to your bank. This is for the ones that have arrangements, let's say loans, overdraft, any other kind of financial arrangements with the bank. And you can suggest smaller installments and no compound interest. I know it may sound a little bit weird. It's when the bank put interest on the previous interest they have already put on your balance. Some governments have already, this one, Some governments have already done something about it and they have waived it, but it's good to mention it. So that's why I said that this is very basic. Step number one, you talk to clients and you start bringing in the money. Yeah, you ask your staff to help you on this. Just put a system down. I can help you to build a system for that. And then you talk to your suppliers for less. You talk to your bank for less. So you ask for the clients to come in and the others to become slower and lesser amounts to come out of your account. Is that difficult? No, right? That's cash flow. So I want you to keep the cash inflow from your clients coming in, limit the cash outflow, and maintain a healthier financial position. And then customer experience, because I see that I'm close to my time and I don't want to take too much of it. I just want to say that customer experience in servicing emergency situations comes in 3 touch points. It's before, during, and after. That's how you create trust between your customer and yourself in situations like this. So I'm not going to go through it. Just follow these steps in order to make the client feel very safe, and also your team to feel very safe and to know exactly what they have to do before they have. From the part that they have to come alone, that they have to take a shower, that they have to bring the fees with them, until they enter the practice. Then the during part is that it's all about the way you are during the meeting, the way you protect yourself from the senses of looking and what they hear from you. Okay, so you have to call them by their name, you have to smile, you have to be positive. And one thing that the best doctors I've ever met do is that before the client leaves, they explain that in 1 day you should be expecting her to have this pain, in 2 days it should get better, in 3-4 days it should be fine. If it doesn't, that's when you need to call me. I know to some of you this sounds so basic. Well, I really appreciate you if you are doing it all the time, and I respect you for doing it. I'm so excited that you do it, but not everybody does it. And actually not very many do it. And you have to watch that. And the after thing, it's the after ritual. You have to explain exactly to the client what they have to do after they leave the appointment. These are the steps. I can give them to you afterwards if you like. So what marketing, and this is going to be very fast from now on, and we're finishing up in 3-4 minutes. So what marketing you should stop doing right now? This is very short, by the way, because it's just one thing that we're not, by no means are allowed to do. What do you think is it? What do you think? Oh, I miss my audience. So this is it. Recently, an airline, I'm just going to share a sample that somebody else done it wrong. I'm not going to show dental practices because there are many who have done it, and I was very upset to see so many wrong marketing going on right now, but I didn't want to expose it, so I'm using an airline. So recently an airline was emailing me and was advertising all over the social media that they have 50% in all the air travel until 2021. And the way they're doing it in order to look ethical is that it's because they also allow people to go back to their countries. They also allow people to plan for their holidays, to relax from this chaos. But is this ethical? Think about it. Is it ethical to encourage people to travel? So is it ethical now to encourage people to spend money on less necessary aspects of their dental care? No. You're gonna do this, and I fully support you on this, but not now. You're gonna see a line in the coming slides, but they're gonna talk about when is the right time to do this. I'm going to tell you because you're thinking now, why should I wait? So you have to do it closer to the time when this is going to be over, and you're going to know. So what marketing you should start doing right now? Marketing. Feel uncomfortable with it, right? Okay. What conversations you should start doing right now? Okay. You have to take your conversations online. What should they be? It's easy. You have to be a source of support. and a source of information. So you have to put positive stuff and also stuff that people are asking for. So you have to be a support and a resource. Okay, let's see an example. So I like this one very much from our doctor here. He said, let's meet up. We're offering free virtual consults. I love it. You know, and it had many shares, it just couldn't fit in the screen. You know why I love it? Because you're touching both your clients and your prospective clients. Because if I get this, and I'm thinking that my child, because my child indeed needs at some point this procedure, I'm sitting at home most of the time. I finish work early because I'm always at home. I don't have so many requirements. And I'm thinking, okay, let me research to find that doctor that's going to treat my son and have a free consultation. It's free. Let's just tick it off the list and, you know, get our brains off COVID-19. So this is a great advertisement. I'm finishing, Mr. Tamer, I can see you. So another one is guidelines for home care. This is for orthodontics, but you can put any kind of guidelines for people to take care of themselves. Especially there is a question coming through very often, and there is great guidance from around the world. Also, there is a very creative way you can put up what is an emergency. Okay, and then look at that one. It's an example of how to cheer them up. So this guy put up a gift. He said, guess how many solar panels we have, and we'll give you a $200 voucher. Or you can make supplies available at the bottom of your practice, which is amazing. Another one of our clients here in Cyprus, what he did, he sent through an email that he has connections with pharmacies that deliver, and he actually did that for his clients, and it worked so well. And he was getting, I'm gonna say, he was getting a commission from the pharmacists for making this happen. So for cosmetic dentists, if you're very worried, I'm gonna go very fast through this. Don't worry. I know you're worried that you know that people are gonna put this lower down on their list. Don't worry. The only thing you have to do is that stay present with your conversation with your existing clients. Okay, and then next will go by itself. So stop worrying, start acting, and start explaining to people that cosmetic dentistry tackles many dental problems. It's not only about beauty. Okay, this is something I've learned all these years. So keep it simple, stay close, connect, give your tips, offer free consultation, and create offers. The following will come automatically. Focus on creating value. And there is one trick I told you already. One post you have to make and you put it everywhere. So if you're worried how you're going to maintain your brain going, what I'm going to put in Facebook, what am I going to put on Insta? Just one and the same post, and you put it everywhere. Okay. And then remember that people don't like to be sold. You address their fear with advice. You make generous offers, and you offer clever payment plans. Okay. This is all of the sum up of this keynote. I hope you have enjoyed it. I'm 56 minutes down the line. Am I good, Mr. Tamer? Yeah?
Yes, we are 5 minutes behind. It's fine. But
Okay.
I will ask you one question, if you can,
Yeah.
because we are limited in time. We are waiting for the last lecture.
Yes.
If you can go through the question and answer section, you can see it down.
Okay.
The question and answer button.
Yes. Which of the questions? Mm-hmm.
Yeah, we got so many questions. If you can follow with these questions while I introduce our last lectures. So I will give you a final word on this.
Which one do you want me to answer?
I want you to answer them privately because there are so many.
Privately. Okay. Allow me to go through that. And I just want to say to everyone on closing that every crisis is an opportunity in disguise for all of you. Okay. And if you prepare now, I don't know if it's disabled, but I want to say that work with your team, work with your patients, suppliers, and banks on your cash flow, you know, and all of these will work out for you. If you don't act, some other dentist will. Trust me. So if you need any help, please give us a shout. We have this, you know, this outline on our website on the Get in Touch, Contact Us section, and you can. So Mr. Tamer, thank you. I'm gonna go now and answer my Q&A.
Thank you so much. This was so positive, so encouraging. It's very important to have this positivity around. You can write down your contacts, your website to our audience. Many are asking. Please, again, if you can answer those privately, because we are a little bit late. And because thank you so much. Thank you so much.
No problem. Don't worry. I'm jumping on it now.
Yes, I appreciate you being with us. Say hi to all the people in Cyprus. Please stay safe and stay home. Thank you so much. Thank you so much. Thank you so much. So, shall we go to my best friend, Dr. Hassan? We are sorry, Hassan, we are a little bit late. Hopefully not too much. Okay, Hassan, do you hear me?
Yes,
Hassan,
yes, I am. I'm with you.
Okay, always we keep the best to the last. Hassan, we are sorry, we are like 5 minutes late. So you are famous enough. You don't need an introduction.
You're so kind.
So okay, so you can share your screen, and it's all yours now.
There's another participant sharing it. It's not allowing me to share it, Tamer. I think.
Okay, you can go ahead.
Excellent. Right. Good evening, everyone, and greetings to all my friends from all around the world. It's a great honor to be here with you today, and thank you very much. Antigone, it was amazing presentation, and I liked what you wrote at the very end. You know, this is ongoing world needs sophisticated yet simple tools, and I think it's really good. I've took a lot of good notes from your lecture, how to work on the business. I think most dentists, including myself, we tend to focus in the business, how to become a good clinician, how to become a good surgeon, a good restorative dentist, but we sometimes ignore how to work on the business, how to make the business successful. And your presentation was amazing. Tamer, do you see the full presentation? I guess so.
Yes, Hassan, yes.
Perfect. So I would like to start by thanking everyone. It's amazing. This was a dream a couple of weeks ago or 10 days ago when the crisis started. And look at you, Tamer, and the team you've managed to put together from BAIRD Academy and ALD, my good friend Waleed, yourself and myself, and Ms. Solange. We put this Congress together. And today at 30 Point, I saw more than 30,000 dentists tuning and joining this Congress. This is amazing. Success wouldn't have happened without the great efforts put by our speakers. I'm so proud that I've got 34 BAIRD speakers. Every single person of them is part of the big family. And obviously, we had so many other people wanted to be part of this Congress, but priority was given to our speakers, our British Academy and ALD speakers. Obviously, today was an amazing program, honestly. I was glued to the screen. I could not leave. Every single lecture had amazing tips and hints. And thank you very much. But I can't wait for tomorrow. Because tomorrow we're starting early. We're starting 8 o'clock GMT, which is 9 o'clock UK time, 10 o'clock Jordan time. And we're going to have amazing group of speakers from Italy, from Algeria, from Saudi Arabia, Palestine, UK, France. It's going to be a good mix between implants, laser, endo, surgery. So stay tuned. Come and join us tomorrow and help me to break the record. Tamer's record is 30,000. So I hope tomorrow we can break Tamer's record. I will be the moderator with you tomorrow. And obviously, Tamer, well done. You've done a great job today moderating this Congress. It seemed like you were a DJ, you know, talking to speakers, asking them about how they're doing.